that. Good morning to all of you and welcome again. This is the last day of the conference. And today we are going to discuss very important issue in this session about overweight and obesity as well as undernutrition. And we are starting with the first session with the topic of overweight and obesity in India and the issues which are related to public health, nutrition and policy. So I invite Dr. Shweta Khandwal. She is a PhD, MSc, and Master in Public Health. And right now she is working as a Vice President in IPE Global. So she has a lot of experience of handling the nutritional issue in the country. So I welcome you, ma'am, and we look forward for your session. Please.
Slides. Okay, perfect. Good morning, everyone. I know the room is like still about to get filled, and I'm sure a lot of energy will come in the subsequent part of the day. But because we want to keep to time, we want to make sure that we start on time. And so today, when we are talking about obesity, it's also something which is, which took its own time to sort of manifest here in India, not only in terms of visibility, but also in terms of policy action. हम आज कोशिश करेंगे कि इन द नेक्स्ट 10-15 मिनट्स एक लैंडस्केप समझें कि कहाँ से हमने ये जर्नी शुरू किया ओबेसिटी का रिकग्निशन का, क्योंकि मैं न्यूट्रिशन में लास्ट ऑलमोस्ट 21 इयर्स से काम कर रहे हैं और उसमें मोस्ट ऑफ द टाइम जो पॉलिसी मेकर्स का फोकस रहता है वाज अंडरवेट, अंडर न्यूट्रिशन, स्टंटिंग, व्हिच इज आल्सो अ बिग प्रॉब्लम स्टिल. बट अभी लास्ट डेकेड से देयर हैज बीन एटलीस्ट a bump in at least attention towards obesity, and that's what we will discuss today, in some brief manner. The first thing I wanted to start with is, now we at least have a definition of obesity. Clinical obesity and preclinical obesity are now defined. This is a recent publication in Lancet, which actually explains that people who are obese, who may not have metabolic aberrations, are called preclinical obese, but people who are having end organ damage or some kind of abnormalities, they are called clinically obese. Okay, so there's a difference. And why it's important that we are talking about these two forms, because India में आप देखेंगे बहुत लोगों का हाथ पैर बॉडी पतला है, but पेट mostly abdominal वाला area is fat. So a lot of us have protruding bellies, not only in men but also in women, a little bit of. So ye pura jo and we are the most populous country in the world, as you know. So we are contributing to a large part of this disease burden. And in that spirit, it was important to see that BMI per se may not be the most accurate marker of defining obesity. And ये waist circumference को introduce करना, waist to hip ratio, ये हम research में बहुत time से कर रहे हैं. Last 20 years से हम ये work चल रहा है. But clinical acceptance, matlab publication wise in Lancet, that if this is published, it gives a little more impetus to all the people who are working in this field to recognize this more severely and understandably. So I hope you're able to understand the difference of why preclinical versus clinical. Both are forms of obese, like appear dono mote honge, lekin preclinical is not unhealthy. Okay, that's what we are trying to say. There's also been, because I'm going to talk about research, policy, action, all the three domains in the next 10 minutes, it was important for me to also tell you that pathophysiology pe obesity ke bhi kafi kaam hua hai. At least in the research community, we've been able to see not only mice models, but human models now to show there are variety of ways by which obesity manifests and how changes in the body sort of come. I don't know what's happening here. Anyway, and today, because I'm using the public health lens to discuss the obesity topic with you, it's important that a lot of our focus is happening in individual bodies per se when we are talking about obesity, right? It's also communities that we get affected, and it's also at a country level that we will have data. But it's also important that please realize that when policy happens, it's not for an individual per se, it's for communities at large, but also to make sure that the country economically progresses. So there is a research community, there's an academia community, and which work in conjunction to make sure that we give evidence-based solutions to policymakers. right? And that's the lens we want to bring here, which is a life course approach. It's not childhood obesity alone or adult obesity alone that we are worried about. It is throughout, right from the time the child is conceived. Maternal malnutrition or maternal different forms of malnutrition actually ensure that the child which is going to be delivered post the entire delivery period is uska life course, uska metabolic pathway kya hoga future ka, that gets determined during that time, and also sometimes before. So आजकल preconception पे भी हम बहुत focus कर रहे हैं, because we want to tell women to enter pregnancy in a good way, in a healthier way, so that the child which is sort of delivered also has a good metabolic profile. And so obesity prevention is an entire life course approach. It's not just a weight problem. It's important to understand that there are metabolic issues also which are involved here. And when we are talking about these multiple forms, India ke bare mein agar hum baat kare to last 15-16 years mein, you will see it's one of the top 5 countries jiski growth in terms of getting children more obese has been rapid. The maximum जैसे वियतनाम का था 10%, India is also not far behind. It's almost 8%, right? And ये दिखता नहीं है. हमें अभी भी इंडिया में सोचते हैं कि thin and stunted and undernourished people है. But please realize that we have already reached a point where there are more obese people in the world than underweight people. So in that light, please remember these numbers as well. And you also know why I'm talking about obese kids, because these obese kids have a higher chance, 5 times higher chances to become adult obese adults. And 40% of our overweight children remain overweight only during adolescence, and about 75 to 80% of these obese adolescents become obese adults. So it's like a thing which gets trickled down and keeps going forward, which is not the best in terms of your health profile. We also know that in terms of the numbers, look at just the inflation. About in 2030, when we want to attain this SDG goals, 50% of us across the globe will be obese. This is really, really very alarming, as well as important for us who are working in the public health community to take note of, because this is the next, next, I think it is already there, epidemic, pandemic, whatever you want to call, because by 2030, 50% of us globally will be obese. Overweight obese. And out of that, if you look at Southeast Asia, our own region in India, that number is also not far behind. It's 34% adults. That's also a huge number given the most populous country that we are. This is a good study for at least the students who are in the room. The ICMR INDIAB study, the Indian Diabetes Study, which was done by V. Mohan's group, along with a lot of collaborators across the whole of the country. And in that study, they measured abdominal obesity, because in India, as you know, like I told you, BMI is not the best marker, but abdominal obesity, matlab waist circumference se measure karke humne nikala. और वो देखा कि that 40% of our women and 12% of our men are abdominally obese. Whenever we are thinking of protruding bellies, we only used to say men. But look at these numbers, which will tell you it's also a lot in women. It may be because of the women don't get themselves measured enough. But in the survey, we found, this is a huge survey, where we found that 30 to 39-year-old women may be 50% obesity tha, abdominal obesity. And 40 to 49 years age group of women had about 56.7% obesity. Again, huge numbers. And if we were measuring by BMI, these same women, only 23% were coming as obese. So therefore, it's important whenever you do your thesis and others, include this as a marker as well. Okay. And some state-wise differences were there, which is all. But there's no green as you see in the map. Okay. It's all yellow, orange, and reds of obesity. Again, because a lot of you are new here, you will also like to know what are the novel and traditional biomarkers for obesity. जो non-invasive थे, जैसे कि मैंने आपको बोला, waist circumference and BMI. But if you're talking about biomarkers, please remember that again, a lot of the research community is coming up with clinical and functional biomarkers, epigenetic biomarkers, multi-component biomarkers, molecular genetic biomarkers, and metabolomic biomarkers. And in this, a lot of you are focusing on gut microbiome, as your work. And in that spirit also, please remember that the microflora also gives a lot of indication on what kind of obesity ensues. So that's also important in mind to keep in mind. There was another survey from the public health community, which was CNNS, Comprehensive National Nutrition Survey. So we have multiple slides and data points from there, but I've just tried to summarize to tell you that this survey between 5 to 19, okay, that's the age group which is usually left. क्योंकि आप जब अगर NFHS का सर्वे देखें, नेशनल फैमिली हेल्थ सर्वे, आपको 5 कवर करते हैं एंड 15 के ऑनवर्ड्स करते हैं फॉर वुमेन, बट बीच का ये जो ग्रुप है एडोलेसेंस वाला और स्कूल गोइंग चिल्ड्रन वाला, ये मिस हो जाता था. तो उसी स्पेसिफिक पॉइंट के लिए हमने 5 to 9 और 10 to 19 ईयर एज ग्रुप के स्कूल चिल्ड्रन एंड एडोलेसेंट्स को देखा. एंड दीज आर इंडियन चिल्ड्रन, ओके, आई एम नॉट कोटिंग वेस्टर्न डेटा, एंड दैट शोड दैट 10% is also huge given the number of children that we have in our country. 10% of our children and adolescents were pre-diabetic, were hypertensive, had high triglycerides, and had high cholesterol and LDL, that is dyslipidemia, okay? And CKD, chronic kidney disease, 5 to 7% of them had that also. So हमारे school के बच्चों में भी we don't even realize we giving them, tiffins which are many times filled with junk foods, which we don't realize in the GARB, but these are actually showing up in the metabolic profiles of these children. On top of it, and I'm sure Preetu will, Rachita will also talk about the physical activity bit later on, but physical activity for our country overall, this is a report card for India, is C. Nobody wants to get B also for our children's, right? And यहाँ पे तो हम C पे हैं, and different components में इसको define किया गया है. Because of paucity of time, I'm moving on, but there's a full report on this, on how they have categorized. However, I've already scared you enough, but I also want to talk to you about what is the positive things in obesity that we have been able to do as a group, right, to make sure that we mitigate this ensuing burden. Now, WHO at least has spoken about healthy diet, and in recent times, I think in the past 2 years, they've also given a sort of a working functional definition of healthy diets, which helps us understand in the nutrition community that we must pay emphasis on fruits, vegetables, legumes, 5 portions of these at least. And these are not just potatoes and tomatoes, but a lot more, right? A lot more variety, diet diversity that they are trying to bring here. Less than 30% of total energy, if we take 2000 kilocalories as the daily intake from fats, less than 10% from fish sugars, and less than 1 teaspoon of 5 grams of salt. And you know already that in India, we consume about 10 to 12 grams of salt. So this is what the healthy diet, according to WHO, is defined as. And there is also enough research to show that different combinations of diets, like low carbohydrate diet, ketogenic diet, plant-based, high protein, intermittent, all of this is coming up rampantly. Ozempics are there, GLP-1 are there. Many people ask about what is the impact of these. Again, those are largely in the individual bucket right now. So because, again, my scope was largely to talk about public health nutrition, using the public health nutrition lens. So I'm not going into detail, but please know that you must, my only, this thing is that research is still happening. We do not know long-term impacts of these things. So, use caution when you're exercising, or just like from today, I'm on keto diet, I'm seeing some ex-celebrity doing it, so I'm also doing intermittent fasting. Don't jump onto that bandwagon just based on what influencers are saying. The research is still happening and the results have still not come. The early results say that a lot of these diets are not very useful for long-term markers. Okay, for short-term, maybe to lose a couple or so, like bariatric surgery and others, have been shown. Some utility has been shown for people who are morbid obese and others, but not for people like you and who do not have any metabolic problems per se. There's also an Eat Lancet diet. Recently, we have been, as a community, we have also been focused on planet's saving, right? We are thinking about making sure that climate change is already influencing us in a bad way. So at least the plant-based diet or the Eat Lancet diet, as per the different countries, has also been specified to reduce the premature deaths per se. 11 million premature deaths can be reduced if we are following this Eat Lancet diet. And again, this has been very nicely explained in the Lancet series of papers. How many grams from different food groups should be taken? It's all specified very well. Now, because I was also telling about public health nutrition policy lens, it's important for me to talk about 2 frameworks, the OPA framework, that is the Obesity Policy Action Framework, where the impact That is, the behavior change is the most important. We all know junk foods nahi khana hai, but somehow it becomes difficult for us to exercise that. And that is what in this model, in this framework has been explained nicely. What are the upstream approaches, the socio-ecological approach, the lifestyle approach, which is the midstream factors, and the health services, the downstream approach, which are helping the clinical interventions per se. And again, being in the public health community, we need to focus on policy actions that influence the underlying determinants of health. They are influencing the food system as well as the physical activity. These three words अपने आप में भी पूरा पूरा इनका एक काम चल रहा है बहुत सारा, but remember that they all have to coalesce somewhere and make sure that they are helping us fight the battle against obesity. Now, whenever public health nutrition interventions are thought for obesity, it's also important to see the education and behavior change interventions in one bucket and policy interventions. They will inform each other for sure. But if you see the research papers or publications or even reports from different agencies, most of them have shown that an enabling environment is very important to get the desired change, right? And when we are talking about emerging areas, in the microbiome, like I explained to you, the air pollution, organic pollutants, epigenetic modifications, all of these works are also informing the all of these things are also informing the obesity bucket. There's also a nourishing framework, which way back in 2014 or this thing, we had worked with Corina Hawkes and Barry Popkin and others. This particular framework also helps to categorize the interventions in three buckets, largely around food environment, food system, and behavior change communication. Which is, the nourishing is also an acronym which tells you about nutrition label standards, healthy food options, economic tools, restricting food advertising, improving nutritional quality, incentives, harnessing the food supply chain, and also informing people through public awareness, advice, counseling, and nutrition education and skills. Okay, this nourishing framework is also very useful for those of you who want to work in the nutrition policy space, for helping understand how obesity interventions can be categorized. In terms of the research summary, there have been few recent systematic reviews, but the most important one which I could find in terms of a meta-analysis tells you that health education and behavior intervention studies resulted in a statistically significant reduction. There were two categories this paper took: less than 6 months and more than 6 months. Okay, and obviously less than 6 months were less significant in making changes in waist circumference, in body weight, and in BMI. But these which were more than 1 year, they showed a significant difference in these two. And most of the other interventions fall in the bucket of school-based interventions. Largely community-based adult interventions are only combinations of behavior and awareness. The policy, if we talk about the policy makers, the FSSAI, for example, in fact, FSSAI, Ministry of Health, WCD, all of them, NCPCR, all of them have introduced sugar and oil boards, along with the collaborative approach with Ministry of Education, to showcase this oil board and sugar board for spreading public awareness. There is an Eat Right initiative also, and there is a front of pack labeling, which is Indian nutrition rating, which gives you stars. Okay, and again, these things are under discussion still, but that's where we are in terms of FSAI's interventions. There's also the Ayushman Arogya Mandir, the PHC units, which were previously envisaged. They are also doing health wellness promotions, awareness campaigns, screening, adult screening after 30 for making sure that you're metabolically healthy, and also Ayush integration, continuity of care, referral linkages, all of that, right? About 18 lakh, I think, are functional. The functional Arogya Mandir are there, and that those are offering these services. No, 1.8 lakh, sorry, my bad. The NAPI, the Nutrition Advocacy in Public Interest Group, which is also headed by Arun Gupta, Professor Arun Gupta, they along with several collaborators, came out recently, just I think a month back, with India's commitment in this field for obesity. They've tried to highlight, make a pledge for making sure, for making sure that we are trying to work towards overweight obesity in a more holistic manner. Last but not the least, there is also a UNICEF report which just came out also a couple weeks before, which talks about 5 major policy actions. 1, restrictions on marketing of unhealthy foods, stronger food standards, front of pack labeling, subsidies, and robust safeguards. So therefore, I want to conclude by saying that it's difficult to see obesity from a singular lens of nutrition, physical activity, and others. It's important that you view this problem from a triple duty lens, which is tackling obesity, NCDs on one, undernutrition on the other, and also taking care of our planet, which is from climate change. So with that, I thank the audience for their patient listening, and over to you.
Thank you, Dr. Shweta, for a very nice and comprehensive overview of obesity. She has raised certain important issues and public as a obesity and overweight as a public health problem. I'm sure your presentation is very useful for all of us, and the policy issues you have given are very important. Thank you so much. Now I invite another eminent speaker, Dr. Ruchita Gupta. She is working as a program officer in WHO office in India, and she has been one of the key person for advocacy of overnutrition as well as undernutrition and all the issues she's taking care of in WHO. And she's going to present a very interesting topic. There are so many companies in India which are which are marketing baby foods and processed food. So her topic is nutrition claims and marketing strategies of these companies for baby foods and processed food in India. So it is going to be a very, very interesting topic. So welcome, Dr. Ruchita. You have 20 minutes, please.
Thank you so much, sir. So good morning, everyone. Hope I'm audible. So today I'm basically going to be presenting a study that we had completed earlier this year, which talks about nutrition profile claims and marketing strategies on baby foods and processed packaged foods in India. So why we basically did this study, WHO works very closely with Ministry of Health and the National Food Regulator, FSSAI, on developing or amending existing regulations governing healthy diets, be it, regulations which restrict marketing of unhealthy foods in schools, or regulations which govern standards for infant foods. And whenever we have these discussions, and the industry is also on the table, the industry argument is that all the fat, sugar, salt, which are the culprits or what we call the dietary risk factors for NCDs, are coming from home foods, because the consumption of processed packaged foods, be it for infants or for adults, is very low in India. So this study was basically done to provide that evidence on the current nutrition profile, the related claims that are there on these products. We had done a study earlier which showed that, while the current level of consumption of processed packaged foods is low, but if we are seeing the decadal trend, it's increasing rapidly. So as Shweta also mentioned, India is suffering from a dual burden of malnutrition. We have undernutrition, but also surge in NCDs, which are pretty much diet related, poor physical activity related. And at the same time, we have seen a surge in consumption of processed packaged foods. So what we see here on this slide is again the high burden of undernutrition, stunting, wasting. But at the same time, what we are seeing is a very high burden of NCDs, diabetes, pre-diabetes, hypertension. We are the diabetes capital of the world. And all of this is happening in the context of limited awareness on dietary implications, food insecurity, poverty and inequality, rapid urbanization, and a nutrition transition, which is contributing to this double burden of malnutrition in India. So this slide here shows you on the left side, it shows you data for a decade, including some future projections on the sale of processed packaged foods, which is basically what we are using as a surrogate of consumption of these foods. And the different colors are basically different product categories which are popularly consumed in India among children, mostly, and adults, because for WHO, prevention of obesity among children is our priority rather than treatment later. That comes as a second step. So what we are seeing here is that over this 1 decade period, we are seeing a surge. And what we can see is more than 10% increase in consumption of categories like noodles, which includes your Yippee noodles, Maggie, etc., soft drinks, which is like basically a Coke and Pepsi and etc., and ready to eat cereals, which is also a very popular product category among young children these days. Before going to school, that's what most of the children are getting. And this is what is fueling the rising burden of overweight and obesity in our country. So, how we went about doing this study? It was done through both an online, offline mode, done in 4 cities in India. And we collected data on over 1,100 product categories, which were divided in two broad categories: foods meant for infants and food meant for older children and adults. And then we saw compliance against existing Indian regulations of FSSAI and also some of the WHO guidance. And then undertook an analysis of the claims, labeling, etc., and policy enforcement. So the study was done in Delhi, Indore, Bangalore, Kolkata. We visited physical stores, collected data from there, and also two e-commerce websites were scanned. And while more than 1,100 products were assessed, what we saw was overall the health and nutrition claims that we found on these 1,100 products was about 3,000. And additional marketing, not just the health, nutrition, and ingredient claims. Apart from that, the other claims were amounting to about 2,000, which is a significant proportion. So you can see how much focus these companies have on marketing their products, the way they're pushing. It's such an overwhelming experience when you go to a shop to procure a product that it gives you very limited sort of scope to actually assess the nutrition profile of the product, but these claims come much before that. So in terms of the regulations and the guidelines that we scanned and we assessed these products against, it was broadly the FSSAI's advertisement and claims regulation, their labeling and display regulation, which governs the front of pack labeling, which is not there, and back of pack labeling. FSSAI's infant food regulation, which provides you the standards for infant milk formula, follow-up formula, commercial complementary foods, and the IMS Act, which is also a penal act, which covers infants up to 24 months of age. And apart from that, we have two documents from the WHO Southeast Asia Regional Office. One is what we call the nutrient profile model, which provides you thresholds for sugar, salt, fat, and energy for overall processed packaged foods. Your chips, biscuits, namkeens, all of that falls under that. And the other document is the WHO Nutrient and Promotion Profile Model, which focuses solely on infant foods meant for children up to 36 months of age. So what were the stark findings for the category of infant foods and commercial complementary foods? So this category includes 4 subcategories: formula milk, follow-up milk, complementary foods, which FSSAI further divides into milk-based and cereal-based foods. So broadly, these 4 subcategories under this. What we saw was about 1/3 of these foods contained a macronutrient above the WHO thresholds. Mostly this was total sugar and energy. And again, almost 1/4 of them did not meet the advertisement requirements for these foods, which have been laid down under IMS Act at least. Because under IMS Act, you're not allowed to sort of promote these kind of foods. When we assess the nutrient profile of these foods against FSSAI regulations and the WHO guidelines, what we found was that most of these baby foods had lower protein content than that was recommended, while a significant chunk, as you can see, 66% of these were sort of compliant with the protein, with added high protein were compliant. However, total sugar again remained a challenge. When we assess their health, nutrition, and ingredient claims, 1/3 of these products had some form of the claim or the other, which is again against IMS Act. When we're looking at the subcategories where the highest non-compliance was found, we found that the processed cereal-based complementary foods, which are most common in India, your Cerelac, Nestum, all of these come under this category. 1/3 of them were non-compliant with ample amount of nutrition claims. There were a lot of third-party endorsements from celebrities like Anushka Sharma and other such celebrities. When we looked at other claims and marketing strategies, there were a lot of misleading claims such as no sugar, while there was sugar added when you looked at the back of pack. Again, ample marketing. What was interesting to see was these health and nutrition claims were still limited in the category of infant milk formula, which is up to 2 years of age. That's because that's the age category under IMS Act, which is strictly sort of implemented. And also there are organizations like BPNI who are sort of ensuring its enforcement, monitoring its enforcement. Whereas there are other products which are meant for children above 24 months of age. For example, the same Cerelac meant for a child 36 months, ample amount of claims. So that amounts to surrogate marketing, which we observed in our study. With regards to the processed packaged foods, this is basically your all other foods that you see in the market, which are sort of processed, what we call also the ultra processed foods. So about 5% of these foods, if we use the WHO standards, would be eligible for marketing for marketing overall. That means only 5% of the products that were analyzed under this category met the WHO standards for the nutrition profile. They had the appropriate amount of energy, appropriate amount of sugar, salt, or fat, and not higher levels. Whereas within this category, the foods which were explicitly targeted to children, things like, your Horlicks, Bonvita, Maggie, there are chips, there are biscuits, which are explicitly targeted towards children. 95% of those products had one or the other macronutrient above the recommended thresholds. And on an average, we found about 7 or more health and nutrition or ingredient claims on most of these product packages. So of the products that we sort of analyzed in this category, 14% of them were explicitly targeted towards children. Again, almost 80% of these products within of the ones that were targeted towards children had higher sugar levels. The culprit categories here included confectioneries, milk and dairy products, which are often considered healthy, your potato cereal based snacks such as your chips, namkeens, etc., and of course juices. Whenever we talk to the policy makers in the ministry, they say, oh, juices are healthy. There's nothing wrong about juices. Juices are the most unhealthy things that are available, high in sugar content, no fiber, nothing, because the way that sugar is metabolized is totally different than consuming a raw fruit. Also, dairy is something which is a very sensitive category in India. If you talk about dairy, government doesn't want to touch that category. They don't want to increase taxes on it because it's sort of an indigenous industry. But again, the products are being sweetened to an extent which is beyond sort of comment. When we talk about the health, nutrition, and ingredient claims, again, we observe maximum amount of these claims in the category of juices and breakfast cereal products. And looking at the ones which were non-compliant to the existing FSSAI regulations, which restrict these kind of claims and marketing, we saw that about almost 1/3 of these products had a claim which was not meeting the regulatory requirement. Again, dairy being the culprit category here. In terms of other claims and marketing, we found a lot of claims on these colas, carbonates, which fall under the water-based flavored drinks, and again, confectionery here. So overall, what are the recommendations that we have? What we suggest is that we need to ensure compliance with the existing FSSAI regulations, specifically among the local upcoming baby food brands. I'll show you some examples. We have these Slurp Farms, which is a celebrity-led brand. So while it's a commercial complementary food, they don't provide you the age group so that they don't come under the ambit of that regulation. So I'll take you through some of those examples. Products throughout categories targeting children, they exceed the nutrient profile thresholds of WHO. We need to align the FSSAI nutrition thresholds with those of the available global guidance to and expand the coverage of all the products marketed to children. And most importantly, is enhancing the enforcement. We are good on paper always. That's been the strength of India. We have all the regulations, all the standards, but we're not able to enforce. I'll just quickly take you through some of the examples. This is, for example, an infant food, infant formula. And what we observed here is discounts that are available on websites, the way it's being promoted as bestseller. It sort of gives for over 85 years. It has standards set for evidence-based infant nutrition. So these kind of language is being used. Another example of this processed cereal-based foods by Tots and Moms. Again, it says 100% ingredient displayed, no added sugar or salt. Whereas if you look at the back of pack, again, there is sugar, no milk powder, no additives, a total 100% natural food, no junk added. So this kind of marketing is happening. This is a malt-based beverage. It says 25% ragi, but when you look at the back of pack, there's hardly any ragi in it. Then these freebies, often these chips come with this free toy, freebies, 1+1 offer, those kind of things. All of these are forms of marketing that are being used to promote consumption of these products. Slurp Farms. This is the brand by Anushka Sharma, made by two moms, healthy noodles. What is this? MSG causes headache, lethargy. We are not using it. So all sort of juice, again, rich in vitamin C, no added preservatives. So real, safe, nutritious, all kinds of marketing strategies we see. So in terms of recommendations, we have two sets of recommendations for the infant food category and for the other processed packaged foods categories. What for infant foods, we are suggesting that we need to close the regulatory loopholes by enforcing mandatory age range labeling and not allow, these products to not inform the age and just go away with marketing their products. Enhancing enforcement, particularly for the smaller domestic products, monitoring the sugar content, conducting regular inspections for labeling violations, addressing misuse of vague, misleading nutrition claims and third-party endorsements, and consider restricting or prohibiting promotional language or emotional and brand or heritage messaging, which is often seen in these products. For the other processed packaged foods, we suggest, high time we introduce a nutrient profile model, which will guide further actions like a front of pack labeling by FSSAI for all foods marketed to children less than 18 years, encouraging product reformulation through incentives or regulation, considering restriction on child-specific marketing and for non-compliant products. You often see a child on these products, something which is sort of encouraging mothers to procure or the children to buy. Again, banning vague or unsubstantiated claims and terms which can mislead consumers. Mandating evidence for all such claims. I think that's very critical. Regulating marketing practices that pair unhealthy products with child targeting advertisements. And lastly, introducing clear penalties for non-compliance and monitoring digital marketing platforms closely. Thank you so much. I'll close there.
Thank you, sir.
Thank you, Dr. Rachita, for covering a very interesting topic and giving us very useful insights. In fact, the advertisement and social media, most of the parents think that the foods are healthy, but unfortunately, the contents are totally different. So I'm really, I'm sure that the issues which you have raised will be very useful for the policymaker and all of us who are sitting in this. Thank you so much for giving us a very nice presentation. Next, I invite Dr. Sharika Yunus. She's a postgraduate in community medicine, and currently she's heading the Department of Nutrition and School Feeding at World Food Program. And she's going to discuss some of the food-based safety nets for overweight and obesity. Over to you, madam. We have 20 minutes now, please.
Good morning, everyone. And at the outset, thanks a lot to Professor Umesh Kapil for giving the World Food Program the opportunity to present. As Dr. Sood already mentioned, I'm going to be looking at how India's food-based safety nets, knowingly or unknowingly, are also perpetuating overweight and obesity. My presentation more or less builds on the presentations by my two colleagues, Shweta and Rachita. So for most of you, India's food-based safety nets, India's food-based safety nets have a rights-based approach. We have 3 food-based safety nets which are covered under the National Food Security Act. We have a rights-based approach, a life cycle approach to the food-based safety nets. So the first food-based safety net in that life cycle approach is the Integrated Child Development Services Scheme, or now which is called the Anganwadi Services Scheme. It has about 6 services. The focus of my presentation largely is going to be on the food component of the 3 food-based safety nets. So under ICDS, there's a supplementary nutrition which is distributed. It's given as take-home rations to children between 6 to 36 months of age and to pregnant breastfeeding women. And in the aspirational districts to adolescent girls. And then there is a hot cooked meal which is given to children between 3 to 6 years of age. Then we have the midday meal scheme. It's actually the erstwhile midday meal scheme, now referred to as the PM Poshan scheme, where there is a hot cooked meal which is provided to children between 6 to 14 years of age, largely children studying between grades 1 to 8. Both in the ICDS as well as in the PM Poshan scheme, despite the fact that NFSA 2023 may be there, but the focus largely remains on fulfilling calories and proteins. And then we have the targeted public distribution system, which is actually the mother of safety nets globally, wherein there's a monthly ration which is provided to households classified either as the Antodaya Anna Yojana or the priority households. And usually what households receive is a basket of wheat and rice. With that introduction, what is it that the government or the National Institute of Nutrition refers to? And my colleague Shweta also did allude to this a bit. So the National Institute of Nutrition recommends a My Plate for the day, wherein the focus is largely on a diversified plate, which should be sourced from micro and macronutrients from a minimum of 8 food groups per day. The cereals should not contribute to more than 40% of the total energy intake. There needs to be good protein content in the form of pulses, eggs, and flesh foods, which should contribute about 17% of the energy intake, and so on and so forth. Now, if we look at the PDS, so in the PDS, there are largely 2 categories of beneficiaries that we have. We have the Antodaya Anna Yojana, who are the poorest of the poor, and they are entitled to about 35 kgs of grains per month from the government. Initially, it used to come at an extremely subsidized price, but as of now, we have the Pradhan Mantri Garib Kalyan Yojana in implementation. So all of these grains are being given for free. And then we have the priority households, wherein each individual in that household is entitled to about 5 kgs of grains per month. And depending, so if there are like 5 individuals, the family is receiving about 25 kgs of grains. So the focus largely of the public distribution system is on grains and grains alone. And there is no linkage between what the My Plate recommendation given by the National Institute of Nutrition may be and what's really being provided here. So the focus is largely food security. Nutrition security does not figure at all in the discussions around the PDS. Very recently, the Department of Food and Public Distribution has introduced what is called the Jan Poshan Kendras. The Jan Poshan Kendras, though they may be called Jan Poshan Kendras, but interestingly, the focus of the Jan Poshan Kendras is on enhancing the financial viability to the fair price shop owner so that he makes a bit more money than what he's making as opposed to just running a fair price shop. And to make that financial viability, again, being called Jan Poshan Kendra, but they sell all sorts of stuff. And the focus largely is on selling ultra-processed foods, processed foods, beverages, ice creams, there'd be hardly any nutritious food that you may find in a Jan Poshan Kendra. Having said that, there are quite a few states in the country who are actually moving the distance between food security and nutrition security in the PDS. Extremely good examples of a very diversified PDS food basket, which is being provided in the state of Tripura. There's also an excellent food basket, very diversified with pulses, oil, apart from cereals, which is being provided in Himachal Pradesh. So if there is state willingness, then there are many states who are doing it with their own state resources as well. There's a recent study that we as the World Food Program have sort of completed. It's still under finalization, and therefore I could not present the findings of that study, but there is a focus as a part of the policy making. We would try and sort of start engaging with the Department of Food to focus more on providing diversified PDS food baskets. Now, coming through the second food-based safety nets, which is the PM Poshan. And what I've tried to do here is, it is a very busy sort of a slide, but what I've tried to do is keep the age groups that the PM Poshan caters to, look at what are the macronutrient in terms of the recommended dietary allowances or the estimated average intakes, then adjust it, because the school meals globally, as per guidelines, should provide about 1/3 of the RDA. Compare it with the NFSA 2013 norms, and then further compare it with the NFSA 2023 norms. Now, the NFSA 2023 norms, though they've been given as of February 2023, but to the best of my knowledge, I'm not aware of any state which has started implementing NFSA 2023, either for PM Poshan or for the ICDS. They are under a lot of pressure to implement it, but there are also practicalities as to why it's not been implemented. So if we look at the adjusted RDA or EAR and we compare it with the 2013 and the 2023 norms, we're not really doing that badly as far as comparison of calories is concerned. There may be scope for improvement as far as proteins is concerned, but calories, a few calories here and there. That's really the point that I want to make from this slide. But then when we start converting the nutrition norms into food norms, and it is important to convert the nutrition norms into food norms, because that's what helps state procure different commodities that then get cooked and provided as school meals. So when we look at the food groups, so the government actually recommends cereals and millets, pulses and beans. Then there is one broad category of vegetables. There is no breakdown of vegetables into green leafy vegetables or roots and tubers. The government just recommends one broad category of vegetables. And then the states sort of use this as a loophole to provide only potatoes and tomatoes and onions in the name of vegetables. There's no category for fruits. There's no category for nuts. There's no category for milk. And then there is a category for fats and oil, which again, very interestingly, with the oil boards and the sugar boards, has been misinterpreted out of context by quite a few states. But here, if I look at, what is the intake per day to meet the EAR. So if I look at cereals, so the intake per day to meet the EAR is about 160 grams. But then we adjust that for one meal. So ideally, one meal only should be providing 53.3 gram give and take. But what the PM Poshan norm is for 100 gram. So you're providing almost double that of what the child should be eating in one meal as a cereal, and then add to it, because the food norms do not give too much focus on the different types of vegetables, etc., that can be given. So it's largely a very calorie dense meal which is given, wherein most of the contribution is coming from the cereals. So this is the percentage calorie distribution from macronutrients for the primary and upper primary children. As you can see, most of the calories are coming from carbohydrates. There are, calories coming from proteins and fats, but the contribution of cereals is the maximum to the energy intake of these school-going children. Then, interestingly, a few states, despite there not being food norms for milk, have started introducing milk, and of course, full credit to those states. It's being introduced in good faith. Interestingly, I did not keep that slide, but egg is such a contentious issue in the PM Poshan scheme in the country, but there are quite a few states who actually provide eggs in the PM Poshan scheme, despite all the politics. But milk is provided by about 11 states in the country, and in the state of Chhattisgarh, it may not be provided statewide, but it's provided in specific districts and talukas. But then when you deep dive and look at what is it that's being provided as milk in these 11 states, you find everything under the sun. You find soya milk, you find Amulya dairy whitener being provided as milk. You have flavored milk. You have, of course, fresh whole milk, and full credit to the 4 states that are providing fresh whole milk. And then you have skim milk powder. I won't name the state where skim milk powder is being provided, but when you taste the skim milk powder, it is overtly sweet. So what is being done is actually, in the name of skim milk powder, it's a very sugary product which is being provided. And the sugar content of the milks that I have here on the screen varies anywhere between 3.28 gram to 18 grams per child per day. So this is just the sugar content that the child is getting from school alone. On top of it, because the school then feels that, children may probably still find it less sugary, they further add dollops of sugar into it to make it more palatable to the child. So in a sense, it's a very, very sugary product which is being given. Then there are about 3 states in the country who provide a micronutrient health mix. Again, if you deep dive into what that micronutrient health mix is, it'll have some ragi, but it will have an overwhelming amount of sugar. And then there are 2 states which provide a health drink, interestingly pushed by private sector under the name of heritage and tradition. But then again, this health drink again is extremely sugary. When we did this study, we actually did it in the International Year of Millets. And at that point in time, there were only 10 states in the country which were providing millets, despite it being the International Year of Millets. And only 4 of those 10 states were providing millets across the state. But when you look at what is it that is being provided as millets, it's either cookies or laddus or chips, which takes away completely from the idea of providing a millet. And probably the idea is the states are doing it from a space of good intention. It's just that there is a gap in their understanding and interpretation of the various guidelines which are out there. Now, coming to the third food-based safety net, which is the Integrated Child Development Services Scheme. And again, I've tried to do a bit of comparison. So the first column is the age of what I've left it only till 23 months of age and not taken it to 36 months, which is what take-home rations cater to. So in the first column, you have the age. Then you have the Indian recommended dietary allowances for energy and protein. Then you have the energy requirement as given by the World Health Organization if the child is breastfed. Then the energy requirement if the child is not breastfed, compared to what is it that the ICDS system gives. So if you look at I'll probably run you through the first row. For a child who's 6 to 8 months, the RDA is around 672 kilocalories. If the child is breastfed, then the entire complementary food that the child should be getting should be providing about 200 kilocalories. That's the entire ambit of the complementary food. Right? So 200 kilocalories. But what the child is getting through the ICDS is 500 kilocalories. So the child is, and the ICDS food was never designed to fulfill the entire requirement of the child. The entire requirement anyhow is 200 kilocalories, and you're pushing down THR, which is 500 kilocalories. And then you can more or less see the same sort of point being made in the next 2 rows. When we look at some global guidance on what such food products should be for children in the age group of 6 to 23 months, so it's recommended to be provided only as about 1 serve per day. The max calorie requirements should be in the range of 100 to 150 kilocalories. The energy the kilocalorie per gram should be at least 0.8 grams or more, and then it goes on and gives protein content, fat content, carbohydrate, added sugar, preferably less than 10% of the energy contribution. There should be milks because milk has a lengthening, milk, non-solids, non-fat, because it has a lengthening effect on the child, as has been proven in many Scandinavian countries. It should be rich in micronutrients, and of course, it needs to comply to the Infant Milk Substitutes Act and the subsequent World Health Assembly resolutions. Again, when we looked at the sugar content of what THR provides, the average energy contribution from sugars is as high as 23%. So really, very, very high. And so, I mean, the point basically that I'm trying to make is, again, less blame to the states, but probably it is where the policy guidance needs to be better from the central level, because the states are providing this as they have this element of a cost norm attached to the THR. They have to provide 500 kilocalories, and then the cheapest source of meeting that calories is therefore sugar. So we really need an enhanced cost norm, as opposed to definitely having better norms for the nutritional categories as well. Again, in the ICDS, it's my last. In the ICDS, there's a lot of focus on growth monitoring, and rightly so, but growth monitoring only to identify undernutrition. There is really no growth monitoring, or even in the capacity building of the Anganwadi workers, is there any element of focus on overnutrition and overweight and identifying these children, or referring these children, or counseling these children anywhere? And this is just my last slide, but just to focus on a few recommendations. Our food base, India has come a long journey from when we were a food insecure country to us now being a not a nutrition, but a food secure country. And therefore, now is also the time that our food-based safety nets need to be looked from a core lens of nutrition. You cannot be talking about, front of pack labeling, ultra processed foods, but at the same time, the government's own schemes and programs continue to pump huge amounts of sugar into the citizens. So there's a lot of focus that needs to realign towards nutrition. There are, credit to the government of India. The National Food Security Act 2023 has actually made the shift of moving away just from calories and proteins to having a more sort of a rigorous set of standards so that the sugar content gets limited. But unfortunately, NFSA 2023 is yet to go into implementation. And why it cannot go into implementation is because the costing of the different products, or the scheme, the PM Poshan scheme, as well as the ICDS THR norms, need to be improved. And that's a call that several states have been making to the center, but it's yet to go into implementation, and largely because the cost norms remain so poor. And then the final focus needs to be then on the capacity building and the social behavior change communication. Thank you so much.
Thank you, Dr. Yunus, for giving us a critical overview of the various food safety nets of the government. It was a really nice presentation. Thank you so much. Now I hand over the proceeding to Dr. Mania for the next session. Please come.
A very good morning, respected dignitaries, distinguished guests, respected faculty members, dear students, ladies and gentlemen. It is my privilege to welcome you to the inauguration of the World Health Organization Network site of Pandemic Preparedness and Emergency Response here at AIIMS, New Delhi. This occasion marks a significant milestone in India's public health journey, strengthening our national capacity to prevent, detect, and respond to future pandemics through science, collaboration, and preparedness. This network site builds upon the WHO Unity Study Protocols, a global framework developed during the COVID-19 pandemic to generate standardized comparable evidence on infection dynamics. We are indeed privileged and honored by the presence of our esteemed dignitaries this morning. May I now have the pleasure to invite them kindly to come forward and take their seats on the dais. We are honored by the presence of Ms. Payden, Acting WHO Representative to India, Dr. K.K. Verma, Dean Academics, AIIMS, New Delhi, Dr. Umesh Kapil, President, Epidemiology Foundation of India, Dr. Puneet Mishra, Professor, Center for Community Medicine, AIMS, and PI, WHO GISRS Unity Studies, and Dr. Sanjay Rai, Professor, Center for Community Medicine at AIMS, New Delhi. I welcome all esteemed dignitaries to kindly come forward and please take their place on the dais. We are indeed privileged to have such luminaries amongst us in the field of public health here on the dais today. May I request Dr. K.K. Verma, sir, to kindly felicitate our chief guest this morning, Ms. Paden, acting WHO representative to India. Thank you, sir. May I request Dr. Sanjay Rai, sir, to please felicitate Dr. K.K. Verma, sir. Thank you. May I request Dr. Puneet Mishra, sir, to please felicitate Dr. Umesh Kapil, President, Epidemiology Foundation of India. Thank you. May I request Dr. Puneet Mishra, sir, to please felicitate Dr. Sanjay Rai, sir. May I request Dr. Shahana to please felicitate Dr. Puneet Mishra, sir. Thank you all. It is indeed a proud moment to have such distinguished leaders to grace this occasion. To commence today's proceedings, I invite Dr. Umesh Kapil, sir, President, Epidemiology Foundation of India. Dr. Kapil has been a leading figure in public health research with decades of contributions to nutrition and epidemiology and continues to inspire the next generation of public health professionals. Request, sir, to kindly deliver the welcome address.
Namaskar and good morning to all. Ms. Pedem, acting representative WHO India Country Office, my colleagues Dr. K.K. Verma, Dr. Sanjay Verma, Dr. Sanjay, Dr. Puneet, on behalf of Epidemiology Foundation of India, I welcome ma'am you, and I must say that Epidemiology Foundation of India, with about 7,500 members, majority of them are public health experts in the country and about 27 other countries in the world. We extend our full support to Dr. Puneet Mishra for his endeavor in the research. And I must tell you, I take this opportunity to just share that All India Institute of Medical Sciences, where I spent about 45 years of my life, has a very rich heritage. And if you look at the AIMS contribution to the country's national health program, there are about 10 to 15 national health programs which have been initiated by faculty of All India Institute of Medical Sciences, like Iodine Deficiency Disorder Control Program, Integrated Child Development Services Scheme Program, National Fluorosis Control Program, National Cancer Control Program, National Mental Health Program, Non-Alcoholic Fatty Liver Disease Program, all have been contributed and provided leadership by Faculty of All India Institute of Medical Sciences. So we have a very rich heritage, and I can assure you that Dr. Puneet Mishra will continue the same heritage with flying colors. I must also share with you that AIMS has about nearly 2,000 publications in PubMed Index Journal, and about 60% of them is in high impact journal. So it's one of the most dynamic institution as far as research is concerned, and we all have a very rich tradition, and Dr. Puneet Mishra will have all support of all of us to facilitate him in undertaking the responsibilities which has been given by WHO to him. I understand that he has been a very active research scientist who has been contributing a lot during the pandemic of COVID and post-pandemic COVID era. So with these few words, ma'am, I welcome you, and all the delegates, I welcome you, so that you enjoy your stay, you enjoy this inauguration program. Thank you very much.
Thank you so much, sir, for those very thoughtful words and for emphasizing the spirit of collaboration that AIMS is famous for, which also underpins this initiative. The COVID-19 pandemic underscored the urgent need for standardized comparable data to guide public health action worldwide. The WHO Unity protocols were developed in response to that need, helping countries understand infection dynamics, transmission, and population immunity. In India, Dr. Puneet Mishra, professor at the Center for Community Medicine at AIMS New Delhi, has been closely associated with this global initiative, and his contributions during the pandemic have been instrumental. We hope that this work now continues and expands through this network site. May I invite Dr. Puneet Mishra, sir, Professor CCM and Principal Investigator of the WHO GISRS Unity Studies, to provide an introduction to the project.
Thank you, Manya, for inviting. Honorable Chief Guest, Ms. Padden, WR for India and Maldives. Dr. K.K. Verma, Dean, AIMS. Dr. Umesh Kapil, President, EFI. Dr. Pradeep Agrawal, Dr. Sanjay Rai, my esteemed colleagues, distinguished guests, all the public health professionals, EFI members, students, media, ladies and gentlemen. In fact, it's a great honor to speak with you today about the WHO's Unity Protocol, which is a globally recognized framework that stands at the forefront of pandemic preparedness and emergency response. The COVID-19 pandemic taught us invaluable lessons about the velocity at which infectious diseases can spread and the depth of devastation that can inflict. In response, WHO developed the Unity Studies Initiative, a harmonized, globally standardized set of protocols designed to enable rapid, coordinated investigations across countries at the earliest stage of an outbreak. So how it started in at AIMS? I still remember it was I think it was September of 2020 when Dr. Mohammed Ahmed, who is NPO at country office, he's here, Dr. Ahmed. So he called us and requested us to conduct a COVID-19 sero surveillance study. You all know that was COVID-19 era. Lockdown was all everywhere. And even though we immediately accepted this challenge, despite of shortage of time and lack of readily available geographically representative study sites. Once we accepted the proposal, we identified potential sites. We identified 10 sites, and initially we have taken 5 sites for seroprevalence. We trained the protocol, the PIs for the protocol, And the 5 sites which were taken, they were all over the country: Agartala, Bhubaneswar, Delhi, Gorakhpur, and Pondicherry. And remember, it was done when there was lockdown. It was very difficult to travel and other things. So for those studies, we included all age groups except infants, both sex, and both urban and rural areas. As a special case, in Agartala side, we have taken tribal area so that we get idea about what's happening for the COVID in tribal area as well, to understand the disease dynamics. Each site had 1,000 participants, and we had 10,000 participants for all across the country for this study. Collecting blood specimen, even in normal circumstances, it's a difficult task. It became even more difficult during an ongoing pandemic, but we did it and we succeeded in our objective. One more noticeable achievement was to convert the initial cross-section sheet design to a longitudinal prospective cohort up to 7 rounds in next 3 years, including cell-mediated immunity and neutralizing antibody through PRNT. Our efforts resulted in some very valuable scientific evidence. The findings provided input for national level policy on COVID-19 vaccination for children aged less than 12 years. We were also able to document the decline in antibody titer as well as role of cellular immunity. These findings were published in prestigious peer-reviewed medical journals, including PLOS ONE and Vaccine. Till date, we have published more than 7 scientific papers, as well as contributed data from India, which was aggregated by WHO to publish at the global level. So the primary objective of Unity is straightforward but powerful: to generate robust, comparable epidemiological data quickly. This data tells us how a pathogen transmits, who is most at risk, and how severe the disease truly is. Such evidence is cornerstone of informed public health decision making. Our past efforts established that we have the network capability and sound epidemiological understanding to undertake any future Unity protocol study. W has selected AIIMS New Delhi as site and me as principal investigator of this Unity protocol network in Southeast Asia region for pandemic preparedness and emergency response. It is one of the just 5 sites in Southeast Asia region, and it gives me immense pleasure that Ms. Padden, WHO representative to India, our Dean, Dr. Verma, Dr. Umesh Kapil, and all of you are here despite your busy schedule, and personally present here to formally, Ms. Padden is personally present here to formally inaugurate the WHO network site for pandemic preparedness. I am extremely grateful to Ms. Padden for her kind gesture for inaugurating this site at AIIMS. I want to inform this August gathering that we have already started the preliminary work for expanding the network to 20 sites. We had 10 sites during COVID, now we have 20 sites. Many of the new AIIMS are now partnered with us for this study. And to-date training program has already been done. Site visit for evaluation of certain potential sites are going on so that this network can further be expanded if the need arises in future. At the end, I'd like to say the WHO Unity Protocol exemplifies the essence of pandemic preparedness: early detection through standardized research, global solidarity through collaboration, and resilient health systems through capacity building. By embracing these protocols, we stand stronger together, prepared not just to respond, but to anticipate and mitigate future pandemics for the health security of all. AIIMS New Delhi strive to help with excellence in this endeavor of WHO. Thank you and Jai Hind.
Thank you so much, sir, for that very lucid introduction to the project. As you have highlighted, the Unity platform is not just a set of studies. It is a global movement towards evidence-based, rapid, and standardized pandemic response. We are honored to be part of this global movement. The Unity studies were conducted in over 150 countries, generating vital data that informed WHO guidance. The new Unity 2.0 network now extends this platform to multiple respiratory pathogens, including influenza, RSV, and emerging viruses, strengthening global surveillance and research capacity. Today, India takes this work forward, not only as a beneficiary, but as a regional leader in preparedness, training, and data generation under the Unity platform. We will now formally inaugurate this center, marked by the curtain release of the plaque and the lighting of the ceremonial lamp. May I request all dignitaries on stage to kindly come forward for this auspicious moment, symbolizing the light of knowledge, collaboration, and preparedness. Thank you to all esteemed dignitaries. It is indeed a momentous occasion for us here at AIIMS New Delhi. It is now my honor to invite Dr. K.K. Verma, sir, Dean Academics, All India Institute of Medical Sciences, New Delhi. Under his leadership, AIIMS has continued to uphold the values of innovation, service, and scientific rigor, values that are at the heart of this center. Request, sir, to kindly address the gathering.
Honorable Ms. Padden, WHO representative for Southeast Asian region, India head office. My faculty colleagues, Dr. Umesh Kapil, Dr. Sanjay Rai, Dr. Puneet Mishra, members of the faculty amongst the audience, ladies and gentlemen, it's my profound honor and privilege to welcome Ms. Padden to our Indian Institute of Medical Sciences and also to you all. This honor was to be done by the director, since director had to go for another pressing engagement. So I was asked to fill in the gap yesterday, 10 o'clock in the night. But nonetheless, it's my personal pleasure also to welcome you all. As Dr. Umesh Kapil and Puneet had already said that AIIMS is the institution of national importance. We came into existence 70 years back, and we have maintained our leadership position in all three important domains which this institution was interested with. That is the patient care, medical education, and research. And not just that maintaining the leadership, we have been providing the guidance also to the different institutions of national importance and also other government organizations as and when they have asked for any kind of guidance or support in the health in the field of medical education, patient care, or research, or healthcare in general. Department of Community Medicine has been in the forefront as the Center for Community Medicine in all the three areas, but their primary thrust has been in the public health area. And they have done groundbreaking research, as Dr. Umesh Kapil was saying. There's a number of research projects which they have taken at the community level, and particularly the translational research, which has led the government policy formulations. And they continue to excel in the field of research, which has been demonstrated recently during the COVID epidemics when they have undertaken the zero surveillance studies in the community. And before that, the HIV, when during the HIV era, they have taken large scale zero surveillance studies in the community. I remember my days during community medicine posting. It's so difficult to access and have contact and connect with the people in the field, especially in the villages. They are always say, apprehensive, they are scared. They see you with suspicion as to why have you come when they are all right. Why do you want to do a study? What are you looking for? Are you trying to say extract some kind of information which is private to them only? And why are you there without adequately understanding as to what relevance it has? And also, till such time you have a connect, you have a personal contact with these people, it's very difficult to conduct any kind of studies in the field. And the community medicine department, they are positioned there in the field, in the community. So they have a connect. And by virtue of their personal contact and connect, they are able to do large scale studies. And I'm sure that with this also, and I'm so glad that WHO has agreed to choose our institution as one of the centers out of 5 centers that they have chosen in this region. And I'm sure that, yes, we would excel and we would deliver and meet their expectations in what they have called this WHO Unity Protocol Network site in the WHO Southeast Asia for pandemic preparedness and emergency response. From the leadership point of view, from the institution, we are with you. We assure you that you will have all the help which is needed from the institution and meet the expectations, not only say the WHO, but the people of the country, the nation, and the society also. And I thank the organizing committee, especially Dr. Sanjay Rai, Puneet Mishra, and of course, the chair of the Epidemiology Foundation of India, Dr. Umesh Kapil, for having invited me and given me the opportunity to be with you this morning and share my thoughts with you. Thank you very much.
Thank you very much, sir, for your visionary words and for reinforcing AIM's central role in India's health security framework. We are indeed privileged to have our chief guest for the day, Ms. Payden, for the inaugural address. Madam serves as WHO representative to India and WHO representative to Maldives. With over 3 decades of experience in public health across national, regional, and international levels, she has held key roles at the WHO and the Ministry of Health at Bhutan. Her leadership has spanned areas such as WASH, climate and health, healthcare waste management, and strengthening institutional capacities across WHO member states. As Deputy WHO representative to India, she provided strategic guidance for accelerating the elimination of visceral leishmaniasis, lymphatic filariasis, tuberculosis, measles, rubella, and leprosy. She also coordinated WHO's collaboration with India on comprehensive primary healthcare, universal healthcare, polio eradication, non-communicable diseases, environmental health, and the COVID-19 response. We are indeed honored by your esteemed presence today here, madam, and I welcome you to please deliver the inaugural address.
Dr. K.K. Verma, Dean, AIMS, New Delhi, Dr. Umesh Kapil, President, EFICON, Dr. Puneet Mishra, Professor, Community Medicine, AIMS, Dr. Sanjay Rai, Professor, Community Medicine, AIMS, dignitaries, public health experts who have gathered here today, students and friends, and my colleagues from WHO, a very good morning to you all. Namaskar. It is indeed an honor and privilege for me to attend this inauguration of the WHO Unity Site at AIMS, and I would like to congratulate the President, EFICON, and his team for organizing this very interesting 3 days of EFICON conference. The last session we managed to listen a bit. It was on nutrition, very interesting presentation, and I'm sure you also had similar interesting and useful deliberations yesterday and day before as well. So congratulations on that. WHO has a very long history of collaboration with AIMS, as several departments are WHO collaborating centers, such as palliative care, newborn health, and also trauma and emergency preparedness. And we also work very closely on reproductive health as well, wherein we got a lot of technical support from different AIMS department in implementing our WHO's country cooperation strategy with India over the last many years. So really, I'm really privileged to be here with the AIMS fraternity, as well as other colleagues, public health specialists from all across the country. My congratulations to AIMS Delhi as a WHO on becoming a WHO network site for pandemic preparedness and emergency response. This is a very huge responsibility, and we know AIMS had really delivered well. As you have heard from the previous speakers, AIMS Delhi had participated in the unity protocols when the pandemic just started, and a lot of researches were done along with other 10 sites, which Dr. Puneet also mentioned. And these research findings were very helpful, not only in policy changes or taking decisions, public health decisions in India during the pandemic response, but the findings also fed into global development of global guidance and strategies and policies for the pandemic that time. And these will be also serving us for addressing any future pandemics or outbreaks that we will be facing in future. So very huge responsibility for AIMS, and we are really grateful for AIMS for taking part in the unity protocol studies during the COVID, and now continuing to also support further in future response as well as preparedness for any pandemics. Now, the current collaboration will enhance institutional awareness, reactivate former COVID serosurveillance sites. So Dr. Puneet mentioned that earlier it was 10, and now he's even expanding it to 20, which is really wonderful and great news for us. And then throughout, as we move forward, we will be also looking at training site personnel for capacity building, skill development under the WHO Unity Studies framework. So thank you so much for that, and we really appreciate all the support that AIMS has provided along with other premier institutes in the country. Now, about the unity protocols, you already heard, but I like to emphasize a bit on it again. The WHO unity protocols were developed during the pandemic, as I've said earlier, to provide a standardized approach for countries to conduct local investigations on emerging or re-emerging respiratory pathogens, enhancing global pandemic preparedness and response activities. So very important responsibility. And this global strategy and preparedness plan triggers rapid activation of research and development activities during outbreaks. So we are preparing ourselves, the institutes are preparing ourselves for activating or triggering any research required in case we face any pandemics in the future. Hopefully, we pray that we don't face any pandemics in future, but here we never know what happens. There's so much of dynamics around viruses as well, and the movement of populations, interface with the environment, etc. So we have to be prepared and ready to carry out any research immediately as we face any new challenges in the future. So post-pandemic, WHO Southeast Asia Regional Office established a regional network of sites to ensure readiness for rapid study implementation. And AIMS Delhi had joined this network in 2024, so last year. And we know that emergence of new respiratory pathogen with pandemic potential has immense human as well as economic cost. And we must be prepared to respond rapidly to mitigate the impact on lives and livelihoods. So we don't want any lives to be lost to any kind of future, outbreaks or pandemics. Now, expanded surveillance has made this possible. You all have seen during the pandemic. And instead of focusing on one pathogen, the network simultaneously conducts mosaic surveillance on multiple pathogens to identify their transmissibility, population susceptibility, infection severity, etc., to inform response. So the key things that we did also during the COVID pandemic. Unity Studies 2.0 takes this forward by providing an operationalization framework to every network site to conduct high-quality standardized investigations and studies for national, regional, and also global informed decisions and actions. So whatever you do here has a outreach also at the global level. And we are really proud for India to be leading in this front. This unified representative network of global investigation sites in turn will provide the systems, tools, connections to rapidly assess respiratory pathogens of pandemic and epidemic potential. And WHO and along with other partners are committed to support these global centers of excellence to build capacity and deliver on our shared and common goals. So here, the site here will be really, what we will be doing here will be informing the appropriate level of response nationally and regionally. Whatever we do here will be, again, feeding into regional and global response and targeting intervention activities effectively to reduce the impact of potential pandemic and ensuring timely collection and sharing of early information. So we get information early on so that we can further reduce impact on humans. I would like to thank the Center for Community Medicine at AIMS for implementing these 3 unity protocols, which we heard over and over again during the pandemic. So thank you for that. And it was really helpful for informing and changing global interventions for the pandemic response. And I would like to congratulate AIMS again for being one of the 5 sites selected for the WHO Unity Study Preparedness and Response in Southeast Asia region. So AIMS is one of the 5 sites in the region, led by Dr. Professor Puneet Mishra as the principal investigator. I would like to wish you all success to the teams of AIMS Delhi and the sub-sites, the 20 sites which have been identified for coming up with some great work, which will be very helpful for the country as well as for the region and globally. As at WHO, we will continue to work with Dr. Puneet and his team, and also with other departments on many of the public health programs that we are already collaborating on, and including researchers on very important areas. Will, in addition to pandemics, will be also working with the teams. And together, we will be able to build a very resilient and safe world for our future populations. Thank you so much.
Thank you so much, madam, for those very inspiring words and for your steadfast leadership in advancing India's public health agenda. We're nearing the conclusion of the ceremony, and for this, I invite Dr. Sanjay Rai, sir, Professor, Center for Community Medicine at AIIMS, New Delhi, whose leadership during the pandemic exemplified the crucial role of scientific evidence and professional networks in shaping India's public health response. Request, sir, to kindly deliver the vote of thanks for this inaugural function.
Thank you, Dr. Manya. Namaskar, a very good morning, everyone present here. Really, it's my privilege and honor to share the vote of thanks with all of you. On behalf of organizing committee, I extend our heartfelt gratitude to all the distinguished guests, speakers, delegates, WHO country office members, and all those who are here in this session. This session is truly very enriching session. Our deepest appreciation goes to Ms. Pedan, the current WHO representative to the Maldives and acting WHO representative to India, for her valuable insight and global perspective on pandemic preparedness, reminding us of the importance of international collaboration and early response system. Our association with Dr. Pedan is very long. When she was here, she was in charge of infectious disease in WHO. We all are working in the infectious disease. So almost since the last more than 10 years. So thank you, ma'am. Thank you for your presence, your nice word, and also your encouraging words for this project. So thank you, ma'am. Thank you very much. A special thanks to Dr. Umesh Kapil, President of Epidemiology Foundation of India, for his visionary leadership and commitment he has for not only for this project, for all the research project. He was here and he mentioned that he was here for more than 35 years. So thank you, sir. Thank you for your support. We are deeply grateful to Professor Dr. Kaushal Kumar Verma, the doing research. Actually, we informed yesterday almost at around 10 a.m. So at a very short notice, finally, sir agreed to grace this occasion. So thank you, sir. Thank you very much for your presence, for your guidance, constant encouragement, and inspiring words that have set the tone of the strengthening institutional preparedness and for future public health emergencies. So thank you, sir. Thank you very much. We also thanks Professor Puneet Misra, principal investigator of the WHO Unity Research Project and also this pandemic preparedness, for sharing valuable research finding and practical insight that gives evidence and policy. So he shared all his findings. We have already published many papers. I was also part of that protocol. Dr. Sasikanti here, he was also part of that protocol, and many other institutions. The principal investors are already here, so they are the part of that unity protocol. So thank you, Dr. Puri. Thank you. Then our sincere appreciation goes to all the delegates, faculty members, researchers, students, WHO members, who actively participated and contributed to this discussion, making this session truly interactive and thought-provoking. So thank you, everybody. Thank you. Finally, I used to acknowledge the dedicated efforts of the organizing committee, technical team, and support staff. Dr. Priyanka is here, Celine is here, all other staff, Deepak, Sumit, so everybody. So for organizing this session, they have worked very hard. So thank you, everybody. Thank you, all the team members. Last but not the least, Dr. Manya, faculty member from my department, for nice conducting this session. So thank you, Dr. Manya. Thank you very much. So, friends, let us carry forward the key takeaway from the today's discussion to strengthen our collective capacity to prevent, detect, and respond to future pandemic. Thank you all once again for your presence and participation. Thank you, everybody. Thank you.
Thank you so much, sir, for your words of gratitude. We are, of course, inspired by your lifelong dedication to advancing India's public health framework. Before we close, may I request Dr. K.K. Verma, sir, to kindly present the AIMS memento to Ms. Payden, our chief guest, as a token of appreciation for WHO's partnership and for her personal leadership in advancing the global health agenda. Thank you, sir, and thank you, ma'am. We are indeed honored by your esteemed presence. And as we close this ceremony, let us carry forward the shared vision that this center represents, one of preparedness, partnership, and global solidarity. I invite all the esteemed guests to please join on the stage for a group photograph. Thank you all once again for joining us on this special occasion. And after this photograph, this is a golden opportunity for our esteemed participants also for a group photograph with Madam. And after this one is done, please I invite everyone available for a group photograph with the esteemed dignitaries.
Young, beautiful girls, you can sit down in front. That will be better. And people sitting in the front will get the best photo. I can tell you. Good, good. So please. चलो चलो good. चलो 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 आगे आ जाओ. Very good. बैठने वालों की 2 रो बना जाओ. चलो चलो जाओ 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 जाओ. जाओ. सरदार जी ਤੁਸੀਂ ਤਾਂ ਲੰਬੇ ਹੋ यार पीछे जाओ.
लेटेस्ट तो अभी
लोगों नंबर से अपडेट करो।
हाँ जी सर।
बहुत अच्छा लगा।
ये नहीं अपना
Okay, good afternoon. We are starting a very important session, that is the Senior Scientist Award. And in this session, as you know, it is very prestigious award. We have 5 presentations, and we have requested Dr. C.M. Singh, a director, RML Institute of Medical Sciences, and sir has been earlier the dean and medical superintendent at AIIMS Patna to chair the session. Second distinguished Dr. Farooq Ahmed, sir. He's a retired director from Milgrims and former VC of KBN University, Gulbarga. So we have requested them to kindly chair this session and take over. The first speaker, sir, is Dr. Pradeep Kumar. So you have 5 to 6 minutes for your presentation. Please come. Over.
Okay. Okay, first speaker is Dr. Pradeep Kumar. Dr. Pradeep Kumar is working as a scientist, Epidemiology Division of Clinical Research Unit at AIIMS New Delhi. He had multiple publication having H index 23 and I-10 index of 44. He is associate editor in acute stroke and interventional therapies, associate editor for translational neurosciences, and guest associate editor for neurodegeneration, guest associate editor stroke, associate editor human gene, and editor for BMC cardiovascular disorder. Dr. Pradeep, please start your presentation.
Thank you, Chairperson, and good morning to all chairpersons and the delegates. So my slides, please, to display. Please. Yes, slide. Yes. So my presentation for Best Scientist Award is the topic is direct oral anticoagulant for stroke prevention in atrial fibrillation. It's a global synthesis of randomized control trial using the network meta-analysis. So as you know that atrial fibrillation is the most common sustained cardiac arrhythmia worldwide. It's affect around 33 million people globally, and major risk factors for cardioembolic stroke. And the treatment regimens are multiple direct oral anticoagulants, and that are preferred over the vitamin A antagonist, and that is used for the both valvular as well as non-valvular atrial fibrillation. So there is no head-to-head comparison trials. So that's why we use network meta-analysis to evaluate the efficacy and safety of directly oral anticoagulants as compared to the vitamin K antagonist in atrial fibrillation patient related to stroke prevention. So we used standard Prisma network meta-analysis guideline that is published by 2020, and we registered our protocol in Prospero having the preferred ID, and we search three databases. One is PubMed, second is Ambase, third is Cochrane Library. We searched the article that are published up to October 31st, 2024, and we also screened the manual references that were found during that database searching. Standard keywords and match terms were refined and were used for making the data search strategy. So eligibility criteria for our network meta-analysis was the population adults with atrial fibrillation with valvular as well as non-valvular AF. Intervention we use directly oral anticoagulants compared with the vitamin K antagonist that may be preferred as once or twice a day, and comparator may be other DOSCs or VKA. Outcome, we access the 4 outcome. One outcome was ischemic stroke, systemic embolism. Second outcome was hemorrhagic stroke. Third outcome was major bleeding. Fourth outcome was all-cause mortality. We included only RCTs because we have to present the high level of evidence. That's why we included only randomized control trial in our network meta-analysis. Statistical analysis, we use Bayesian random effect model, and we reported odds ratio followed by the credible interval, and we also reported surface under cumulative ranking that is used to compare the treatment rank also. We did the analysis using the Meta Insight software, that is the online free available version 4.0.2 beta. We also did the quality assessment of all the included randomized control trial using the modified Jadad score that is usually used for the systematic review and network meta-analysis, having the score of 0 to 8. So in the results part, we screened around 860 records. Out of 860, 183 were duplicates from the different databases, and 550 articles were screened for the title and abstracts, and followed by we reviewed 97 full text, and out of 97, only 43 have reported the outcome, and 43 RCTs were reported in our final network meta-analysis. This is the Prisma flow diagram. You can see here, the final inclusion is 43 RCTs. So out of 43 RCTs, the publication range here were ranging from 2007 to 2022, covering diverse clinical settings, and they have compared the 4 DOCs, naming dabigatran, rivaroxaban, apixaban, indoxaban, and compared with the vitamin K antagonist. The outcome reported were ischemic stroke in the 31 trials, for the hemorrhagic stroke, 20 trials, major bleeding, 38 trials, mortality, 27 trials, and 13 trials were reported about the outcome in the non-valvular atrial fibrillation, and 30 trials were reported for the valvular atrial fibrillation. Both groups were accessed in our network meta-analysis. You can see the results for the outcome number 1, ischemic stroke systemic embolism. Dabigatran showed the major effective, followed by the apixaban and rivaroxaban. For the indoxaban, there was no significance, but in the what we did the subgroup analysis in the valvular group, dabigatran as well as apixaban were the most superior DOACs, and for non-valvular, no significance was achieved. But in the valvular section, dabigatran and apixaban were more. You can see the forest plot here, and the comparison is between the DOSs as compared to the VKA. And these all are the outcome: ischemic stroke, valvular AF, non-valvular AF, and combined. So in the combined also, apixaban and dabigatran were the most superior for the ischemic stroke systemic embolism. This is the network plot. You can see here, it depicts about the strength of the association between the different treatment regimens. And second plot is called as Sukra diagram that reflect the treatment modality, which one is superior. You can predict here the dabigatran is showing the most superior treatment, and the apixaban second one for the ischemic stroke systemic embolism outcome. For the second outcome, hemorrhagic stroke, best outcome was received by dabigatran, that is odds ratio 0.30, then endoxaban 0.47, apixaban 0.53, rivaroxaban 0.60. So here dabigatran also was the most important treatment regimen for the hemorrhagic stroke. For major bleeding, again, apixaban were found to be significantly reduce the major bleeding components in the atrial fibrillation patients, and the odds ratio was 0.69. That means 31 reduction if you prescribe apixaban. And for the non-valvular atrial fibrillation, no significant reduction was observed statistically between the other DOCs. And for the valvular, apixaban was the most significant. In case of all-cause mortality, apixaban again was the most common, followed by the dabigatran. Near about both have the similar efficacy. We should recommend the treatment regimen should be start with the apixaban or dabigatran. So results, dabigatran top ranked using the Sukra ranking plot. Apixaban is also top for the major bleeding reduction and mortality. And for the non-valvular atrial fibrillation, dabigatran was the best for ischemic stroke, systemic embolism, and hemorrhagic stroke. And for valvular, apixaban leads according in all the outcome. So in the quality assessment also, we did using the modified ranking scale, and we found all the 43 RCTs where have the low risk of bias. So study strength, it is the first largest network meta-analysis comprising of 43 RCTs, and that is the largest and most updated evidence comparing 4 DOSs with the VKA in atrial fibrillation patients, and focus exclusively on randomized control trial. It also includes both valvular as well as non-valvular atrial fibrillation patients. So study limitation there exist. Heterogeneity in the AF classification was noted. Outcome definition were varied in different cities, and follow-up length were also varied. There were lack of individual patient data. That's why we not do the individual patient analysis, and the dose specific adherence variation was not possible because most of the cities were not provided about the dose regimen individuality score. So that's why we not included in our network meta-analysis. So potential indoxaban is a newer agent. So lesser studies were found. So that may be a limitation of our study that we don't found any significant association with the newer agent called as indoxaban. So conclusion, dabigatran is superior in reducing the ischemic stroke hemorrhagic stroke risk. Apixaban is the safest one, and we should further patient level analysis are recommended. And we have submitted this network meta-analysis in Indian Heart Journal, and it is supposed to be expected because minor comments were received. Thank you. Any questions? I will be happy to answer.
Thank you. Thank you, Dr. Pradeep. Thank you.
Okay. Next, I invite Dr. Sudip Bhattacharya, please.
The next speaker is Dr. Pradeep Bhattacharya, a faculty from the Community Medicine in Deoghar, AIMS. Now, he is the next faculty for in two of the institutions in Philippines and Malaysia. He has more than 160 publications and patent patent has 2 patents he has, and he is in the editorial board of the British Medical Journal. And he is a fellow of the Royal Society for Public Health, London. Dr. Sudeep.
Thank you very much. Respected seniors, colleagues, and juniors. So my topic of presentation is trends in diabetes screening and care in Jharkhand, India. So you already know India is a hub of a diabetes center, and from national surveys or many studies, it ranges from the prevalence ranges from 7% and pre-diabetes ranges from 10 to 25%. And especially Jharkhand, the studies are very scarce, and as per ICMR old study, it shows 5.3% prevalence, and recently Ramgarh district observed a diabetes prevalence is among 8.2%. So we have a problem of diabetes and other non-communicable disease in tribals also, which was previously thought as a myth. So what we have done from AIMS and others, as it is a difficult area in the tribal area, with respected our ED sir and ECO team, we have created a digital academy that is called AIMS Deoghar Digital Academy, and we have trained more than thousands of healthcare workers working in the periphery for screening of non-communicable disease as well as diabetes. And also multi-stakeholder collaboration is also important. So you can see we have collaborated with the State Health Department, WHO, police personnel, district commissioners, and local panda, local priest also. Because without their help or collaboration, it is impossible to penetrate the tribal population. So these are some collaborative pictures. Next level, we have done some meeting, and we are conducting regularly physical meeting with the ground level healthcare workers and listening their challenges regarding screening of diabetes, non-communicable disease, and other problems. Most important point is that getting connected with the tribal people, because already sir has told previously in previous session that connectivity is the strength of the community medicine. So we connected with the local people, because if trust is not there, then they will not accept you. This is an example of NCD screening is going on in a household. So laterally, we have trained our students also, not only faculty or healthcare workers, we have trained our students and in turn, they are also doing blood sugar screening by stream method. So with this background, after working for hard 5 years in a new institute, we want to analyze the temporal patterns and trends of diabetes screening and management across Jharkhand using routinely collected program data. So obviously, it is a cross-sectional study. The data source was taken from Jharkhand State Health Department, and study period, it covers 5 years, 2021 to 2025, September. And indicators were enrolled, screened, diagnosed, under treatment, follow-up, and adherence control. So from this first graph, we are seeing that the enrollment has been increased from 3.5 lakh to 70 lakhs within 5 years. And its average growth is over 110% per year. Early surge is 2 plus 253%, but there is a recent slowdown due to stabilization. Screening rose from 2.6 lakhs to 64 lakhs. Coverage improved from 73% to 91%. But still the gaps is there. And regarding expected versus diagnosed versus under treatment, the expected diabetes cases estimated at 7% prevalence of the screen each year, rising from 18,000 to 4.4 lakhs. Diagnosed cases also increased 3,000 to 1.4 lakhs. Detection rate began at 21%, now it is 31.3%. And most importantly, there is drastic increase in the treatment initiation. That is, it have started from 2.1% to now it is 94.3%. So next is follow-up adherence is important, but follow-up adherence we are seeing that it is increased from 3.8% in 2021 to 19%. And the trend is sharp rise between 2023 and 2024 and 2024-2025, but there is a plateau is there. And control rate is 1.22% to 7%. So what we have done, because we have lack of data, because census has done in 2011, we fit into a linear projection model. It showed a strong fit with a significant upward trend, that is p-value is significant, and it is projected that the enrollment target of 183 lakh is expected achieved by 2023-2033 under the current trends. So if there are two scenarios, one is best case scenario, one is worst case scenario. If best case scenario में क्या होगा कि the target will be achieved, we are assuming the target will be achieved by 2031 to 32. अगर worst course scenario होते हैं तो ये target 2034 to 35 में हम achieve कर पाएंगे. But this forecast is a assumption based. There are many limitations. If you want to ask, then I can go to detail later because I have very less time for presentation. So initially what we have done for last 5 years, that is very small work, but still we are doing our level best. There is increase in case detection rate and treatment initiation success, but we are still lacking challenges in follow-up adherence and achieving glycemic control. So now we are going for the Lancet publications, and we are going for the in the family also, how family dynamics can changes the treatment adherence and outcomes. So we have proposed 3 models, and it is published in Lancet Southeast Asia. Again, it's important how Apex Medical Institute that INIs can help to improve the indicators of a state. So it is also published in Indian Journal of Community Medicine. Next is communication is another issue for the tribal populations because there are different tribes and different languages are there. So you are coming suddenly from outside or aims and you are going to the community, this is not acceptable. So what are the strategic communication? You can read from this article. Next is another important aspect is cultural competence. As a healthcare worker, we are coming from Punjab, Haryana, going to Jharkhand, or Jharkhand, they are coming to Punjab and Haryana or other parts of the country or South India. They do not know how to communicate. So cultural competency is one of the important aspects. So we have to focus on that. You can see from this paper also. And most importantly, the language barrier, you have to abolish the language barrier. So already we are using our mobile, we are using our icons. So we are not reading what is the icon is there. If text message is there, we are clicking for text message, what clicking like that. So it is not a new things like now. It is actually old things from Greek, from you go to tribal area, tribal village, they are doing this alchiki printing. Their symbolic messages are there. So we are developing app to send the symbolic messages to the tribal communities so that the message can be easily delivered and without any language barriers. So happy Johar, thank you very much. And I am finishing with my last favorite quote, that is, the world is changed by your example, not by your opinion. Thank you very much. Thank you. Any questions?
Yes, sir. Thank you.
Okay, thank you, Dr.
Now I request Dr. Anju ma'am to please come.
Okay, please start.
Hello, good morning, respected chairpersons, and good morning, everyone. The title of my study is Diagnostic Accuracy of Chromosomal Instability Marker for Detection of Measurable Residual Disease in Pediatric Acute Leukemia. So chromosomal instability is defined as the persistent high rate of loss and gain of whole chromosome or a part of chromosome, resulting heterozygosity and aneuploidy. Chromosomal instability is an important factor for the carcinogenesis. And there are several methods to demonstrate the CIs, like FISH, CGH, but all these methods are very costly, not feasible everywhere, and need expertization. So it requires some alternative methods like morphological marker of chromosomal instability. This marker, the traditional marker, but doesn't use in routine practice. So the index study emphasized revisiting the chromosomal instability marker that is already described. We discuss 7 CI marker in this study. As shown in this figure, we can see first figure is showing micronucleus, that is multipolar mitosis. Here we can see nuclear part. There is an internuclear chromatin bridge, that is a chromatin string. Here we can see the there is a ligands. Here we can see that is a nuclear heterogeneity. Bone marrow aspect, smears and biopsy. So the aim was current study to determine the diagnostic accuracy of morphological marker of chromosomal instability for measuring a measurable residual disease in pediatric acute leukemia in comparison to flow cytometry that was considered as a gold standard in this study. So the study design is a cross-sectional study. Data were collected retrospectively from departmental archive, bone marrow aspect and biopsy, flow cytometry detail from the pediatric acute leukemia patient and patient in remission from October 2018 to December 2021. And the scoring of CI markers was done in 2 groups. Group 1 included BMA, smears and biopsy of acute leukemia patient. In Group 2 included non-leukemic patients in remission. 2 slides per patients were screened for scoring of the CI markers. And the CI markers were quantified on a per 1,000 hematopoietic cell in light microscopy immersion. On the current study cutoff value for combined CI markers, for a 7 CI marker, more than 5 CI marker per 1,000 cells considered as abnormal. For the each CI marker, more than 1 CI marker considered as abnormal. The diagnostic accuracy of CI markers of both groups compared with the flow cytometry, as there was no such study, so sample size was calculated. Hypothetically, AUC was taken 80% against the null hypothesis, and sample size was calculated 70 cases in each group. But availability was sample, we took 84 cases in each group, and the data were analyzed. Stata 14 software, and along with the descriptive study, diagnostic accuracy was estimated by using 2x2 table against the flow cytometry. ROC curve was plotted and area under curve was estimated. Mechanism test was applied to assess the significant difference between 2 tests. And the study was approved by Institutional Ethics Committee. And in this study, we took 168 total BMA and biopsy sample from 168 patients. Out of them, 84 patients of acute leukemia and 84 patients in remission. The median age of included patients was a 6-year. Male-female ratio was 4:1. And the table 1 is showing the diagnostic accuracy of morphological marker of CI in compared to flow cytometry for detection of the MRD in pediatric acute leukemia. Here in the table we can see the combined CI markers have 100% sensitivity, specificity, PPV, and MPV. And most of the CI markers have a very good sensitivity ranging from 10 to 92 point, but the specificity, PPV, NP, all CI markers have approximate 100 to 52%. When we plotted the ROC curve, the area under curve we found is a 1. That is a perfectly show association with the reference range. When we plotted the ROC curve for each CI markers, and we found most of the CI markers have a very high AUC ROC value, like nuclear pad, nuclear heterogeneity, chromatin strings. And when we applied McNeema test, and we found the micronucleus have a significantly high sensitivity and specificity in comparison to other CI markers. Similarly, nuclear bud also have a significantly high sensitivity, but other CI markers didn't show any significant difference. In the index study found 100% diagnostic accuracy of combined CI marker for detection of MRD in pediatric acute leukemia. But each CI markers sensitivity having in a wide range, 10 to 96%, while specificity and predictive value very high for each CI markers. The disparity in sensitivity suggested that all CI marker not always very high frequency present in all leukemia. But when they are present, they indicate presence of disease. When they are absent, that indicate complete remission. We also found the AUC ROC curve also show perfect association with the gold standard. And most of the CI markers also show a perfect association with the flow cytometry, except few like CB and ligands. That is demonstrate the morphological markers can be effectively affirm the true positivity and true negativity, and that is crucial. A clinical setting where the timely and accurate decision making is essential. And in this condition, the CI markers will help for the patient management because it's a very easy to perform and it's a very cost effective and simple to perform as a everyday health. And there is a lack of comparative study in the literature for the morphological marker of CI and flow cytometry. However, occasionally study described in a solid tumor like CF breast, and they show sensitivity to CI markers is 100%. AOC, ROC also is a heavier value 1 and significantly high for the micronucleus. That is corroborated with our study results. But none of the study in the literature describe the CI markers role for describing the MRD detection. And only occasional study showed the multiple CI markers in acute leukemia and MDS as a prognostic significance. The limitation of our studies that we are unable to correlate with a molecular study like FISH and NGS. So we conclude that study results showing the combined CI marker of morphology showing a significantly high sensitivity, specificity, and PP values for the MRD detection in pediatric acute leukemia. This marker could become a very useful for everyday medical practice and helping a diagnosis and treat the blood cancer patients more effective, but more larger and advanced research needed to determine their role to improving the patient care. This is my references. Thank you.
Okay.
Ma'am, what was your research question?
My research.
Liner.
Yes, sir. My research question was that is there any what is the significance of morphological marker of CI for detection of a MRD?
CI क्या होता है मैम?
Chromosomal instability marker of morphology. Chromosomal instability marker of morphology.
ये क्या होता है?
सर ये हम बोन मेरो एस्पेक्ट एंड बायोप्सी उसमें हम देखते होते हैं कि माइक्रोन्यूक्लियस, क्रोमेटिन स्ट्रिंग, न्यूक्लियर बर्ड, मल्टीपोलर माइटोसिस, these are the chromosomal instability marker. Like fish in fish, maybe are looking at amplifications. There is a fusion. These are the molecular patterns. But we can see these things in a bone marrow aspect and biopsy also, sir. These things we can see. They are spread by in a light microscopy in routine day practice also, sir.
Validity क्या है?
Validity, sir, as the we are confirming them is the flow cytometry is using the gold standard as a presence of these marker indicated as the leukemia or absence.
आराम से बताइए, आराम से बताइए.
हाँ, the real presence is showing a.
धीरे मत बोलो.
Slowly. Okay, sir. The presence is indicating there is a presence of a high frequency, is showing presence of a disease like acute leukemia. Okay, sir. When the complete absence, they are indicating there is a remission, complete absence of disease, sir.
कौन सी disease में इस्तेमाल करते हैं इसको?
They are used to detect the acute leukemia as a presence or in an absence in a complete remission.
तो जो पेशेंट आते हैं उसमें ये वाला टेस्ट करते हो?
Yes, sir.
अच्छा, तो उसकी मतलब कितना सेंसिटिविटी है, कितनी स्पेसिफिसिटी?
In this study, we found 100% sensitivity for the when we using the we are looked at 7 CI markers. Okay, sir?
नहीं, मैं इस टेस्ट की बात कर रहा हूँ.
हाँ, इसी की बता रही हूँ सर.
सेंसिटिविटी कितनी है, और स्पेसिफिसिटी कितनी है, पॉजिटिव प्रेडिक्टिव वैल्यू कितनी है, नेगेटिव प्रेडिक्टिव वैल्यू कितनी है?
Yes, sir, I shown in the my tables.
दिखाइए.
Where is gone? Sir.
हाँ, क्या हुआ?
मेरा वाला प्रेजेंटेशन नहीं है, इट्स डिफरेंट. ओके
प्रेजेंटेशन की वैलिडिटी होनी चाहिए ना.
प्लीज डिस्प्ले माय प्रेजेंटेशन. हाय अंशु खैरवा. Yes, sir.
आप यूसीएमएस से हैं?
Yes, sir.
Which department?
I'm a pathologist, sir.
Pathologist.
Yes, sir.
हाँ बताइए.
Yes, sir. See in this table.
ऐसा कौन सा टेस्ट है जिसकी 100% सेंसिटिविटी और स्पेसिसिटी है कोई ऐसा टेस्ट?
Yes, sir. Like we use as a gold standard flow cytometry. We use as a flow cytometry as a gold standard, sir. Okay, sir. And we compare with the flow cytometry with these CI markers, sir.
क्या नाम है आप?
Dr. अंजू खैरवा.
अंजू.
हाँ.
अंजू जी, ऐसा कोई भी टेस्ट मेरे को तो नहीं समझ में आया आज तक कि जिसकी 100% सेंसिटिविटी हो, 100% स्पेसिसिटी हो, 100% पीपीवी हो और 100% नेगेटिव प्रेडिक्टिव वैल्यू हो.
Sir, we calculate with using.
सर आप आइए और कुछ लाइट थ्रो करिए कि ऐसा कैसा टेस्ट है. हाँ, तो प्रेडिक्टिव वैल्यू कितना था?
Sir, when we using this predictive value is the positive predictive value. When we using a 7 CI markers.
माइक में बोलिए.
When we using the 7 CI markers, we compile, then we found the 100%. When we using the each 4 CI marker, that is vary. For micronucleus, that is 100%. For nuclear bed, that is a 98.8%. For a multipolar mitosis, in 98.1%. For the chromatin base is also 100%. When we saw for the ligands, 81.8%. And when we saw the chromatin string, there is a 93.8%. And when we saw nuclear heterogeneity, that is a 96.3%, sir.
आपका सैंपल साइज कितना था?
We sample size, sir, took 84 160 84 each group. We took 84 patient in leukemia, 84 patient for a remission group. Total. Okay. Yes, sir.
And you found that 100% sensitivity.
When we using the compile the 7 CI markers, then we found, but for each CI marker, when while looking the individual, when I am looking the individual, then it is a variable, sir. So list for the ligands, 10.7, sir. Okay, and then it's the highest for the nuclear heterogeneity. Okay, sir. It's a vary, and for nuclear bed is 96.4%.
Applied value kya hai? When we look at this whole situation and based on your objective, what is the applied value of it?
We are looking at patients on follow-up also. Patient signs, symptoms, their progression, their hemograms, their complete absence of blast, and their patients. Yeah.
In both the arms. So what is the applied value? How will you scale it up?
Looking at, we are scoring these markers on a bone marrow SP and biopsy smears, ma'am.
Right. That's
okay,
right.
Okay. And then we score them for each markers also, and we also combine also, ma'am, for them. Okay, ma'am. And then we put the value in a software set of 14s, and that was calculated. Okay, ma'am.
And how do we scale it up now? Because every institution, do you think will have all these facilities? At least even in Delhi, if we look at it. अगर इसको आप 3-4 institution मिलके करते, and probably when that question was raised in terms of sensitivity,
ma'am, उसमें बोलो ma'am.
Sensitivity, specificity, PPV and NPV, the sample size would have taken care of that part. You know, that's the. Thank you.
Thank you, ma'am.
Hello, I mean, is it a prognostic or a diagnostic test you have done?
Yes,
prognostic or diagnostic?
Sir, prognostic markers.
Not a diagnostic.
We can use as a diagnostic also, sir. We as a study shown is a diagnostic the breast cancer में shown किया गया fibroadenoma versus carcinoma breast, some solid tumors. Okay, sir. In here we are looking as a formal MRD detection. In this study, we are looking as a MRD detection. So we are looking here the prognostic value also as a prognostic value here. Here, how is that completely patient in a remission or patient with a disease, sir? Okay, sir.
But it requires a proper skill.
Yeah.
Flow cyclometry, I mean, it can be done in a laboratory even. Yes.
We come with this flow cyclometry.
Flow cyclometry done by whom? A pathologist or a histopathologist?
Sorry, pathologist.
Pathologist.
Yeah,
And
sir.
here you require a trained histopathologist.
No, there is also hematopathology. That is hematopathologist. Flow cytometry also we are doing in hematology section of pathology. And this
is done in a secondary hospital.
Yes, sir. There is bone marrow aspirate and biopsy is very easy.
Secondary hospital, I'm going to say district hospitals.
Yeah, sir. Bone marrow aspirate and biopsy everywhere is possible. Aspirate smears, that's why I'm telling it is a cost effective. Like flow cytometry is a very costly method and require expertization for an interpretation or like FISH and CGS, these techniques also is a costly methods and require expertization. But these are the like a technologies I'm teaching. They can be do. And
Is it available in all the tertiary level hospitals in the country?
yeah, tertiary hospital also as well as we can use at the district hospital also, sir. District hospitals we can easily use.
Really?
That's why, yes, sir, really.
You have seen that. You have observed that.
Yeah, sir. Initially,
in any of the states.
sir, actually, initially I was a specialist in ESI Gurgaon Hospital, and I was looking this year.
You were in Delhi NCR.
Yeah, I am Delhi NCR.
So outside the states, like say Bihar, UP.
No, sir, I did my MD SMS Jaipur, where also I did my senior in PhD.
Put it in the national view.
Yeah, I didn't get, sir.
See, they are the diagnostic or prognostic guideline by ICMR, whether it can be included there and on what basis.
I tried to, sir, I didn't try it still.
Another thing, how you selected the cases from the MRD? What are the criteria?
So this is the criteria. This clinicians are.
What are the selection criteria of the records?
Sir, this already is completely in a remission, sir. Morphologically.
No, I'm asking you. You have taken the cases which are recorded.
Yes, sir.
So how have you collected from the record? There are many records, but you have selected some. What are the selection
The
criteria?
flow cytometry showing there is a complete absence of these are blast. Patient is completely in remission, and clinicians are sending to recheck. Only check marrows when they are on after induction therapy. 22 days after they are want to check any there is blast in a for a flow cytometry and bone marrow aspirate, sir.
Have you put any selection criteria of the MRD records?
Yes, sir. There is a well defined for in our institute already for the clinical site also and department also. They are using.
I'm asking, there are hundreds of records in leukemia.
Yes.
What are the criteria you have taken?
Inclusion or exclusion criteria?
No, that's what I'm asking.
Okay, sir. We took two groups, sir. Leukemia patient and remission groups. We included some leukemia patients, we included in leukemia group. And in the remission patients, we included in the remission group, sir. I'm telling you.
All the cases of leukemia in that period, which period?
Sir, I told you, we are taking this, sir. See, sir, MRD was considered a 33 days as per BMF 2002 protocols. We are taking as a, they are considered in our department, and we retrospectively take out these patients bone marrow aspirate and biopsy. And we did the scoring of these patients, sir. And another group is the patient which having the group one is that having biopsy and smears of a patient as diagnosed as acute leukemia.
When you study, it's a sample.
Yeah.
It's not a universe. So if you have the sample, what are the criteria, sampling criteria you have?
Sir, such as for sampling, you want to say?
Sampling criteria, particularly or specifically for this study.
Okay, sir.
Yeah.
Yes, okay, ma'am. Like a sample size we calculated, ma'am.
When you are presenting a research work, you have to see what was the sampling method used, what was inclusion, exclusion criteria, all this you should have presented in your presentation.
Okay, ma'am.
That is must. Whenever you are making presentation, you must ensure that.
Sure, ma'am. Sure. Okay.
Okay. Any other question?
Kuch zyada hi ho gaya, sir. Thank you.
Okay. Thank you. Thank you.
May I request Dr. Smita, please? Sorry.
Okay, Dr. Smita Srivastava is a public health professional with almost 20 years of diverse experience in the health sector encompassing clinical medicine, public health, and clinical research domain. She is MBBS graduate with MPH, MA in population studies, PG diploma in hospital and health management. Dr. Smita has been associated with National Health Mission in Delhi and national level for more than decades. She has played a significant role at grassroots level in program implementation, clinical management, healthcare administration. Dr. Smita, please start your presentation.
Thank you so much, sir. So, first of all, good morning to everyone, and I would like to thank. Okay, sir. So, first of all, I would like to thank all the EFICON committee to allow me the opportunity to present the paper, and I'm thankful to the chair and all the respected seniors for being present over here. So my study is titled Reimagining Urban Primary Healthcare Through U-Arms, Insights on City Health Action Plan and Urban Governance. So for the background, I'll just like to mention that unprecedented urbanization has taken place over the last few decades in India, and the same is projected to be approximately 50% by 2050. And as we know, the epidemiological transition is taking place in the entire country and as well as in the urban areas where NCDs are gaining prevalence, and nutritional problems also persist in the urban areas. And under NUHM in 2013, UPHCs had been launched along with the UCHCs for secondary care. And in 2018, Ayushman Arogya Mandirs were established under the Ayushman Bharat scheme for further decentralizing the services closer to the community. And these urban Ayushman Arogya Mandirs, these are facilities at 15 to 20,000 population compared to the UPHCs which were at 50,000 population, urban population. So these basically serve as the urban equivalent of the rural sub-centers, and these are linked with the respective UPHCs as in a hub and spoke model. So the rationale for the study was that the states are facing some challenges in the operationalization of UARMs, and there are significant interstate variations in their capacity to implement as well as in the performance of the UARMs. And even we got to know through the field visits and various other visits that there are gaps in the coordination with the ULBs and the state health departments. So there was a need to assess their functionality and the governance challenges, and which would likely help in informing policy decisions at the national level. So objectives of the study were to primarily to assess the healthcare needs of the urban population, both the slum and the non-slum population, identify the key challenges and analyze those challenges, compare service provision in UARMs with respect to the UPHCs, whether they are a beneficial entity to be started or not, or to strengthen them or integrate them with the UPHCs, assess the coordination between the ULBs, and provide some actionable policy recommendations. So the research questions were also primarily in line with the objectives. So to compare the utilization patterns of UPHCs and UARMs, understand the operational strengths and bottlenecks in the functioning and management of UARMs, to identify the challenges faced at the state level by the administrators, like at the state level as well as the ULB levels, and to evaluate the effectiveness of the coordination between the UARMs and the ULBs. So the methodology, it was a mixed methodology and involving both the qualitative and the quantitative approaches, and basically it was an administrative study, and the duration of the study visits and data collection period was April to July, and it was conducted in 11 states and UTs of India, and purposive sampling was taken to capture the implementation variations. So basically we had divided the states into selected the states based on 3 criteria. Some of the states states did not have any UAMs operationalized, either very low numbers or none at all. At the start of the study, they were Delhi, Bihar, and Uttarakhand. Then states with high operationalization and service utilization of UAMs. So this was Gujarat, Telangana, Assam, and Chandigarh. And the third category was states with strong ULB coordination. So these were Kerala, Odisha, Maharashtra, Gujarat, and Chhattisgarh. So first we analyzed the secondary data, so which was based on the ARM portal of the GOI and the ODK toolkit for the IPHS. So we found that there was significant progress in the rollout of UAMs across states. And at the start of the study, at the start of the secondary data collection, only 52% of the UAMs were operational out of the 12,347 to be operationalized. But by the end of July, it was 92% of the UAMs which had been operationalized nationally, and of these 99% were functional. However, again, the interstate variations were noted, with Tamil Nadu having operationalized all the 100% UAMs sanctioned to them, and Delhi and Bihar were still in the process of operationalizing because of some administrative changes. So, but however, this itself indicated that the states have a robust commitment towards strengthening of the urban primary healthcare through UAMs. And as far as the IPHS baseline assessment is concerned, the ODK toolkit showed that 16% of the UAMs and 11% of the UPSCs scored IPHS compliance score of greater than 80%. And whereas in the aspirant category, it was 23% of the UAMs and 8% of the UPSCs. And rest of the 61% were in the progressive category. So 61% of the UAMs were in the progressive category between 25 to 79% score, and 81% of the UPHCs. So the operationalization status, this I'm just giving an overview. So these were the state-wise numbers. So some of the states have 100% proposed, and some were having, like Uttarakhand had 0% because they were yet in the planning stage. And again, the data shows that 99% of these study states, they had operationalized. So IPHS domain-wise, if we see, then the IPHS domains for the UAM and the UPSC. So there are basically 6 domains in IPHS. So basically, from the service point of view, which I have highlighted in yellow, 28% of the UPSCs, they have services compliant with the IPHS norm that is greater than 80%. And vis-a-vis the UPSCs, which have only 70% score above 80, 7% of the UPSCs have achieved a score of more than 80%. And but however, we see that the UPSC, since they are a pre-established entity, like working since the last 10 years, so they have substantial HR. The HR score and the infrastructure score for the UPSCs was better as compared to the UAMs. And diagnostic and drugs for the UAMs, they were on the lesser side. Like 43% of the UAMs and 25% of the UAMs, they fall in less than 25% category for the drugs and diagnostics. So this is a graphical representation of the same. So, and then if we see the healthcare access and utilization, so basically we found in the field that UAMs have a very important role in complementing the services of the UPHCs. And while the OPD of UAM is almost 50% of that of UPHCs. But the thing is that it was established recently only, like 22, 23 onwards only, and the states are still in the process of establishing. Still, the service delivery, as we saw in the last slide, it was going on in a good pace. And the UPSCs still dominate the RCH services, whereas the NCD care uptake was there more at the UAMs, which was one of the key functions for establishment of UAMs. And the NSS data, it makes us understand that the private sector utilization is still very high in the urban areas at 61% compared to 35% for the public facilities. And from the primary data, we have found that the UAMs are mostly located in the government buildings in several states where the active ULB collaboration is there. So some of the states were like Telangana, Gujarat, Chhattisgarh, and Kerala. But in most of the other study states, they were operating in rental premises. And there were spatial inequalities also. At many places, the mapping has not been done. At some places, they are clustered together, maybe close to the UPSCs. So that kind of thing was also hampering their on-ground functionality. And while most of the states preferred morning shift for the UARMs, which was 8 a.m. to 2 p.m. shift, but in some states like Gujarat, Odisha, and Chhattisgarh, they had dual shifts also. And some operated only in the evening shifts, like in the Mumbai HBT clinics, the Apla Davakhana, and the Kerala UARMs. And overall, if we generally say 8 to 12 was the package range, CPSC package range, which was being provided. And they have reporting mechanism mostly to the UPSC, which was not problematic. And some of the UARMs which are located in the peri-urban areas, there they are reporting to the rural PHCs or even to the rural CHCs at some places like in Chhattisgarh, Bihar, and Telangana. So this is the study status of the UARM. So this I have just depicted for the sake of understanding. So while UARM status I have already told, polyclinics are also there in several states, and so there is a mix of UARMs, UPSCs, and polyclinics. And most of the state-specific initiatives which were there in the states, they have either been discontinued or they have been upgraded into UARMs to provide the comprehensive services. And state level, mostly the state health departments, they are responsible for the policy guidelines, recruitment of the human resources, especially under NHM, provision of drugs and diagnostics, and monitoring of the UARM functionality. And ULBs, wherever they are active, they are providing the infrastructure either in the form of land or buildings. And they also provide logistics. Some places they are providing drugs also. Sanitation services is routinely, it is mostly covered, and occasionally HR also is provided through the ULBs. And good coordination was seen in Gujarat, Kerala, Odisha, and Telangana. And weak coordination was seen in Delhi, Bihar, and Uttarakhand, which was impacting service delivery. So, and also the financial contribution of the ULB was inconsistent. So while it was good in Gujarat, Kerala, Telangana, also in Mumbai and Odisha, but it was not there in Delhi and Bihar. So the role of ULBs, again, this is state-wise depiction of the findings. So municipal land and infrastructure support is mostly provided, but the rest other states, they had other kind of contribution by the UARMs. Like in Odisha, the UARMs, they are also supporting the physiotherapy activities from their own funding, then IEC along with the infrastructure. And in Telangana, they are providing free buildings and electricity and water supply to the UARMs. So they have their own state-specific, they have modified it according to their suitability and the ULB's capacity to provide the funding. But in Delhi, like the fragmented structure was seen, and there was no joint committees, or there was lack on accountability on part of the MCD, and there was no coordination, proper coordination seen between the DHS and the NHM as well as the MCD. So these are again the domain-wise challenges, which is linked to the graph which I had shown earlier. So these are all related to the IPHS domain-wise challenges. So we have to overcome these challenges so that the UARMs operate in a better way. So the strengths of the UARM, which we could understand, was that they are actually bringing services closer to the vulnerable population in most of the study states, and a better community ownership and participation is there. The people living in the vicinity of the facilities as well as the healthcare staff over there, they were saying that the footfall is increasing, and since they are newly established, so they are expecting more footfall as these facilities get stabilized. However, some of the and these are also helpful in reducing the burden of care on the secondary and the tertiary facilities. So a gatekeeping function below the UPSC was also noted. And the bottlenecks were that some of the states did not have the clarity on the operationalization of the UARMs, because the NUHM framework where it is to be included is yet to be finalized and released. And opposed that trainings need to be conducted. And there were difficulty in recruitment of HR, mostly MBBS doctors and lab technicians also were demanded by the states. And rental spaces, they were operating on rental premises, which was a challenging scenario for them because each of the facilities were different, and ensuring IPHS compliance was also difficult for them. And currently these are being funded by PM Abhim and the 15th Finance Commission grants. So financial dependence on these grants were there. So the states as well as the health facilities, they had this apprehension as to how it will continue after the these grants lapse. So from discussion point of view, we understand that the urban slums, they face a lot of factors and risk factors are there and challenges are there related to their socioeconomic class and then environmental hazards and sanitation, poor sanitation, drinking water non-availability and living in crowded places, which is risking their the communicable as well as the non-communicable diseases. So targeted interventions are required closer to these vulnerable populations, and even in the revised framework, it is necessary that we keep the, although it may be made universal, but we need to keep the urban poor and the vulnerable population on priority. And so the UAMs are acting as a vital intervention, and along with the UPSC, both of these facilities, they are the pillars of healthcare for primary healthcare and community healthcare. And but an integrated approach is required where not only clinical care, but also outreach component and the community support through the ASHAs and the MAS is also provided to the community to create better awareness and health seeking behavior. And the significant challenges are there which need to be overcome in the long term to ensure sustainability. And in most of the ULBs, the healthcare remains a lower priority, or they are limiting themselves only to the sanitation work and their core work of garbage collection, water supply, all these kind of things. But health per se, or some of them have health facilities of their own, which they are running through their own drugs, diagnostics, and other support. But otherwise, ULBs, they are not taking that much of ownership. So the recommendations of the study is that regarding the operational and coverage and the operational sustainability, that the urban health system needs to be streamlined with that of rural health system, so that the growing healthcare needs of the urban population are catered to properly. And UAMs are critical for the in this context. Although state-specific flexibility is required and contextual adaptation is required, so that they can plan in their own way, and synchronization of service delivery between the UAMs and the UPSCs, especially with respect to the timings and the kinds of services and the reporting mechanism is required, so that both these facilities are able to provide services in a smooth manner. And now it is time to move from permanent the rental-based infrastructure to rental-based infrastructure to permanent structures. Second is with the more important finding is that with respect to governance and financial sustainability, the ULB should be empowered, and the 3F principle of function, funds, and functionaries, all the three should be institutionalized. Blending finance approach should be maybe one of the options which can be used. And the ULBs, the larger ULBs, they have funds and they can support the smaller ULBs, or some kind of cross-subsidy mechanisms can also be in place, which we have found in 1 or 2 states. And the demarcation of roles between the state and the health department and the ULBs needs to be there. And the most important things is we have a lot of primary healthcare facilities in the public sector, which is the Okay, sir. So City Health Action Plan is one important plan which should be flexible, and differential norms may be adopted for the metro and the non-metro area. So with this, I conclude immediate policy action needs to be taken to address these changes, and so that UAMs, they become cornerstones of the Indian public health system.
Thank you.
Thank you.
Yes, there is one question. What is ULB?
The urban local bodies.
Urban local body.
Yes.
Now, what is the definition of operational and functional?
So operational is when we are setting up the entire facility in such a way that the infrastructure and all the readiness is there, infrastructure, HR, drug diagnostics, everything is functional when they are actually, they start seeing the patients and the patients start visiting. So operationalization, because we have to first establish them and get them operationalized, then the functionality portion starts. So this way we have tried to
operational one. You see our health delivery system is a generalized, graded, referral healthcare delivery system.
Yes, sir.
So is it there referral connectivity?
Yes, sir. Yes, sir. Referral connectivity. Yes, sir. It has to be streamlined, sir. It has to be referral mechanisms.
Give the structure, na? What are the comprehensive health health services?
Yes.
Graded referral.
Yes.
Graded referral means it starts with the pre-hospital.
Yeah. Yes, sir. Yes, sir.
So whether the ambulance services and others, they are
Yeah, it is there, sir. They are stationed near the UPSCs and the UARMs also, and the ambulance services. And whenever it is required, the patients are transferred with the help of ANMs and ASHAs. And the referral mechanism.
I'm asking about the system.
Yes, sir. The system is there, although it is not functional very effectively, and it has.
That's the definition, criteria of operational and functional.
Yes. Yes.
One is the coverage.
Yes.
Then to how many? What are the standard and what it is? Current
Yes.
and
yes.
plan and current. The other is functional and operational definition must be very clear. Otherwise, you cannot say anything.
Yes, sir.
Yes.
Good presentation and effort. What is your criteria for saying that the center is successfully running operational? You have some cutoff or some criteria?
No, ma'am, this was a very new entity. Actually, the funds were being given through 15 Finance Commission and PM Abhim grants. So under NHM officially, they are not there now till the framework is released, and IPHS norms have been established for these. So to call them since they are very new, so it is the reason why some of the states may have not been able to operationalize. At times,
I'm just asking, suppose those who have operationalized, how do you say that they are actually running successfully? These UAMs are where they are running like Telangana, Odisha.
Yes, many states.
How do you say that they are actually functioning well?
Ma'am, we have the HMIS portal where they are reporting. We have the ARM portal.
Some criteria, some cutoff.
No such cutoff is there. The IPHS, ma'am, the IPHS defines.
IPHS is only for infrastructure.
No, ma'am, IPHS is for the 6 domains. Ma'am, IPHS is for the availability of drugs, diagnostics, infrastructure, service. Yes.
Patient load. What is the patient?
Ma'am, patient load, we have.
What is going to actually give you the criteria that it is functioning? It is operational.
Ma'am, IPHS defines the public health facilities into 3 categories. Aspirant, which are like the ideal case scenario is that they achieve greater than 80% in all these domains, 6 domains, which
so how do you get that 80% in a facility which has been just established?
So that is why, ma'am, it was a very low percentage. 26% of the facilities they scored.
So then I'll just end the discussion.
Yes, ma'am.
I think those who have been functioning for a very long time.
Yes, ma'am.
There, I think you can do this study, but those who are coming up new, you are only looking at the infrastructure and the not operationalization exactly, not functional, but just whether it is ready for
whether they what challenge
necessary resources.
What challenges they are facing in getting them operationalized.
Thank you, ma'am. Thank you so much. I think
thank you, sir.
Further discussion we can have during the lunchtime.
Yeah.
Thank you so much.
Thank you. Thank you, sir.
Over cup of tea. Okay.
Thank you.
Okay. Next, I invite Dr. Prasanth, sir. Please come and make a presentation.
Thank you for the opportunity.
Please start.
Yeah, so my topic is understanding implementation issues in maternal death surveillance and response review. Globally, the performance in relating to reduction of maternal mortality has been very low in the first half of the SDG era. If you currently estimated rate of reduction is only 6.2 for India and globally 2.2. What is required is 14.8. Compared to the non-maternal causes, the maternal causes has been reducing, largely relating to access issues and health system strengthening initiatives. Global trends show considerable variation, and this kind of a scenario we see in India also. The inequalities and system strengthening issues within the states, if you aggregate at the national level, you have a different picture, and if you go disaggregated, you will know where the shoe pinches. The primary goal of the study was to see if the primary objective of eliminating preventable maternal mortality by strategically intervening is actually being done by the states. India is signatory to various international agreements, ICPD, World Conference on Women, MDGs, and SDGs. As of now, the country MMR stands at 88 per lakh live births, and which is short of the target of 70 by 2030. Tracing the history of MDR, we could trace it back to the RCH phase 1, continuing to the RCH phase 2. MAPID supported by UNICEF, 2004-5 it started, which has supported the initiative by which the Government of India guidelines came up in 2010, which had components of FBMDSR and CBMDSR. WHO revised its guideline in 2012, changing from MDR to MDSR, and the Government of India guidelines also got revised in 2017 from MDR to MDSR. So the objective of the study was to assess the process of implementation. So the Government of India guideline has defined a process from reporting to review and response. So we try to look at the process followed by the states in terms of its coverage, effectiveness, and timeliness. We also try to look at the factors influencing the reporting and subsequent review, and the perceptions, experiences, and attitudes of healthcare professionals which might have played a role in the implementation. The qualitative study tried to look at in-depth in 3 states based on the burden of MMR, a high burden state Assam, medium Maharashtra, and a better performing state called Kerala was selected. In-depth interviews were conducted with policymakers, stakeholders, and healthcare providers, and focus group discussions with primary informants and the district teams. The inclusion criteria included primary informants, healthcare providers, administrative health officers, who were assigned a role as per the Government of India guidelines. We tried to map the stakeholders and try to see for convergence the extent of involvement by the health department, with the various departments that could be of use in addressing the non-medical causes of death. We also tried to map the resources at the disposal of the state, which will help the state in implementation of the MDR. Human resource and training. So there is a Government of India guideline. The state officers are trained, and subsequently the district and the peripheral officers are trained up to the primary informants. Tools and formats are already given in the guideline. Some of the states have adopted, some of them adapted. Technology and data systems, we have a software in place, and most of the states are utilizing them. Logistical support, the teams which are going to the field, funds are given for their travel, for collecting data. Governance and coordination from the state level, task force is there. At the CMHO level, there is a committee, there is a review by the district collector, and there is a block level team which investigates. Financing resources, NHM supports finances for reporting and review. Largely, the Government of India guidelines were used by the states. Facility-based maternal death review, surveillance and response, community-based surveillance and response, and the confidential review of deaths, basically by the Kerala. Actually, when the guideline was revised, it was the Kerala model that was adopted, which the state continues to do with the support from FOXI. Adequacy and coverage, there has been an issue that we have noticed regarding the classification of death as per ICD classification. So when the 2010 guideline came, it was ICD-9, and in the revised guideline, it was ICD-10, despite the presence of ICD-11 at that point of time. Largely due to training issue, this could be happening, but then the reporting has been a problem. 78.4% of reviews are done by CMHOs and 49% by the district magistrates. It is a task force which generates the state report, which also aids in giving feedback to the district, block, and the peripheral stakeholders, which is not happening in the states. Other than Kerala, where periodically, not annually, periodically some reports is coming and they are used for taking action. We try to look at the 3-delay model and try to map the reasons relating to the 3 different delays. And the social factors, gender issues, while playing a role in delay 2, transportation facilities, management, referral patterns have affected delay 3, and absence of triage systems and immediate response available at the casualties and the departments have caused delay 3 as well. The first one, these are narrations highlighted by the mothers or the husbands of the deceased. They focused on the delay, why the delay has happened. So the gender preference, the male preference, and the second part of it, which says, if you go to a government hospital, there could also be a possibility that they will try to push you for family planning. And then despite the mother is a fourth brother, they did not go to the public hospital. Blood transfusion, and we have to arrange private and incurring out-of-pocket expenditure. And then when normal procedures, normal response do not come from the health system, the patients try to look for other alternatives and end up in trouble. The various recommendations, the key recommendations are just listed here. There is a lot of focus on IEC. There is a requirement to develop culturally appropriate communication protocols, encourage data sharing, decision making involving families, and provide counseling to address refusal of care. There is a requirement to have more appropriate IEC materials distributed to the field, trained peripheral workers, and have a chain of referral established. The triage protocols require a strengthening, lot of training gap is there. And the team-based approaches, it is largely non-existent in any state. So team-based approaches in maternal care, post-discharge follow-up, feedback systems, contingency plans in case of shortage of medicines and equipments, allowing second opinions by institutional mechanisms, and encourage anonymous confidential review of maternal deaths. Thank you very much.
Can you give us the component of the MDSR?
Sir.
What are the spatial components?
Sir, the MDSR, when
I want only components.
the facility-based maternal death surveillance and response, community-based surveillance and response, and the confidential review of maternal deaths. Three components. Yes, sir.
It's not what are the services provided by them?
No, these are the three. For ensuring these three mechanisms and process have been defined.
Can you say that it is successful? What is the requirement and how it is done?
Yeah, so for example, if you take the FPMDSR, the state
events, number of events.
It is not on the number of events, because the number will vary based on because Kerala will have a lesser number, UP will have a larger number.
I'm asking you how the people are accepting that, utilizing it. Services are there. You have said, there are 3 or 4 components are there.
Yeah.
So how from the community, they're availing? What are the percentage?
Yeah, so
target.
The percentage will apply in this context to the number of cases reviewed against reported. So if all cases are reviewed by the CMHO, 100% review is what we are targeting. A percentage of which, this is a decision of the district health unit to bring to
the maternal deaths, requirement is the need is in the community.
Yes, the reporting is from the community as well as for facility.
What is the load? And what is the acceptance? How much the people are being attending the different institutions?
So
what is not the exact, what proportion?
Yeah, so
how many of them are going to the private and how many of them are going to the public?
Yeah, so this has not been a determinant except for the out-of-pocket expenditure, sir. Irrespective of the place they seek care, public or private, if the outcomes are better, it is outcome captured by us.
What about the out-of-pocket money?
Out-of-pocket expenditure is there, but when compared to the death, that will be a consequence.
Because there are studies on that.
Okay.
In all the states you have said, all the studies are there.
Okay.
So attendance in the public, attendance in the private, how much money they have spent individually, and what are the government assistance? Yeah,
so the range of out-of-pocket expenditure in the cases that we have interviewed, 5,000 to 12,000 rupees. Sir. Yes.
Okay, thank you.
Thank you.
We are sort of kind. Thank you.
Thanks.
Yes, ma'am, please.
Dr. Prashant, I think it was a good presentation, and I'd say that ultimately the whole aim is that after maternal death surveillance, we need to improve so that we come down with the maternal mortality. That is important part. But one thing which you really pointed out was that the review by district magistrates was only 48%. The meetings are scheduled every time, but they actually do not happen. So that is another thing, based on this. And we also have to see what was raised by Sir, that how many of the private facility deaths are being reviewed, because we are only focusing on the government part and also, the community part. Community part also I've realized, partners together when we developed this FDSR program, the reports are actually not reported as maternal deaths. They're just reported as death, but not maternal death. So that is why we had tied up with RGI to give us all the deaths, whatever have happened, and we will do the verbal autopsies ourselves so that, this can be, action can be taken and we get a correct number. That is important part. Thank you, but it was nice presentation.
Yeah, Madam, the community-based captures irrespective of the cause, the place of death, whether it happens in transit, in community, public sector, private sector, community-based captures. The percentage of review by the district collector is it's very difficult to interpret. For example, if ideally only those cases which requires convergence and resource allocation, which is at the disposal of the district collector, beyond the health department, should be brought to the attention of the district collector. So 48, we will not be able to say whether it should have been increased or decreased. Maybe 10% is also good enough. If an appropriate due diligence is taken at the district CMHO level, that those cases that requires attention has been brought to his attention, and an outcome when this resource allocation has actually resulted. Yeah. Yeah.
Okay, thank you.
Yeah.
Thank you.
Yes, thanks.
Thank you so much. I would like to thank both the chairperson for chairing this session and giving a very important observation. Thank you, sir, Doctors Farooq and Dr. Singh, sir. Thank you so much.
Thank you, sir.
Next. Can we start the next session? You want to say a few? Okay. Okay, we are starting the next panel session. Again, very important panel discussion. What is the role of artificial intelligence in screening and detection of cervical cancer? I will request Dr. Sunila Gargman and Dr. Madan Gopal, please come. Let's dais. ऐसा करना है?
थोड़ा और इधर कर दीजिए. And we need 5 chairs. हाँ ठीक है बेटा. We need 6 chairs. 6 chairs. All of you come.
आपको तो बीच में बैठना है.
अब आप बैठो बस में. Thank you, Dr. Sood, for really being, for 3 days I'm watching continuously, and you've been taking care of each session so nicely. Thank you so much. That's it. Thank you.
Thank you, Dr. Sood and the organizers for this opportunity. I think after the morning presentations and the discussions, it's a very important thing. And many of the important things happens when people are off guard or they are in between the lunch is staring at that and we are between the lunch and this. Many of the important things happens during that time. In this panel, I would be moderating and Professor Sunila Garg would be chairing the session. And the topic of our panel discussion would be the role of artificial intelligence in screening and early detection of cervical cancer. We have been all focusing on cancer cervix detection, but if you talk about the screening percentage as compared to the Western countries, we do only less than 10% of the screening, whereas in the Western countries, more than 90% screening. And here comes the role how we can utilize AI for doing this screening. And with us today, we would be having 4 eminent panelists. I think Professor Sunila Garg would be introducing the panelists as well as giving her opening remarks.
Thank you so much. I think I'll give pleasure to each one of the panelists to introduce themselves so that they can introduce much better. So I'm Dr. Sunila Garg and I'm Chair of Program Advisory Committee at NIHFW. But spent over 4 decades at Maulana Azad Medical College in the capacity of head and also sub-dean. Thank you so much.
Good morning, everyone. I'm Dr. Rambha Pathak. I'm Dean Academics and Professor and Head Department of Community Medicine at Government Institute of Medical Sciences, Noida.
Good morning, everyone. I am Dr. Ritu Sharma and I am Professor and Head of Obstetrics and Gynecology Department, James Greater Noida, and my area of interest is preventive gynae-oncology. Thank you so much.
Good morning, everyone. I am Dr. Rajiv Dangri. I'm Technical Director, Histopathology and Cytopathology with Dr. Lal Path Labs.
Hello, everyone. My name is Rushabh Mehta, and I am the co-founder and CEO of Identify.bio, and we have built an AI-assisted pap smear screening algorithm.
I'm happy that Dr. Sanjay has also joined because Dr. Sanjay, I'd like to take people to those days when we used to go to Alipur and we had a project in 80s on feasibility of involving existing infrastructure in early detection of precancerous cancer lesion of uterine cervix. And that was looking at the, kind of visual inspection. And we used to look at the agreement levels that doctor ka kya diagnosis hai, worker ka kitna diagnosis and all. But we realized that, that was the only project where we were taking, pap smears and all because it was in project mode. And I still remember amount given by ICMR was quite substantial, 40 lakh rupees. That was important part. But still we could see, despite, Dr. Sanjay and me going to Alipur every day, we were catering to, 20 Anganwadis and no woman would come. So what we did was that in each of the Anganwadis, we put the examination table where the gynecologist will go and people, and the medical officers will go to, so that women will come forward. Despite that, one of our important experiences was that couple of times I realized, in one of the villages, the people will come, the men will come and they'll make the woman get down the examination table. Tum kyun aaye examination ke liye? Kyunki ye tha ki if we are going to diagnose a woman, her treatment and her partner's treatment also will be done. But today we are in era, and that was a time when cervical cancer named as was number 1 cancer. You see, when we talk of in women, and today when we talk of it is at number 2 position, but nonetheless, a very substantial number of women are there. And since every woman is not coming for diagnosis, which we are going to discuss now, and it is going to be of great importance to our rural and urban centers. Dr. Gamba is here and the team is there from Identify.bio. And so that, we can pick up, we can do as many pap smears as possible. And with the help of artificial intelligence, we can detect because we have shortage of manpower. We all realize that. And also we know that, to have the figures, we have got approximately 1,27,526 new cases approximately every year. And also 79, nearly 80,000 deaths are there. But important part is it is a late stage diagnosis and there are regional disparities. What is going to happen in Delhi or what was happening as was told in the earlier presentation, what happens in different states, with regard to urban health centers, rural centers, or with the population, things are very, very different. But barriers to early detection are quite, important to know, and where each one of our community medicine people have got a very, very important role to play. Not every center, Mahatma Gandhi Institute of Medical Sciences at GOPD or AIMS has got Vallabhgarh. So we can create a lot of awareness. Or, JIMS has got close by urban and rural center, but still there is lack of awareness and education. And basically with regard to the risk factors, and we also know that the people do not know that what are the benefits of early screening. That is important. And we do have a lot of socio-cultural factors and stigma. As I said, that the men were bringing down women from the examination table to QA examination ke liye. So because it carried a stigma, examination karana means there is going to be something which is going to come out and you are going to be detected. Similarly, I am going to be penalized. That part is important. And we also see that because majority of the women are, for them, vaginal discharge is something very normal, so they do not perceive it as abnormal. So there is a culture of silence. So that part is very important. And also financial constraints are there. Plus, we also know that at many parts there is geographical inaccessibility and lack of health insurance also, because everybody does not, go to the government facility, and we still have realized that out-of-pocket expenditure is very high. But, still, looking at this, we have huge human resources challenges. There is shortage of trained professionals when we look at, and basically this shortage of trained professionals, including, when we talk about, it's not only doctors, it's nurse. Nurse can also take a pap smear. She can also do a, swab. So that's like few of you would have learned that recently some of the projects are talking on empowerment of the women to collect the swabs themselves, so which can be examined, in the healthcare facility. And then there is also kaun padega unko, technician kahan hai hamare paas mein, so that is important. And then also whosoever are there, are they adequately trained? That part is very important. And there is inadequate training and awareness amongst the providers, and many of the healthcare providers, they themselves lack sufficient knowledge, and there is no consistent training. That part becomes another important. There is a provider's bias and communication gap is there. And some healthcare providers, they hold cultural misconceptions and biases which are linked to screening, particularly which is regard to sexual activity, which affects their communication and recommendation of services. And workforce motivation. How many of us, when we go to the healthcare facility, are there that there are 20 women jinko internally humne examine karna hai, those who have come for property insertion, should I examine, should I take their swabs and do the examination? So we are all demotivated. That part is also important. And I also took up this subject with my own institution, that particularly when so many women are coming, this is the best opportunity. They're coming themselves. Why don't we take their smears and examine, so that this is a ready-made material, like that we can expand to several healthcare facilities. So also we do have fragmented cancer care continuum also, because of the disruption in, healthcare system referrals, which was already discussed in the previous time. So, looking at all this, do we have come out with a solution where in a short time, people can, whatever smears are collected, they can be read fast. The results can be communicated fast to the people, so that we start with early diagnosis and management. And since wherever it is happening, we are taking, the pap smears and all that, that part is important. So we have to see that, how we can go ahead in this direction and make use of artificial intelligence. In VIA, it is being used to some extent, and some of the projects are coming in this direction. So let's go further and have a discussion. And I request Dr. Madan to interact with all our panelists, so that we can come out with necessary, some of the challenges and what could be the possible solutions. For your information, JIMS Noida is taking up a pilot project in this direction in their rural and urban centers. And for that, whatever slides they have already got, that means 3,000 approximately pap smears they have got, they're going to validate that against the software. What all how much is the detection rate? Are we able to detect much more than what is already there? It is much better to over detect and then treat the not cancers, but also BV, TB, Candida. That means bacterial vaginosis, trichomoniasis, and candidiasis. We are also interested in treating the infections. Thank you so much.
Thank you, Professor Garg, for setting up the contest In fact, we have a very esteemed panel. Bringing in the public health lens would be Professor Brahma Pathak. Bringing the clinical perspective would be Professor Ritu Sharma. And from the histopathology and laboratory perspective, we have Dr. Rajiv Tangri from the labs. And the use of technology for assisting all of us, all the three parameters would be Rishabh Mehta, who is the AI developer for this. I think we have heard Dr. Ramba. The first question is for you. We have heard Professor and I also, in my opening, mentioned that we do have a low screening percentage, though a lot of effort is going from Government of India side. And a lot of efforts are being made to push people for screening. AI training is happening. But uptake is not there. What are the barriers and challenges? Professor Garg has also mentioned about the social barriers. Already one or two aspects he has given. What else, so from a public health lens point of view? So what are the social barriers for hampering this screening process?
To answer this question, I'd like to answer this question with my own personal experience of implementing this program in our urban and rural health training center. What we started was with the help of NGO, we tried to implement screening program for cervical cancer, and we found that none of the women, like whatever we say, the previous day, these people, field workers will go, motivate them, will inform them that the team will be coming tomorrow, and next day, we will be getting only 5% or 10% of the people. Then we tried to find out the root of the problem. We identified that these workers who were going to motivate community, they were themselves not motivated. So the program that we started was, first of all these ANMs, health workers, the field workers who are there, and ASHA workers, they will be screened first, and when we will be able to motivate them enough, then we will go to the community. And that actually worked. Because when we conducted training program for them, and then we conducted their screening. So after their screening, they went to community and they could tell them with confidence that yes, it is very easy and you will get to know your condition and your status and you will be provided treatment straight away. So this was something which was needed. So we say that there is less of awareness in the community. But it is not only that the community is not aware, even our workers, our field workers are not aware that these things can be, they know from knowledge point of view. But when it comes to attitude and practice, actually doing it, till they do it themselves, they will not be able to share their personal experiences with the community. This is what we felt when we implemented this program. And now it is successfully happening. And what I would say that the other barriers other than awareness is basically definitely social and cultural barriers, because females, they would not like to go and get examined by a male doctor. So that shyness that is there. And even like if we ask them to come to hospital, if we say that, okay, you come to gyms and get yourself screened, they will not prefer, because then they are daily wages, they may be losing that, then they have some household responsibilities too, for which they will definitely not like to unnecessarily get themselves screened for something that they are actually not suffering from. So these things, these problems are there. And not only that, there was one more problem that we identified. Whatever slides which were prepared in the field, when we examined those slides, many of those were like commented by pathology department that these were inadequate. So they could not give any result on that. Now, that lady whom we brought for screening, if she doesn't get her report, why do you think that she will recommend others to come for that screening? So these problems are there, and that's why we are looking for a solution with the help of artificial intelligence. That is it possible that we are able to provide them some solution at the point of care, wherever she is coming for screening, we want to provide them at least some idea that whether she is having the problem or not. Further, the diagnostic part can be taken up at Madam's OPD. But before that, before she reaches her OPD, we want her to, get some idea whether she is suffering from the problem or not. And there we are looking, like we are trying to take help of artificial intelligence, whether that can help us in the field in bringing up the numbers. So these are the things that.
Thank you. Actually, beautifully captured about the public health lens. But Professor Sharma, you are a clinical practitioner. You have been already screening a lot of people with cervical cancer. What is your experience about the patient acceptance, the screening of the patient in case of any abnormal results? What is the follow-up? Is there any follow-up happening with the patients or not? And what is the reluctance of these patients coming to you and talking about their cervical screening patterns and other follow-up things?
Yes, sir. Sir, actually, there are so many challenges as far as the clinical perspective is concerned. Whenever the patient comes to the OPD, usually we all know, as ma'am has already discussed, that the people, the women, they don't come forward for screening. And once they are visiting the hospital, actually they are coming for some other complaints and they don't come to the hospital exclusively for screening purpose. So we as clinician, we are offering them the opportunistic screening. But even the uptake of this opportunistic screening is very, very low. And the main challenge is that, which I personally feel, is that in the OPD, we are running a cancer screening clinic. And that cancer word is a stigma for the patient itself. हम वो run कर रहे हैं, but once the patient reads that cancer, she hesitates to enter into that screening room. And I personally believe that that terminology needs to be replaced with a better acceptable terminology like the women healthcare clinic, where we may be providing these screening facilities, which may be incorporated in a comprehensive health package. One thing is that. Second is that there are other challenges which are related to the provider as well as the person or the place and the policy of my hospital. If I am concerned with that screening purpose, the patients themselves, as ma'am has said, if the patient turns out to be positive, what next? The patient is apprehensive about that. If in my institute, if the screening test turns out to be positive and I don't have further facilities available at my institute only, then it is a big question whether I should go for this screening and what is to be, what the patient is going to be counseled further, what next step she has to take. That is one thing. Also, in most of these centers, as far as the provider related missed follow-ups, I think in my setup, there is no digital platform available, electronic database is not available. We are manually keeping the records, and there is a possibility of missing data as well. And so the follow-up visits, they are being they are not scheduled as they should have been. So we are getting the missed data as well. And as far as the provider related challenges are concerned, most of the institutes, they are having a shortage of the dedicated counselors in the OPD. In my OPD, I am having a counselor related to the antenatal care, the family welfare program, but there is no dedicated counselor available as far as the cervical cancer screening is concerned. So that is a big issue. Also, there is shortage of the cytopathologists and the colposcopists in any institute who, if they are available, they are overburdened. Then, as ma'am has discussed, we are getting the pap smears done, and then we are getting the results as the pap smear is inadequate. This is being happening in institute level as well. So, because all these collection of the sample, preparation of the smears, they are operator dependent, and if they are not efficient enough, this is going to be an issue further. So then related to the infrastructure, if I talk about my institute only, it is a tertiary care institute. HPV testing, as we all say, that is the primary recommended modality for all levels of resource settings. But that facility is not available in most of the institutes. And coming to the pap smear and wire, then again, the availability of the reagents and the availability of the equipments like the colposcope remains an issue. Quality assurance remains an issue. Then at the policy level, if I go again, we have started now. No doubt, we have started at our institute a preventive preventive oncology clinic. Again, the dedicated gynae oncology clinic, the dedicated cancer screening clinic remains dream, because the other national programs like the maternal and child health and the infectious diseases programs, they surpass these issues, and the cervical cancer screening takes a back seat, and we as clinicians, we are being overburdened in our OPDs with these clinical priorities, and at times we ourselves are not offering the opportunistic screening to the patients as well. So we have to take all these things into consideration for improving the cervical cancer screening overall. Thank you so much, sir.
Professor Sharma, for elaborating all these things. Dr. Raji, you are at the helm of affairs at one of the busiest laboratories, and you know about the workload, and you know about the complexities of this pap smear, which Dr. Ramba has already mentioned, inadequate sample or the sample claims. And what are the challenges which you are seeing working at the lab in detecting this with the cytology and other aspects?
Thank you, sir. So, as everyone has mentioned already, that there are a lot of unsatisfactory smears. Now, why are the smears unsatisfactory? Probably the transitional zone has not been sampled properly. The person who is taking the smears is not taking the smears properly, is not reaching the transformation zone. But when we are reporting, we need a minimum number of cells as per Bethesda 2014 guidelines to report the cases. So if the number of cells, the squamous cells is less than that, we will call it unsatisfactory. So that is one of the big pre-analytical challenges. Of course, there are many more challenges. I mean, one is a non-availability of the trained manpower. In Western countries, there is a concept of cytotechnologists. They are the screeners who screen all the pap smears before the cases or the cases which are of interest are put up to the pathologist or senior pathologist before being reported out. Now in India, I know of only one large government center where cytotechnologists are available. Apart from that, I am not aware. I mean, there may be one or two handful centers where cytotechnologists are available, but rest everywhere, the reporting, even the primary screening is being done by the pathologist. Now, pathologists, and the screening of pap smear is a laborious task. It takes, one smear can take 5 to 10 minutes. A conventional smear can take even more time. If there are some abnormal findings, maybe 5 or 10 minutes extra. So one person in the entire day cannot report more than 30 to 40 cases. In the camps, we get thousands of cases every day. So there is lot of delay in turnaround time. Lot of people they get reports even after months once the smear is taken. So results are coming to them after a long gap. That is one of the big challenges. There are, of course, there are analytical challenges also. When screening, we may screen such large number of cases, we may miss out on the findings which are very subtle. Differentiating between ASCRS, LCIL from reactive changes is sometimes very difficult. Sometimes if there are very few HCIL or malignant epithelial cells, people who are screening very quickly may miss out on those things. So those are the challenges that we regularly face. CAP and NABL, they also recommend that whatever negative cases are reported, there is rescreening of all those cases. A subset of cases, at least 10% of those cases, must be rescreened by senior pathologists so that we don't miss out on any findings. That rescreening hardly any lab does because, again, shortage of manpower, shortage of time, pressure of turnaround time. So these are the challenges that we usually face in our laboratories. And I feel artificial intelligence is one thing that can clearly and very easily handle all these challenges.
Thank you, Rajiv. I think we would be all wondering what is this AI in cytology, because many of the people in the audience would be thinking, I think Rishabh, this question is for you. Many of the people in the audience would be thinking what AI in cytology is. What are the future prospects about this and how it can be used and helpful for all of you?
Right, sir. So that's a very important question, and thank you so much. Just to break down, this AI in cytology, what it is. And like Dr. Tangri mentioned about the cytotechnologists, this algorithm in a way is a digital cytotechnologist, which is able to look at the entire pap smear. The algorithm has been trained using lakhs and lakhs of specimens of pap smears and single cell annotations, and is being able to understand the difference between a positive cell and a negative cell. And it looks at the same morphological features that a cytotechnologist would look at, which is the nuclear cytoplasm ratio, irregular findings on the nucleus. It's also able to detect various types of microorganisms that are present on the slide. And really what it does is it presents these findings for the pathologist. So the AI the algorithm itself in no way is intended to make any diagnosis, but rather assist the cytotechnicians and the cytopathologists in their work that they are doing.
Sure, because I've been asked by the organizers saying that the time is short, but only very quick question, very short answer. So give your answer from the specialties from where you are coming. How do you see AI, future of AI in public health, in the clinical side, in the laboratories? And Rishabh, how we can be implementing that? Very quick answers so that then I can request Professor Sunila to sum up in this, please. Orders are same order will be followed.
Like what we have started doing in gyms, because I will talk of my institute where we have medical incubation center. So the first thing that we did was we started with validation of smart stool, which is being used, and whatever, like where I will say that Dr. Ritu is PI in that, and we are using it in field to see whether we are able to detect screen cervical cancer. Not only that, we also want to validate the tool that has been developed for pap smear by Rishabh's company. So this is something that needs validation. This is a new thing that has come up, and we have to validate in our setting and see to what extent we are actually able to implement. What is the feasibility of its implementation in our setting? That is what needs to be done. So this is what I would request all the institutes to carry it out in their setting, so that we have enough data from Indian scenario that we are able to do it, because there are many challenges which we are going to face. This is a new thing that has come up. There is lack of training, there is lack of infrastructure which we will require. So what will be the feasibility, cost, effectiveness, all those needs to be studied. So I would request all the institutes, most of those who can do it, to go for it, so that we have our own data to back up this. Thank you.
As ma'am has already said that we are using smart scope, and from my experience, I can tell you that we are looking for the agreement between the instant results which are provided by the smart scope and the interpretation by the specialist gynecologist using the colposcopy. And I have found that there is a good agreement between the two, and this has also improved the confidence among the residents who are using this smart scope, and my nursing staff who are using this smart scope in the OPD, and this has automatically reduced. This is still in the research phase, but I am sure that this is going to reduce the burden on the colposcopist. And also it has a positive factor that it has improved the compliance of the patient, because it gives you a visual indicator. It gives you the images of the cervix, and it also gives the this report in the form of the colors, that is the red, amber or the green color, and the patient is counseled, and she is satisfied once the color shows the green color, and she goes for the routine screening schedule. And once the color is amber and or the red, she goes for the next step of the screening. So this is very good as far as the patient compliance is concerned. Yeah.
Telegynecology. This is what we are basically looking for, because then gynecologists can be sent from the center to the hospital, tertiary care hospital, and then she can advise them and ask them to refer here so that they can further treat the patient.
Looks very promising, I think, Dr.
This can improve the capacity building of this patient.
Dr. Rajiv, they are saying about telepathology.
Yes.
that comes to you. How you see
Yeah,
that?
so actually AI, I mean, is a very good triaging tool. We are using it for last 5 years or so at our laboratory. And I would say for the patients who are in the camp, using AI, they can at least get immediate results that their smears are negative. I mean, all we have to do is we have to tell them that your smear is negative or there is some finding. That finding, what the finding is, what is the exact interpretation that can come later on. But at least 70, 80, 90% of the patients who are negative, they can be relieved immediately using AI tools, which can triage all the negative cases and positive cases. Then that can then go to the senior pathologist who can spend some more time on those and give out the actual reports. And those will need follow-up also. Okay. But at least the negative cases can be screened out and can be relieved immediately from the campsite directly.
Sure, we have heard about the utility of this. How to scale this up?
No, definitely. That's a great question. So as we've seen, I think one of the biggest utilities is in addressing the manpower shortage and the very tedious repetitive tasks. In terms of scaling, what we have done at Identified Bio is built a very asset-light, low-cost model. Using Indian data has been used to train this algorithm, which is now being piloted globally. And so each hospital needs to get some infrastructure for slide scanner. The cost of these slide scanners now has come down tremendously from where it was even 3 to 4 years ago. And once the lab has that, then there's a lot of these type of tools that one would be able to take advantage of very quickly in a very cost efficient manner. And it can also over time, once it's used at scale, bring down the total cost of operations as compared to without using these tools.
These scanners, they are, I mean, the Indian made scanners, they're very small scanners, just one slide scanner. You can even take those to the camps. So those are now available.
Okay, thank you. Thank you, all of the panelists, Dr. Ramba, Dr. Sharma, Rajiv, and Rishabh. I think now time has come to close this panel, and we request our chair, Professor.
Thank you so much. And my first and important, I think, comment will be that since all of us are sitting in this room and majority of us go to rural and urban centers, how many of my female colleagues, male colleagues will come later? Are you doing internal examination and are taking, samples, smears and all that? Because that is the first thing from where our hesitancy will go away. Because we say that karat karat abhyas se jadmati hot sujan. So each one of us becomes wiser. Your quality of smears, which has been talked about, all are going to improve. Then comes the role of, your future learning in terms of when we talk about, the scopes which are going to diagnose very early. So we should not limit ourselves only to this collection of the smears, the quality of smears and all that, or creating awareness. That part is very important. But we have to go further, that what happened further. Because through this telepathology, further we can learn that and we can communicate to the patient. That part is important. So agreements between all these levels is very, very important. So I feel that, this is the time when we talked about, lot of projects are coming to ICMR about women collecting the swabs themselves. But first is let us all do the collection of swabs ourselves. Women empowerment will definitely come by themselves. But important part is at each urban center, rural center, internal examination has to be carried out. The smears have got to be collected over a period of time. They can comment upon that quality of smears is going to be better. So that is one of the important things. And I'll say that, now artificial intelligence is the need of the hour. Considering our 148 crore population, and then we say that 20% of the women of the reproductive age group, we have to focus on this direction. Please do not hesitate and go forward and implement this. Thank you so much.
Thank you. Thank you. Thank you.
Thank you so much. Now we are having another interesting session on HIV Sentinel Surveillance Plus 2026 in India. And it is my privilege to introduce the distinguished speaker for this session, Dr. Sanjay Rai. You know him, he is a distinguished professor at the Center for Community Medicine. And he is also editor of the WHO Southeast Asia Journal of Public Health and president of the National Medical Association. He has been the member of the High Power Committee for National Health Mission and various committees of ICMR, more than 50 projects. And he is one of the key person who has made very useful contribution in HIV/AIDS as well as the National Control Program for tuberculosis and immunization. And if you remember, during COVID pandemic, he was the nodal person for evaluation clinical trials of the COVID vaccine. And sir, we are really happy to have you in this session. So over to you for HIV Sentinel Surveillance Plus 2026.
Thank you, sir. Thank you very much. So just before lunch, and between dinner and lunch, so I'll try to finish next 30 minutes time. This has been allocated to me. So good afternoon, all the dignitaries here, delegates, my faculty colleagues, ladies and gentlemen. First of all, I would like to thank organizers, especially Dr. Kapil, Dr. Pradeep, for having me for this important session, HIV Central Surveillance in India. So I'll try to focus on 30 minutes as I mentioned. So we are aware, majority of us are aware India has the third largest number of people living with HIV globally. So the current number is approximately 25 lakh. Any guess other two countries above us in terms of number? In terms of prevalence, there are many countries, but because of our population base, in terms of number, we are the third. Still, so South Africa is number one with approximately 9.2 million cases, and then the second one is here, Kenya. Now, Nigeria, now Kenya. It's around 7.2 million. So we at 2.5 million number of cases, we are 3. So our HIV epidemic is concentrated, not the generalized epidemic. Concentrated means epidemic is concentrated in a particular group, not in the entire population. And that's why the prevalence is 0.21. So concentrate, and that groups we call high risk group and then your best population. High risk group in our country, the best population group, panel sex worker, sex within, and IV drug users. We consider them as a high risk group. So this is concentrated in that particular group. We also call them the key population group. And then from these key population groups, HIV travel to general population, this population, you can see this population, several main migrant and the long distance truckers. So, as per the estimate, the adult prevalence is around 0.2, slightly higher in the female. The number of people living with HIV in this country are approximately 25 lakhs. The HIV incidence per 1,000 uninfected population, if you see, it's 0.05, that means 5 per lakh. So in cases per lakh population, we are reporting 5 more cases per day. Although there is a decline, but still we are reporting 5 cases, and again slightly more than so number of new infection in terms of because of this incidence, the new infection per year is above 15 years of age is approximately 66,000. So annual deaths, although there is approximately 50% decline on the new annual cases if you compare with the 2010 data, but still we are not up to mark. If you want to control HIV as a public health problem by 2030, which is the SDG target also, then we must take some more action. So this is the current status. I mentioned earlier, so approximately 66,000 new cases per annum. Then your annual AIDS-related deaths, almost 39,000 deaths per annum. This is the trend of HIV prevalence. So we had peak during 98, 99, and then there is a gradual decline. So this is the prevalence of HIV. So during the time we had approximately 0.6, and now we have 0.2. The prevalence is. The trends of AIDS-related death. So we started ART from 2004 onwards. So we had sharp decline in the AIDS-related death after that. So average life expectancy before 2004 was approximately 10 years. Now it's just like any chronic disease like your hypertension, diabetes, lifeline you can take medicine and you can survive. So now it's a sharp decline after this introduction of ART to the general population. So number of annual new infection I have already discussed. The state and wise prevalence, if you see, there are 16 states. So the country prevalence is 0.2. So there are 16 states. They have prevalence is more than the national average, that is 0.2. And Mizoram, Nagaland, and Manipur, and they are at the top. These two, Nagaland and Mizoram, the prevalence is more than 1%. So there's some milestone. In 1985, we started HIV surveillance. So the surveillance program was started in 85 by ICMR, but that was a lab-based surveillance. And soon after, when we started this lab-based surveillance, we detected our first case. That was in 1986 from the Chennai. So India detected the first case in 1986. Then in Ministry HIV AIDS cell was set up. Then National AIDS Control Program, phase 1, phase 2, phase 3, phase 4, phase 5. Currently we are in the phase 5, and very soon we are going to launch phase 6. So the current phase is from 2021 to 2036. Now coming to, so we started HIV sentinel surveillance. Finally, NACO launched this HIV sentinel surveillance in 1998. Surveillance started in 1985, but HIV sentinel finally. Before 1998, in 1994, a piloting was done. So surveillance, HIV sentinel surveillance was started in 94, but NACO finally launched in 1998. So in that piloting, we had a total 52 sites, but when they finally launched this in 1998, that time we had 176 sites, and out of 170 sites, 92 were NC sites. We have currently had 8 population group for this China central service. I will discuss later this. So our HIV epidemic pattern is monitored through HIV sentinel surveillance among various population group, high risk group, mass population, and prison and general population. So high risk group, I already mentioned these 4 groups are high risk group, MSM, transgender, and also your IV drug users. high risk, so 4 high risk group plus general population. We take proxy for the general population, antenatal clinics. So antenatal attendee as a proxy for the general population, and then prison. So in prison also around 67 central prisons we are conducting HIV central surveillance, and to these population, long distance truck drivers and your single male migrants. So these are 8 population group we are conducting HIV central surveillance in right. So just we all know what is the surveillance, what is the sentinel surveillance. So a system of monitoring HIV epidemic among a specified population group by collecting information on HIV from designated sites. And we call these designated sites sentinel sites. For high-risk group, we have sentinel sites. For this population, we have sentinel sites. For general population as a proxy, so NC clinic, these are the sentinel sites. So the objective of our HIV central surveillance program is to monitor the process of HIV infection over the time. We use data to estimate the burden of the HIV through modeling, not as it is data we are not using, but modeling, we are using a spectrum model. So for burden, so even if we are calculating incidence, to get modeling. Then to monitor the distribution and spread of HIV prevalence in different population subgroup and in different geographical area, to identify emerging pockets of HIV epidemic in this country, and to monitor the progress of HIV cascade prevention in the country. So these are the objectives of HIV central surveillance program. Important application of our HIV central surveillance program to estimate and project burden of HIV at state and national level. Now, since last 2 years, now we are projecting even at the state level, at district level burden. So we just published the district burden estimate also. And another use is to support program prioritization and resource allocation, and based on the burden of the HIV in that particular geographical area, to assist evaluation of the program impact. And for definitely for the advocacy, we are having the HIV central surveillance data. So this is the epidemiological basis of the HIV surveillance. As I mentioned earlier, it's a concentrated epidemic. So concentrated in a high-risk group. So from high-risk group, it travels to the general population through your this population. So male clients, and then through the spouse partner of the female. So it's travel from a concentrated population to general population through this population. So this is the epidemic pattern in our country. So they are the drivers of the epidemic. So this is the overall organogram of HIV central surveillance in this country. This is the current organogram. The National AIDS Control Organization is the nodal agency for the policy, for strategy and planning of the all HIV AIDS related control strategies. Then All India Institute of New Delhi is the nodal agency for coordination at the national level. So so faculty member and Center for Community Medicine aims as the coordinating agency from the CCM, the focal person for HIV central surveillance, and then Dr. Puneet Misra, Dr. Rakesh, and Dr. Partha. The faculty members from my department, they are part of this HIV central surveillance. And then you have the various project staff for this HIV central surveillance activity in this country. So under AIMS New Delhi as a nodal agency, we have central team members. Many central team members are here. Dr. Nubhata Bhattacharya is here. A few years ago, she was the nodal person for this. So many faculty members are from the, so around 30 to 35 faculty members from the various medical institutions, they are the central team member. And for the overall supervision in this country. Then we have the regional institute, 8 regional institute. and then a reference laboratory. For HIV testing during surveillance period, although we have this facility even at the district level, but we are not using the district laboratories for this. We have the medical institution laboratory, our government institution laboratory. So only state reference laboratory we are using during the surveillance period for the HIV sentinel surveillance. So not all the laboratories. Like in Delhi, Subdivisional Hospital is that this our for our state reference laboratory for HIV surveillance. So all the samples from all over Delhi, we collect here and the HIV testing done here only. For UP, like Institute of Medicine, Banaras University, Biomedical College, KGMC, so Aligarh Muslim University. So these are the centers for our HIV testing, not all the. And then we have so we divided entire country into the 8 regions, and these are the 8 regional institutes. They are responsible for a few states allocated to them. These are the states, like these are the 8 regional institutes. Chandigarh, so Chandigarh, Haryana, Himachal Pradesh, Jammu, Kashmir, and Ladakh, Punjab, they are the best. So they are monitoring, they are providing technical support to state AIDS control society. So PJ Chandigarh is responsible for these states. Then AIMS New Delhi, we are the nodal agency for the entire country as a national institute. As a regional institute also, we are providing technical support to Bihar, Delhi, Jharkhand, Uttarakhand, and Uttar Pradesh. 5 states. Jodhpur is also part of our this network, regional institute network. Rajasthan and Madhya Pradesh, these 2 states are attached to AIMS Jodhpur, ICMR network. Pune, the population is Bali. So Daman, Goa, Gujarat and Maharashtra, they are responsible for this. NIH, Karnataka, Kerala, Telangana, Puducherry, Bhubaneswar, Andhra Pradesh, Chhattisgarh, Odisha, Kolkata, Andaman and Nicobar, Meghalaya, Nagaland, Sikkim, and West Bengal, and then RIMS in fall. Arunachal Pradesh, Assam, Manipur, Mizoram, and Tripura. So these 8 regional institutes don't provide you technical support to the entire country through the states attached to them. These are the case definition. I don't think time for the surveillance purpose. So case definition for each and every group, like common sex worker, male sex worker, injecting drug user, gender, single male migrant, what do you mean by a single migrant, long distance trucker, like not all truckers are part of our surveillance program. Only long distance truckers. We assume that because of their nature of work, at a greater risk than the other truckers. So if for our surveillance purpose, we are not including all truckers or all drivers, only the long distance truckers, those who are traveling more than 800 kilometers. So these are the various definitions. So just on the methodology. So for I mentioned earlier, we have 8 population group for HIV central surveillance. So for ANC, setting is from the ANC clinic. As I mentioned earlier, ANC is a proxy indicator for our general population. So the sample size is 400. So almost all district hospitals of this country under our surveillance network. So we collect sample usually from January to March, these 400 samples. There are various criteria. You can ask question and that time I can discuss. The methodology is consecutive sampling. We cannot collect more than 20 samples in a particular day to maintain the quality. There are approximately 20 questions related to demography, etc., and other characteristics. And we are testing for the 4 biomarker: HIV, syphilis, hepatitis B, and hepatitis C. And our HIV central surveillance. Business. Currently, we are only including central prison only, not all prisons of this country. There are total 67 prisons. Sample size again 400. Method is your random sampling method. We have the sampling frame. We know in NC we don't know who will come on that particular day. But for that we have a sampling frame. So we asked all the prison key candidates share this your list of all the prisoners, and then we do random sampling. Then we share this random sample list to the prison, and then we collect this. So the method is random sampling. 32 questions. In this, we have some high risk questions also. The specimen is serum, and again we test for this for biomarker. Then the migrant, the single migrant truckers. So for high risk group and for this population, the sample size is 250. For truckers and single male migrant, the sampling strategy is consecutive sampling. For other four groups, again with the same principle we apply here also. We have the sampling frame, total number of individuals registered with a particular targeted intervention project partner. So TI is our NGO partner. So we give the total number of high risk group individual female sex worker with that attached to that particular. So we do random sampling, and again this is the way. So there are various questions related to demography, other characteristics, social characteristics, and also related to here. So we have questions in 41, 42, 45. So in various here, it's not the serum sample, it's a DBS, dry blood spot. So we collect on the DBS card, drop of the dry blood spot, and except syphilis, for other three biomarkers like HIV, hepatitis B, and hepatitis, we are testing. So you see the evolution of our Chinese central surveillance program in this country. We started with 176 sites out of 176 and 1988. So the current round is your 19th round. In 19th round, we had more than 1,500 sites. Out of these 1,500 sites, 908 are NC sites, 67 are prison sites, and approximately 700 are high risk and population side. We are going to start from the 1st of January 2026. So we just completed our training program for this country. So again, for the expansion of the charge sites, as in our country, it's concentrated. So our focus is to cover this high risk group population as much as possible. So we started with only 6 sites in 1990. Now we are around approximately 700 sites. This is 2024 data, 24 data 605. In 26, we have approximately 705 sites, charge sites. So see the prevalence and typology as for a high risk group. I think we have the highest prevalence 9, followed by STG and MSM, and then FSW, migrants, and then truckers. So adult prevalence. Now I'm talking about the based on our HIV central surveillance data, the prevalence, ANC prevalence. I have only 2-3 more slides. So see the in ANC the overall prevalence is 0.23%. So prevalence is 0.23, and there are 12 states above this. And again, Nagaland, they are have the maximum NC prevalence. For prison also, in prison, if you see the overall prevalence is more than 1. So overall, let's say approximately 2. Again, there are states where we have very high prevalence in these prison inmates, like Mizoram, 21. Punjab 9.25, and in these 2 states, it's mainly the epidemic is driven by the users. So then, when we collect data for HIV sensitive service, we use for the estimation purpose. Directly, we are not using. So we use a model we call spectrum. has developed this model. So use various data in this spectrum, like your demographic data, statistics data, epidemiology patterns, surveillance and survey data like NFSS data. So we use all the data sets for the modeling purpose. And then the project, suppose we use 2011 census data and then we project for the current level. So for demography, we are using data and projecting for the current level. So in that model, we are using so these are the input for the our model. So based on this input, then we generate estimate at the national level, at the state level, and now we are generating at the district level also. So we are monitoring and see. If you are including only district hospitals, so there are a lot of limitations. It's not the district hospital population that like for NC. It's not the representative of the entire population of that district. Many private hospitals that and population is different. So there are some limitation of this service, but even if you can monitor the trend, assuming that for every year the same type of population will attend the clinic, district hospital clinic. So for monitoring directly we can use. For estimation purpose, we cannot use directly the data. So through modeling for the entire district we are using, so that model is spectrum model. So in summary, India has the third largest number of people living with HIV globally, approximately 2.5 lakh. Its HIV epidemic is concentrated in a particular group. Still, we are in that phase one. It's not a generalized type epidemic. We call it general epidemic when the illness is in the general population. Still, in our country, the drivers of the epidemic are in protected sex with various high-risk group and injecting drug use. And our Chinese internal surveillance data is one of the important data. So it's a cornerstone of evidence-based HIV response. So why we are doing this surveillance? To keep everybody free from illness. So survey one to Sukina. Thank you, everybody. Thank you very much. If you have any question. Question नहीं तो ठीक है. Thank you very much.
Excellent presentation. I have a small query.
Yes, sir.
We'll talk in the tea time. ये जो आप ब्लड स्पॉट लेते हो, HBV वगैरह का जो सर्वे करते हो, इसका डाटा प्लीज शेयर करिएगा, कहीं ना कहीं पब्लिश करिएगा.
No, we have already published.
मैंने देखा नहीं तो मैं आपसे ले लूंगा.
It's available on the ministry website also. If you are data, so we have published also. It's available there. But this is the.
मैं आपसे ले लूंगा.
Thank you, sir. Thank you very much.
Thank you, Dr. Sanjay, for giving us a very detailed overview of the current surveillance system in the country. So thank you so much for your time and support us. Thank you so much. So we'll break for lunch, and please join us at 2 p.m. sharp, because there is a very important session, and I hope you will enjoy that session. It is on diabetes mellitus. What are the guidelines given by the ICMR, and we have the panel discussion on those guidelines. So please come at 2 o'clock sharp.
हमने कोशिश तो की कि आधे घंटे में पूरा कवर कर दूं। क्यों जी वो लड़की जरा कितना टाइम लगेगा? परफेक्ट 30 मिनट में खत्म किया वही क्या होता within time
क्या काम कर रहे हैं? कितना प्रेवलेंस आ रहा है इसका
अभी जो लोग ये कर रहे हैं ना, जो हम एस्टिमेशन मॉडलिंग यूनिट पे कर रहे हैं, अभी एनालिसिस का डेटा पब्लिक डोमेन में आने दीजिए, उसके बाद सभी लोग चुप हो जाएंगे। हमारे जो सक्सेस स्टोरी हम रोज कर रहे हैं
एक्चुअली
HIV को बहुत कंट्रोल कर लिया हमने। जो मैंने अभी ग्राफ दिखाया ये साथ डिक्लाइन हो रहा है,
पर नहीं हो
अभी पता चल जाएगा। नाई से पूछो कितने बार सामने अभी आ जाएगा 2-3 महीने।
बढ़िया वही ऐसा है कि एम्स का नाम करो, अपनी मेडिसिन का नाम करो, तो हम फील प्राउड चलो खाना खाते हैं।
सर
दूध का प्रोसेस दूध नहीं अरे यही
अपने आप कर सकते हैं। हाँ हाँ ठीक है।
Yeah, we can control. I'm just having a look. Okay.
So, good afternoon, everyone. I know this is a post-lunch session, and I hope you're not feeling very sleepy or. Okay, so good afternoon, distinguished guests, respected panelists, esteemed colleagues. It is my privilege to warmly welcome you all to this panel discussion on gestational diabetes mellitus in India, defining research priorities for equitable and evidence-based care, organized by Division of Descriptive Research, Indian Council of Medical Research, in collaboration with EFICON 2025. So, GDM represents a critical intersection of maternal and non-communicable disease burden with profound implications for both immediate and long-term health of mother and their children. I have put together what are the research priority areas and what are the funding opportunities with Indian Council of Medical Research together for you. It's a brief presentation. So, as you all know, Indian Council of Medical Research promotes biomedical research across country, and its mandate is to formulate, coordinate, and promote biomedical research, conduct, coordinate, and implement medical research for benefit of society, and translating medical innovations into products or processes and introducing them to public health system. So it is more than 100-year-old institutions which started in 1920s with investigating beriberi initially, and it went on, and we all have seen its journey. And in 2020, when the pandemic hit, it played a very important role in developing co-vaccine. So when now the new structure of ICMR is that it has an intramural wing and an extramural wing. In the intramural wing, we have the old communicable disease, non-communicable disease, reproductive and child health and nutrition division, division of epidemiology, and various heads, directors of institutes. In the extramural wing, we have descriptive research division, delivery research division, development research division, and discovery research division. These are the various institutions of Indian Council of Medical Research which are across the country. When you look at the funding opportunities for the extramural grant, ICMR funds its own institutes to conduct high priority research. For the extramural grant, we have small grants which are up to 2 crores. The intermediate grants which are up to 8 crores. The CAR project, Center for Advanced Research, is granted, which is up to 15 crores. Then there is First in World, which has been inspired by the Chandrayaan, which is up to 1 crore. And then there are National Health Research Priorities, which ICMR takes up, which is multi-centric, bigger studies up to 25 crores of funding is being given. Various fellowships, research supports are done, and call for proposals are shared from time to time on the advertisement on the website in the form of EOIs, expression of interest. And these are the National Health Research Priorities for the Indian Council of Medical Research, where you can see on the 9th number, neonatal mortality, which if the maternal health is good, if the life course approach is given, the neonatal mortality will decrease. So considering gestational diabetes mellitus, which we will be discussing extensively today, is a high risk condition for mothers, which leads to consequences in mother as well as the child. So it would lead directly to decreased neonatal mortality. I have talked about the EOIs, expression of interest. So thank you so much. I would like to first invite our moderator and first panelist here, Dr. Harita. She is professor of obstetrics and gynecology at Jipmar, Pondicherry. She was awarded Foxy Corion Award in 2012 and FROG in 2015. She has published more than 100 articles, one book, and 5 chapters. I welcome you, ma'am, and hand over the session to you. Thank you so much.
Thank you, Dr. Ravleen, for the kind introduction, and good afternoon, everyone. At the outset, I would like to thank the Director General ICMR and the Organizing Committee of EFICON 2025 for inviting me to briefly talk on the current landscape of GDM in India and to moderate today's plenary session on dissemination of findings of ICMR Task Force Study on GDM in India, defining research priorities for equitable and evidence-based care. I'll say a few words on the current landscape in India and then kickstart the plenary session. The prevalence of GDM in India is known to be high among South Asians, and the latest evidence from India is this national study, ICMR India study, which is in press. And Dr. Mohan has kindly permitted me to share the results of the study. The national prevalence of GDM in India was 22.4%, with no significant urban-rural differences. And the prevalence of early GDM and late GDM were 19.2 and 23.4% respectively. Central India had the highest prevalence of GDM at 32.9%, and West India had the lowest at 16%. High systolic blood pressure and family history of diabetes were independently associated with the risk of GDM. So the paper concluded by telling that nearly 1 in 4 women in India, pregnant women in India, have GDM with regional variability. And the prevalence of early GDM, which is a relatively new concept, is also high. And hence there is a need for screening of all pregnant women for GDM starting in early pregnancy. Next, moving on to the plenary session, the objectives of the session are threefold. The first would be to disseminate findings from the ICMR task force study, which was carried out in 7 sites in India, and to assess their implications for national policy and program implementation. The second objective is to identify key gaps in the screening, diagnosis, and management of GDM across healthcare and community settings. And the third is to explore emerging scientific and technological frontiers, including biomarkers, AI, and digital tools that can transform GDM care. For this session, we have panelists from reputed research institutions in India, and their expertise in this area would greatly enrich the scientific deliberations. It is my privilege to call upon the esteemed panelists to the dais. Dr. Nikhil Tandon, Professor and Head, Department of Endocrinology and Metabolism, AIIMS, New Delhi. Dr. Puneet Mishra, Professor, Center for Community Medicine, AIIMS, New Delhi. Dr. Neeta Dabai, Senior Scientist, Society for Applied Studies, New Delhi. And Dr. Niharika Dhiman, Professor, Department of Obstetrics and Gynecology, MAMC, New Delhi. I request all the panelists to be kindly seated. Now we will okay. Now we will proceed with the talks from the expert panelists. 8 minutes have been allotted to each panelist, and I kindly request adherence to the time slot so that we have ample time for question and answer session at the end. I first call upon Dr. Puneet Mishra to deliver his talk on situational analysis of healthcare facility and community preparedness for implementing Government of India guidelines for GDM, findings and way forwards of ICMR task force study, in which Sir is the principal investigator. Can I have Sir CV, please? Okay. Okay, over to you, sir.
Respected Dr. Tandon, who is Dean Research and co-panelist, all the distinguished guests on the dais, all EFICON members, students, and dear friends. Today, I'm going to discuss one of the research study which was conducted by us, and it was on situational analysis of GDM in community. I'll not go into discussion about why GDM is important, what is the prevalence, because that has already been discussed. So I'll go why this study was needed and how we conducted and what are the main findings. After that, I'll be happy to answer any questions which you might have. So if we recognize it early, probably we would be able to reduce many maternal and fetal complications. That is of interest to us. Also, if we recognize early and we treat them, the chances of developing type 2 diabetes in future will be reduced. Government of India has identified the importance of GDM. They have developed a manual for the screening. As you know that 70% of India population is still in the rural area, and they are mainly served by the primary health centers, community health centers, paramedical workers, mainly A&M. We don't have a specialist there to treat. So Government of India has come up with simple guidelines how to test it, how to treat it for these centers. But despite of that fact, it has not been implemented. So ICMR thought of conducting some study to find out what are the regions, and we have undertaken this study to see regions behind that. One of the issues is when we develop, when we test for diabetes or GDM, we do OETT, where 2 tests are required, 2 pricks are required, and they have to wait there for 2 hours. Many times when a female reaches the center, they have already taken some food, tea, or something. So doing fasting sample becomes difficult. So in these guidelines for rural area, where many of the population they are from the rural area and they do not understand the importance of fasting, they have come up with single step procedure. Although some of clinicians they have some doubt about it, but when we work for the field, when we have to go into the field and for the masses public health approach, we compromise somewhere to cover maximum population with the maximum benefit. So Government of India has come up with the single step procedure where you have to give 75 grams of glucose, and then you have to do blood sugar, and if it is 140 or more, it is considered as GDM. And it is first test to be done during first antenatal contact, and second test during 24 to 28 weeks, provided first test was negative. These are the guidelines, but there are many challenges. Challenges like simple challenges, manpower. Challenges like non-availability of 75 gram of glucose packets. Then low awareness about GDM. Many other service providers, they are not trained well. So provider level, individual level, health system level, then community level, there are many challenges. And we thought of discussing and finding out what are the main challenges so that we can implement them in program for better screening. Because if you do screening only, then you can treat them.
If you treat them only, then you can prevent the further complications. So that was very important. So we have undertaken a situational analysis as a ICMR task force study. And these were the aim to understand the challenges and possible solutions in implementing GDM programs. So it are mainly the guidelines which are developed by Government of India. First they came in 2014, then 2018, and revised in 2024. We started this study, this was sanctioned in 2019. By the time it was time to start, COVID came. So we started in 2022. And it was a multi-site study. There were 6 sites. And sites were taken in each zone: north, east, west, central. So that way we have taken 6 zones. I'll come what all the zones. And we have taken some information, collected information from doctor or nurses who are present at the PSC mainly regarding the infrastructure, mainly regarding the logistics. Then we have conducted in-depth interviews as well from different level of health officers, starting from ASHA, ANM to MOIC of the PSC. And some of the medical college and CD staff, they were also included, and FGDs were also conducted. So this was overall structure. These were the sites. Since time is less, so some of the photographs from the supervisory visits of different sites all over the country. Now coming to the results, there are 6 sites which were taken in different regions of the country, including tribal region of Meghalaya. And in quantitative data, what we have found that 88% of healthcare workers were aware of the term GDM and its diagnostic cutoff value. But 90% of the healthcare workers did not know how to calculate calorie needs of the pregnant women, because if you know somebody is having GDM, the first line of treatment is medical nutrition therapy. So they were unaware about this thing. Then inconsistent practices in GDM treatment and management were found. They were familiar with at least one mode of GDM treatment, but dietary modifications, only 2% of healthcare workers supported their dietary recommendations with the use of diet charts. So why it is coming so low? Because most of the health workers were ANM. There was inadequate availability of essential stock for GDM. 75-gram glucose packets were unavailable at most other sites. We have taken aspirational district as well as non-aspirational district at each of the site to know. And we have taken different PSCs, CSCs and district hospitals as well. Then we did some qualitative studies as well, in-depth interviews to understand the issues and challenges, and conducted focus group discussions. These were the objectives for the in-depth interviews, and the data were ultimately grouped under following themes. And I'll present the brief results, summary findings of this. So majority of the participants like ASHA, ANM and lab technicians have a slight understanding of GDM, while they acknowledge GDM as a condition which can have long-term consequences on both mothers and children, but they lack knowledge about potential health complications. So this kind of answer, they said yes, there are complications, but what complications they were not aware. And it leads to, if you know better about the complications, probably you will try to convince a mother for testing. Then medical practitioners, including medical officer, nursing staff, demonstrated more advanced understanding, which was expected. There was shortage of resources. There was inconsistent GDM screening practices. And there's inadequate health system preparedness for GDM screening and management. Referral was poor. Although at some of the sites in the South India, I found that more than 70% women, they get screened. The reason was they were getting some incentive for getting screened. If they were getting tested, they were getting some monetary benefit. So that was one of the reasons. Some of the places we found the reason that they were not willing to wait for 2 hours. And in many places, the newlyweds, they are not allowed to visit alone. So somebody has to sit there for 2 hours, mother-in-law or sister-in-law. So those were the issues which we have found. Then FGDs were conducted. Again, we have found that lack of GDM awareness among pregnant women and community, then inadequate sharing of information, limited knowledge and implementation of medical nutrition therapy. This is really important because the first line of treatment is MNT, and we don't have dietitians at the rural area. So you have to do it through ANM or the medical officer who is present at the PSC. So we found that in the current scenario, we have to train them. They are not fit to provide MNT to the masses. So based on our finding, what we have found that we need to give specialized training to medical officers. At most of the places, they are general duty medical officers are educated in enhancing their knowledge about GDM testing and management. They should be trained to identify and refer uncontrolled and complicated GDM cases to health centers while taking care of other manageable patients at PSC. Because at many places, it has been found if they are skin positive, they are sent directly to medical college. We cannot, I mean, now we are getting more medical college, but it's very difficult if we send all the patient to higher centers and not treating them at the PSC. Many of the cases can be treated at the PSCs. And ASHA and them should be trained to mobilize because they have good community support and they have good understanding community believes on them. So they have to be mobilized. And one of the most important finding as a public health provider, what I think the ANM should be trained to provide medical nutrition therapy because that is the only way you can provide this to masses. And for OGTT compliance, waiting areas, daycare units or diabetes centers should be set up because we don't have any place for them or their mother-in-law, their relative to, I think time is over. Okay. So there are certain challenges now, how we can achieve it. One or two more slides. So how we can achieve it? My idea is to establish some model centers and some zones with the help of local resources without providing extra money, pushing extra money, what are the resources, how to train them, and that should be done on the state government because health is responsibility of a state government. So we have those model centers. We can supply 75 gram of glucose, which has already been started in some of the states, and train ANM, nationwide training to ANM for medical nutrition therapy. It can be, with the local food already chart should be prepared with the weight and the local food which is available. Those can be provided and some kind of training should be given to ANM to implement this program for MNT. That's all from my side. Thank you very much. And sorry for taking 1 minute extra.
Thank you, sir, for explicitly summarizing the findings of the ICMR task force study and highlighting the critical gaps in healthcare facilities and community and way forwards for implementing Government of India guidelines for GDM. Now I invite Dr. Neeta Dabai to speak on medical nutrition therapy in gestational diabetes, bridging evidence, equity, and innovation for better maternal fetal outcomes. Dr. Neeta Dabai is a senior clinical research scientist and gynecologist and deputy director with Society for Applied Studies, New Delhi, which is a not-for-profit research organization and is an ICMR and WHO collaborating center of excellence. Over to you, ma'am.
Hey, good afternoon, everybody. And at the outset, I'd really like to thank ICMR for this honor of presenting my views on medical nutrition therapy in gestational diabetes mellitus, bridging evidence, equity, and innovation for better maternal and fetal outcomes. It is challenging in a country which loves its food, and no advice on food is really very well happily tolerated. It is a first-line therapy and the cornerstone of gestational diabetes mellitus, whether you are on metformin or on insulin. Therapy or nutrition counseling or advice is very important. It focuses on individualized dietary counseling. That's exactly what maternal nutrition therapy is about. Monitoring of blood glucose along with exercise to achieve euglycemia. And the challenge is to also have appropriate gestational weight gain without compromising the fetal outcome on the fetal weight gain. So the global evidence, trying to bridge the evidence, global evidence of MNT is very clear. There is the national consensus of all the organizations, the ADA, the WHO, that MNT is the initial treatment for all women diagnosed with GDM, lifestyle, exercise, it reduces the GDM incidence. And there are so many pooled analyses which show that you can reduce the need for insulin and of pharmacotherapy and have better glycemic control. There are many comparative diets which have been tried, and some of them really reduce adverse outcomes, but evidence is not definitive, and there is a high heterogeneity between the trials. There is now emerging evidence that low-grade systemic and placental inflammation and gut dysbiosis is central to GDM pathogenesis, which is also central to many other conditions like high blood pressure, hypertension, PIH, as well as preterm labor. There is a lot of work going on placental, on inflammatory markers. So integrating anti-inflammatory and gut-friendly strategies seems very justified. And also there is evidence about probiotics with decreased incidence of GDM. There have been some good RCTs done, but still the evidence is not homogeneous. So the Indian evidence of MNT very interestingly has shown reduced neonatal hypoglycemia, delayed GDM progression in treating gestational diabetes mellitus, and early treatment, like pointed out by Dr. Harita, that the early gestational diabetes mellitus, which is a problem, treating that with MNT leads to a good outcome. Millet's once-a-day trial is one of the good trials done by Doraisamy et al., and it showed a significant mean postprandial blood glucose reduction. And interestingly, South Asian genotypes are likely to have elevated post-meal blood glucose level compared to Caucasians in the study done in Bradford. So the Indian evidence of inflammation and gut microbiota, there are very small studies done, but they demonstrate presence of systemic and endothelial inflammation in GDM. And early studies have shown that gut microbiota disruption supports the global findings in women with GDM. But most are observational trials and very small trials. So the global versus Indian evidence actually does come up with the same message to all of us, and the Indian adaptations need we need more standardized scalable MNT programs, and there is an urgency of launching large multi-center pragmatic trials to bridge this implementation gap. The national guidelines, like pointed out by Dr. Mishra about MNT, I'm just showing this because the next slide, I want to tell you about the experience we have had. We presented a paper on the burden, risk factors, and outcomes associated with GDM in a population-based cohort of pregnant women from North India. This was a randomized controlled trial, and it was a secondary analysis of a larger WINGS trial, in which we had 13,500 women. But we followed women from preconception to pregnancy, and there were about 2,294 women whom we followed. We found an incidence of 19.2% of gestational diabetes mellitus, of which 5.6% were early GDM. And we looked at the potential risk factors, so increasing age, increasing BMI, and a high HbA1c pre-pregnancy contributed to the burden of GDM. And the other thing which we wanted to tell you very clearly was that there was appropriately treated gestational diabetes mellitus, like it was done in this randomized controlled trial, where we had women who were exclusively counseled for their for diet. They had a proper dietary recall, which was done by a dietitian, and a very closely monitored blood glucose levels to look at the appropriateness. So if you are treating GDM appropriately, then there is no difference between the fetal and maternal adverse outcomes between non-GDM and GDM. The research gaps are very glaring. We have very few high quality RCTs. There is heterogeneity in interventions, and we need a lot of implementation research into what we have found and how to deliver MNT at scale. The scalability of medical nutrition therapy, as was so clearly talked by Dr. Mishra, that what are the gaps and what are the problems in implementation. And we also lack research in equity, cost effectiveness, and scalability. Which brings me to the next part of my talk, is the equity challenge of nutrition. And I really looked up what is about equity. There are so many papers on socioeconomic equity, but this one line from the Global Nutrition Report caught my eye, that what we eat across the world continues to fall short of the minimal standards of a healthy and sustainable diet, with resulting obesity and diet-related NCDs. So we have rapid urbanization in our country. There is transition to processed and packaged and obesogenic food. So while we are completing the energy part of the diet, we are not focusing on what is really good for the what should the calorie intake consist of, the proteins, the carbohydrates. We are just looking at the energy. And then there are health system inequities, limited time, staff training, as has been already detailed. So processed food consumption and GDM, what is the evidence from India? We have an urban cohort data showing Western type dietary pattern, high in red processed meats associated with significantly high risk of GDM. There is the Bangalore study by Mahinda et al. And done in Bangalore, which compared diets and found that fried snacks, sweets, non-veg foods were again linked to very high risk of GDM. And globally, Paula et al. Had done this meta-analysis where they found that 48% higher odds of developing GDM than when women consume ultra-processed foods. And that is something which we need to take out of our markets, out of our women's and our children's needs. So strengthening integration and implementation for nutrition in GDM is a challenge. Program integration, community engagement, task sharing, and culturally relevant diet design. All this has been actually taken up by Sir. I only want to point out that a pre-pregnancy or a periconception counseling really works very well with early implementation of GDM, which we did in our WING study, and a very close monitoring of the blood glucose, reminder strategies, telecounseling, and the digital innovation. I mean, we're talking about innovation. I could only look at the digital M-Health support. We already have many digital support systems already working, like the Kilkari, the M-Mitra. They are all can be used to support and actually bring home the message of medical nutrition therapy to the women, reminding them, following up with them, advising them. It needs to be scaled up, and it needs to be easily accessible and easily adaptable to the women in our country. So medical nutrition therapy is not just about food. It's about equity innovation and breaking the intergeneration cycle of diabetes. And the call to action would be to integrate MNT into routine antenatal care at every level. Thank you so much.
Thank you, ma'am, for sharing your insights on medical nutrition therapy in GDM and how connecting evidence, equity, and innovation can improve pregnancy outcomes. Next, I would like to call upon Dr. Nikhil Tandon to present the topic, Addressing Future Cardiometabolic Risk in Women with GDM. Dr. Nikhil Tandon is the Professor, Department of Endocrinology and Metabolism and Dean Research Aims, New Delhi. Sir has more than 600 peer-reviewed publications and more than 120,000 citations and an impressive H-index of 94. He's a former President, Endocrine Society of India, and holds the fellowship of several eminent organizations, and has been the recipient of the Dr. B.C. Roy Award and Padma Shri. Over to you, sir.
Change slide.
Yes.
Okay, thank you, ma'am. So I'm going to be sort of shifting gears slightly before we possibly come back to antenatal again. I think one of the reasons why I requested Dr. Ableen that I should speak on this area is to sort of communicate that GDM is not a disease which is restricted to the pregnancy. It has implications for the life course. And unless and until we do that, what happens is that the care provided to the woman in pregnancy stops at the end of a successful outcome. And then people forget that there's a lot of carry-on baggage and legacy which goes on. And that is an important point which you really need to do. If you look at any systematic review or meta-analysis, you'll find that a woman who has had GDM is about 10 times more likely to develop diabetes in future compared to their normal glycemic peers. One of the things which actually has plagued the area of gestational diabetes really is diagnostic criteria. And I'm not going to go into details there, but I'll just allude to that because especially when the younger audience reads papers, it's important to see what criteria have been used to make the diagnosis, because it will have sort of implications for prevalence, it'll have implications for transitions, it'll possibly also have implications for therapy. Anyway, for a large part of the last several decades, the Carpenter and Couston criteria were used to diagnose GDM. And there are a few studies from India which looked at what happens to women diagnosed with GDM using these criteria as they in their postpartum life. And I'll primarily refer to the work we did, which was more than 350 women. And as you can see, at a median follow-up of about 20 months, 32% of the women had already developed diabetes. And if you take between 2 and 4 years after their index pregnancy, nearly half the women had already developed diabetes, which is a really, really large number, right? So, and if you therefore then combine both pre-diabetes and diabetes, virtually 75% of women in that very, very short window of 2 years or 20 months after their index pregnancy actually had dysglycemia of some description. Compared to the general population using these data, if you compare them to their peers in the general population in the third decade, this was an 18-fold excess risk. If you compare the women in the fourth decade, it was about a 9-fold excess risk. So clearly, it's a low-hanging fruit for even NCDs because it's mandatory to get a glucose test done during pregnancy, and therefore you can identify women and catch them early because these are really young converters. So what we found was, number one, and I think this has been alluded, and I think for the sake, despite being repetitive, it's important for us to understand that not only are GTTs done not as much as we would like during pregnancy, the postpartum glucose tolerance tests are few and far between. In this particular study, despite it being part of a research project, we eventually only got 1/3 of the women to subject them to a post-delivery GTT, right? It's a very important time of life for the woman. She's managing herself, she's managing the baby, she's managing the house, and if she's working outside, she's also managing that. It is really not a priority for us. We've got to make it easier for her to be able to do the test. The second thing was that weight gain was definitely driving. There was, if you look at the prevalence of overweight and obesity in this cohort of women at the time of the beginning of their pregnancy, it was about 1 out of every 3. And it was nearly 3 out of every 4 by the time they had delivered, which is a mean BMI change of about 4 kilograms per square meter. That's a huge increase, right? And therefore, given this very rapid conversion, it becomes important for us to consider that whatever efforts we have to make, we don't have the luxury of saying, we'll come back and see you after 5 years and doing it. It has to be done very, very early. Then, of course, the criteria changed to the IID-PSG, which is what is actually recommended globally. And the thing with IID-PSG, for those of you who are not familiar with these diagnostic criteria, is that they defined a cut point above. If you exceeded that cut point, you were no longer called GDM, you were called overt diabetes in pregnancy. So GDM today is actually the left of the curve of glycemic excess, right? So we're actually picking a woman with the sort of lower half of the elevated glucose. The higher ones are called overt diabetes in pregnancy. And therefore, if you now use these criteria to diagnose women with gestational diabetes, you obviously will get certain different results. And that's what we found once again. And this is the longest study done postpartum. Again, you'll find about 60% or 65, nearly 60% of women had dysglycemia, but numbers with diabetes was less. It was about 10% because you were starting with a cohort which did not have such elevated glucose levels during pregnancy. They were elevated, but they were censored at a certain level because anybody who went above that no longer was called a GDM. They, of course, had to be managed for hyperglycemia in pregnancy. Again, the important point is even with this cohort, if you look, the 10% diabetes prevalence was at about 18 or 20 months after delivery, right? The equivalent study, which is a Harpo study, which led to the creation of IID-PSG criteria, had a similar diabetes prevalence at 11 years after their index pregnancy. So not only do we have more GDM, we're also converting more and we're converting faster. And I think the message which is very important is that the health system shouldn't pat themselves on the back by just managing the diabetes of the woman or the hyperglycemia of the woman in pregnancy. They've got to look after them even after the delivery. So we therefore went ahead to do a trial which is supported by the ICMR through the GACD scheme to see if a light touch lifestyle modification, fully realizing that this is a time of life for the woman, they really can't expect them to be doing things with, like going to the gyms and etc. So it was a light touch lifestyle modification to see whether we can impact the likelihood of them having worsening glycemic status. So the basic policy, the basic strategy here was women who were identified with gestational diabetes, they were called back for GTT anytime between 3 to 18 months postpartum. If they had diabetes, obviously you can't prevent diabetes, they already have diabetes. If they were either normal glycemic or pre-diabetic, they were then subjected in a randomized controlled trial to either intervention or a standard control. And all that we looked was, will the intervention prevent progression of glycemic worsening? So if you are non-glycemic in this postpartum GTT, did we prevent you from developing either pre-diabetes or diabetes? If you already had pre-diabetes, did we prevent you from progressing towards diabetes? This is actually the largest trial in the world done. There were two other studies being done at the same time as us, one from Brazil and one from China. And we clearly did more, despite the fact that we landed up in severe difficulty. This was during COVID. And so a lot of things which we intended to do, especially calling women in, etc., really went for a toss. The intervention was actually very light. So that's part of the problem, because it was an implementation research study, and we therefore couldn't do anything which the health system could not have then adopted later on. So just 4 group sessions over a period of 6 months, 2 SMSs a week, which came from a central, monthly phone calls, a reassessment at 6 months to see whether they had been putting on weight. And if they'd been still putting on weight or not lost weight, we intensified therapy. 70% of the people came from public hospitals. I will, Ravleen, since the DG is not speaking, I'm going to use his time and speak. Right. So 70% were public hospitals, and we actually recruited more than what we were supposed to recruit. The sad part of the story was that there was a trend in improvement, but it did not reach statistical significance. Again, the important point was, look at the BMI categories of these women. 65% were either overweight or obese. So again, weight gain is a very, very important part of what was happening. And again, 9% had already developed diabetes, even within 3 to 18 months of their things. Now, the 3 other things which I want to convey to you, which are important, especially for the health system implication of it. So we've always said women with GDM, higher risk for developing diabetes. Therefore, all women with GDM should be therefore managed with the same stringency. What we realized was that this is not exactly true. Take a cohort of women with GDM, do their GTTs in the postpartum state. You can either have normal glycemia, pre-diabetes, which is either IFG or IGT, or a combination thereof. If a woman with GDM in their postpartum GTT has normal glycemia, the incidence rate of diabetes is actually reasonably low for you to do a soft touch intervention. It's just 3% per year, right? The moment a woman has either IFG or IGT, it becomes 10 to 12%. If they have both IFG and IGT, it becomes 30%. So there is a definite gradient. You can see how far the woman has already progressed and then plan your interventions accordingly. We also found that depending on the number of normal glucose values during the antepartum GTT, and these were all done by IDPSG, so you can have either 1 abnormal value, 2 abnormal values, or 3 abnormal values, and there was a gradient. Those with 1 abnormal value had about a 5% risk of developing future diabetes in the immediate term. Those who had 2 abnormal values was about 8 to 10%, and those who had 3 abnormal values had about 20%. So again, if you can do a risk stratification in a low resource system, you can actually focus more in those who have got the highest risk. And I just want to add the point about the so-called overt diabetes in pregnancy, because people forget, people keep talking about GDM as per current classification. Even if you look at the DIPSI criteria, it's more than 140. It doesn't further stratify beyond that, which is all right, as Puneet mentioned, from a public health perspective, because you do what you can do. But the conversion rate of a woman who had overt diabetes pregnancy, that is, they meet diagnostic criteria for diabetes which we use in a non-pregnant person, a fasting of more than 126 and a post-glucose of more than 200, had a 70% conversion. 70% conversion. Now, this may be a small number of people, but they need a lot of care without us. So let me just stop here by saying that the risk of type 2 diabetes in women with GDM is about 10 times higher. So this is a very important area for us to focus. invariably what happens is that the obstetricians do their work and rightfully are happy that healthy mother, healthy baby at the end of the pregnancy. The woman never reaches a physician because nobody sends her to a physician. Fortunately, now with the FIGO having a postpartum passport, there may be an improvement in this, but this is clearly a huge, huge health system gap which we've never addressed. The risk of type 2 diabetes in somebody with overt diabetes in pregnancy is massive. 70%. We have higher rates of GDM, we have higher conversion rates to diabetes, and we have faster conversion. So we're really in significant trouble. And as I said, there is a risk stratification which is possible, which we could potentially use when if we have limited resources. A light touch intervention did not seem to be successful, though, as I must say, the COVID issues created problems for us. We may or may not need additional strategies, including drug interventions, which have been done in the past for diabetes prevention studies, but time will tell us what to do. I'd like to thank the ICMR specifically, not only for this, but because most of the work which I presented has been supported through the ICMR, and immensely grateful to the organization for allowing us to do this work. Thank you so much.
Thank you, sir, for your valuable research inputs, emphasizing the magnitude of cardiometabolic risk in women with GDM and the importance of early identification and interventions postpartum for its prevention. Now I invite Dr. Niharika Dhiman to deliver her talk on health equity, access and management strategies, practical interventions and policy interventions in high-risk pregnancies with focus on GDM. Dr. Niharika Dhiman is a professor, Department of Obstetrics and Gynecology, MAMC, New Delhi. She's a member of several organizations and she's received several national and international awards. And she's contributed to journals and books, and the field of interest is gynecological oncology and critical care in obstetrics. Over to you, ma'am.
Thank you for those kind words. And can I have my presentation? I thank ICMR and the organizers here for inviting me. And I also thank Dr. Pavan for sharing his slides with me. And sir has actually shared his slide, and I'll be talking on equity, access and management strategies, practical and policy interventions in high-risk pregnancy with a focus on GDM. Basically, we've talked about MNT, what's the dilemma in the diagnosis, and screening of antenatal women. So how it is being implemented at the level of public health, that is what I'm going to talk about, and the problems that are faced. So the Government of India is committed to provide accessible, affordable and good quality maternal health care. Addressing the gaps in accessibility, affordability and quality of care is important to reduce the maternal mortality and morbidity. And I would say here that GDM actually is a disease of long term, which actually, affects the mother as well as the newborn. So definitely screening and prompt treatment is necessary to prevent this morbidity here. The efforts are directed towards bridging the geographic and socioeconomic divide in the maternal health service delivery and policy interventions for high-risk pregnancy women, including GDM. And so, yeah. How do we ensure accessibility to maternal health services? This has been achieved by building healthcare infrastructure at every tier of the health system. There is the delivery point, the FRUs, the MCH wings, and for the complications of GDM arising through GDM, we have HDUs, ICUs, and also birth waiting homes, which can take a good care of these complications. Introducing alternative modes of transportation. Basically, this actually kind of bridges the gap due to geographical variations, and in areas of West Bengal, some forest reserves or hilly areas where the terrains are difficult and transportation is actually a problem. So air and water ambulance and Palki and Doli and all have been adopted by the local, taking the help of the local communities and the volunteers for early referral and transportation of the mothers. Capacity building of healthcare providers, skilled birth attendants. It comes under the Lakshya program has introduced the Daksh and Dakshata, where basic emergency obstetric and neonatal care and also the comprehensive emergency and neonatal care are taken care of. And here doctors or the MOs are also trained in the anesthesia field, where they can help doing cesareans as and when required. And at the village level, there are outreach activities such as the ANMs. They do registrations, which these days what is being done is a RCH number is being generated over the mobile. SMSs are sent for, as a reminder for their regular antenatal checkup. And this is being done at the basic level of healthcare by the ANMs and the ASHA workers. The program, the Suman program, it also helps in, kind of giving the basic and the advanced emergency obstetric care. And it identifies Suman volunteers, which actually help in the capacity building, and a good referral and identification is therefore done. For ensuring affordability in maternal health services. For GDM also, there has been, the entire logistics and the expenditure has been calculated for 5,000 population, which you can see it's there in the GUI document or the guidelines for GDM. So this has been done by the various schemes under Lakshay and Suman, which are the GSSK, that is the Janani and the Shishu Suraksha Kalyan program, and it actually reduces the out-of-pocket expenditure by actually giving free delivery and cesarean sections. There is, free dispersal of drugs, and even the diagnostic like ultrasound and all are being done free of cost at the GSSK mission. The GSY, the Suman Healthcare, and all these programs has helped, bringing it at a very affordable level where no cost is charged for the antenatal women here. Apart from this, under the Pradhan Mantri Surakshit Matritva Abhiyan, there are incentives being given to the ANMs and ASHA workers also. And as we see, they have upgraded high-risk pregnancy factors from 10 to 25, and it includes GDM also. So as I've already said, there has been an extensive tracking system for patients who have been diagnosed with GDM, with incentivization of the high-risk pregnancy women as well as the ASHA workers. And the achievement so far under this has been that the total antenatal checkups conducted were more than 6.7 crores, and a total of high-risk pregnancies identified, which included cases of GDM also, which was more than 1 crore. So we know that the prevalence of GDM is high in our population, 10 to 14% in India. And I think this has already been covered beautifully by Sir. And so what we see here is that because of this high prevalence, what GOI recommend there are guidelines, we've already covered this. It has to be a screening test as early as possible in the pregnancy, and we are doing it by the DIPSI, and actually it cuts on the cost. And MNT can be advised by these trained ANMs and ASHA workers, and it has been recommended that, GDM mothers who are on MNT can be delivered at the lowest facility possible. They need not refer it to the high facilities. Only those on pharmacotherapies have to be referred to the higher center. Yeah, and monitoring has to be effective. We all know, as per the data, we see that the percentage of women, who have been screened has been increasing over the years. So screening definitely is the goal to, actually identify the women, and at public health level, a proper identification, role of MNT definitely, and a referral in case the criteria are not met on the MNT, the mother requires pharmacotherapy, they have to be referred. So National Program for Prevention and Control of NCD has a crucial role to play in disease management for GDM turned type 2 diabetes mellitus. As we know, in the postpartum period, the turnover is high, as Sir has already said that. Availability of logistics for GDM screening at village level or at the basic facility has to be done properly, and the procurement has to be done timely. There has to be a capacity building, a regular reporting, monitoring at every level. The GI has actually made the systems have been formed such that the registration and documentation has to be done. A quarterly or biannual review of GDM activities has to be done at every level. And the information education and basic counseling has to be done in the community for community awareness of GDM, so that they can seek care, and robust evidence generation and research for policy inclusion has to be made. Thank you so much.
Thank you, Dr. Niharika, for giving us an excellent overview of the management strategies and interventions with focus on GDM. I would like to thank all the panelists for their excellent contributions. And if there are any pressing questions from the audience, maybe one or two questions we'll be able to take. Otherwise, they can be addressed during tea. Sir, I have a question for the panelists. Should India still be advocating the DIPSI guidelines? Because we might potentially miss out women with high fasting blood glucose if we just stick to DIPSI guidelines. So, what are your thoughts on that?
Definitely you're saying we might miss on those with the high fasting, but if you talk about the screening at public health level, where the ANM, I think the follow-up or getting them to a center to get tested, I think one test would be enough. As Sir said, we don't know the upper limit, but definitely a lower cutoff can be set.
We have unpublished data from JIPMER. We have a retrospective cohort of 2,400 women, and we have found that 30% of women who had a normal second hour had abnormal fasting. So the guidelines were published in 2018, and 7 years down the line.
So I think what is being said is we have to acknowledge that, and it's like an informed acceptance of the frailty of DIPSI, right? Scientifically, it is not easy to support DIPSI. From a public health perspective, you're saying that, if you can't do anything else, at least do this much. And therefore, that balance has to come. Let me just take it one step further. What is the aim of any test? The aim of a test is to identify a person who has
the disease,
who needs to be taken care of, right? Now, let us say that, and some people say you miss 30%, some actually say you miss more than 30%. Dr. Mohan's data in which he did and showed more. The issue of importance is those who got missed. If you did not treat them, did they get harmed? That is the most important question. Fortunately or unfortunately, we haven't answered that question till now. We are now in the process, again, courtesy the ICMR, we're doing a 7-site study, which is trying to address that question. Not only whether or not you're missing, so that's that you miss, but what, so the study is as follows. We're going only to centers which use DIPSI as a primary method of diagnosing diabetes. We do a second GTT within the next 3 to 7 days, which is with IAD-PSG. The results of that IAD-PSG based is not revealed to either the patient or the treating physician unless you hit overt diabetes, right? The patients are treated as per the DIPSI results. So you will have 4 categories which result from this combination of 2 tests, both positive, both negative, DIPSI positive, IAD-PSG negative, DIPSI negative, IAD-PSG positive. Our concern here is those who are DIPSI negative and IAD-PSG positive, do they actually have higher or worse outcomes? If they don't, then we should be fine with DIPSI. If they do, then we have to make a push that we can't just look at public health perspective. We are allowing a proportion of our pregnant women to get harmed. We should not allow that. So I think that's the way we need to look at it. Till such time we have data, I think we'll just have to settle for, whatever is practically feasible.
So one more quick question. Is there a need for population-based cutoffs for our population? Because some studies have shown that the Asian Indians have a higher risk of adverse outcomes at different cutoffs.
So
Yes,
let
sir.
me tell you a small story which you as obstetricians would actually be more familiar. So how was IAD-PSG? How did the cutoffs come? From HAPO? So effectively in HAPO, they identified that if they take the current cut points, 92, 180, whatever, I never remember numbers, and 152, I think those are 3 numbers. They if women are above any of these, they have a 75% excess risk of a composite outcome. Right? Why 75%? Why not 100%? Why not 50%? Fortunately, there are very few people in the room, so I can say it loudly that it was voted. 5 people voted for 75%, 4 people voted for 100%. That was the basis of this. Today, especially after new, and if you look at, are you going to harm somebody by treating them at a lower level also, which the early GDM toboggan study is showing? What some of the countries have started doing is they've actually shifted the cut points from instead of 75% excess risk to 100% excess risk. So that's based on their data. You're very right. Hopefully the study which I described just now may also allow us to look at some analysis to see what cut points we should use.
And we look forward to the results of the study, sir, and I would like to conclude the session. I thank all the panelists once again. Thank you.
Thank you, ma'am.
We never do simple things.
Thank you so much. And now it is my great privilege to welcome you all for a very famous, prestigious oration, Dr. V.K. Srivastava oration, which is being delivered today by Honorable Director of AIIMS New Delhi, Dr. M. Srinivas, who has a very illustrious career of more than 3 decades in various academic, administrative, and research positions. To do this honor, I will request Dr. Farooq sir, who was the former principal of Assam Medical College, former director Nilgrims, and also pro-vice chancellor of KBN University Gulbarga, and Dr. Ajit Sahay sir, who has been the founder head of department of medical biometrics at JIPME. Over to you, sir, for further proceeding.
Good afternoon, everyone. I request Honorable Director AIIMS, Dr. Srinivas, to come to the dais. Now, this session is the Vinod Kumar Srivastava oration. Now, before we start, I just introduce Professor Vinod Kumar Srivastava, who is was an eminent public health person, nationally known and internationally known also. And he is the founder member in starting the EFICON India. Earlier, he was the Southeast Asian director for the International Epidemiology Association. He has a lot of contribution. He is an alumni from the SGPGI, earlier the institute, and now the university. He has several, worked from several medical colleges in Uttar Pradesh as well as abroad also. So in his name, and this year's recipient is Professor M. Srinivas on the oration. I should introduce also
It's my privilege to introduce Dr. Srinivas. Now, he is a reputed pediatric surgeon and a noted medical educationist, as well as accomplished research worker, as well as he is an eminent hospital health administration expert. He is an alumni of AIMS and has academic excellence. He has recipient of many of the awards in the undergraduate, postgraduate, and postdoctoral things, and also the national awards on the pediatric surgery, Association of Pediatric Surgery. He is professionally recognized by internationally by the Our Ladies Hospital for sick children in Dublin, as well as he is also the fellow of the European Society of Pediatric Surgery, ESPS. And he has written he has contribution in many of the journals and others. And his students are spread all over the country. Even starting from here to the northeast, one of my, he is there. I have known them particularly. And I request you, sir, and you are the recipient, and we congratulate you, sir, on this. Thank you.
So thank you very much. Good afternoon for a kind introduction and respected chairpersons, the distinguished delegates here. I was just telling them many of the people are having the snacks outside. I was requesting them that they will get inside because epidemiology is numbers. The numbers are more outside than inside. Well, thank you, sir. You made me to remember our own friend in my own room, from the Dibrugarh. They made me to remember our own friends in the pediatric surgery. Well, first of all, I think I must thank Professor Umesh Kapil because, he was not only from our side of the human nutrition and epidemiology, but I was closely associated with Madam Aati Kapil also because we are a very robust hospital infection control. We used to go and hunt the people and then say that, sabka sample le lo aur dibal kar do, aise mein andar nahi aana chahiye. So we were the people, the most powerful people when we were in that hospital infection control team with the madam. And then we could change, we could change. When I came back to India in 99, we saw that, the most of our babies were dying. And one of the reasons was that our infection in the newborns in the ICUs. Madam was a lot of contribution from Professor Aati Kapil, madam. Well, because pediatric surgeon has not only in the epidemiology, community medicine, and all this conference of today, I must take the contributions which have been done from our departments. Professor Kapil is sitting here, and the people were there from the community medicine, and then morning also you had many of those programs happening, and our own thing. So basically, I'm just taking through what are the contributions of the AIMS. What is that we have done and where do we learn from here? That's where we will take it from the institution perspectives and then initiatives and the vision which we carry forward so that we go it. Again, I was just discussing with the sir that, with great respect to the great Professor V.K. Srivastav, his role in public health, again, something which we always remember. And in the disease outbreak responses, especially in the Japanese encephalitis, is something which makes us to remember again and again in this thing. And of course, the affiliations with the Institutes of National Importance and the head of the community medicine at the Lucknow. And then, of course, it's a recognition. It's an honor for me that, I'm standing in front of you and then see that, the great Professor V.K. Srivastav here, And then we wanted to say, the pioneering of the aims in epidemiology and public health since its inception. We have decades and decades of legacy of the All India Institute of Medical Sciences, community medicine, community previously called preventive and social medicine. Then we changed the name to community medicine. Roots are in the AIMS Act itself. When and how the institute was, conceptualized and this thing. Referring to the AIMS Act, AIMS Act, it says, I'll just read verbatim, one or more medical colleges with different departments, including Department of Preventive and Social Medicine. This is the fundamental thing. I highlighted that. When this was discussed in the parliament by the health minister, who happened to be the president, Rajkumari Amritkar, madam, this is something which has been fundamentally put in the of this institution, the preventive and community social medicine, And then moving to the fifth point, the rural and urban health organizations, which will form the centers for the field of the training, medical, dental, nursing students of this institution. Again, the fundamentals of community medicine and epidemiology, that's what the building blocks of this institution, AIMS New Delhi, have been enshrined way from when this was, inception of this institution was done. The discussions in the parliament, the president of the AIMS, the health minister, Rajkumar Amritkar's vision, that's what is depicted in the funding, the purpose, the inception, the AIMS Act. And then the mandate was very clear, transformative role for the India's public healthcare system. That's something which we'll see as we go through that, how did the institute do it for the country. And integrating the clinical practice, the most important thing is not isolation. In the community medicine has to be community, doesn't mean that it just ends up with community as epidemiology, integrating with the medicine. It has been a good institution. Even as a pediatric surgery senior resident, I would love to go to Wednesday morning and then do the surgeries there and OPD for pediatric surgery. That's the kind of integration which we had with the super specialties, also with the community health at the Vallabhgarh Hospital for us. Well, when the nation looks at things, what are the things this institution has done? It's not just the community medicine department or Vallabhgarh or a project, but looking to anything and everything, policy, advocacy, programs, the various discussions which happens to the ministry, the then planning commission, the present Niti Aayog, all that, just to know some of them, National TB Elimination Program, this institution is there, Integrated Child Development Scheme. Sir was just talking about, how his days of being in the Department of Gastroenterology going on this thing. Universal Ideation of this art, and again, hepatitis vaccination program, National Program for Healthcare of the Elderly now. Now you see that. From today we have a National Center for Aging in this campus, National Blindness Control Program, a huge impact, from the Rajendra Prasad Center for Ophthalmology Sciences, huge impact. Fluorosis control, look into that. Department of Anatomy, not even computer medicine or toxicology or forensic medicine, Department of Anatomy, the founding fathers of this institution, from there, they took the fluorosis research to the books and corners of the country and then said that, this is the National Program for Fluorosis Control Program. That's where this institution stands for. Community medicine, epidemiology, and then national trauma policy. Look, today we are the WHO center and many of these collaborating centers, including the trauma, and the people from the Southeast Asian region, many parts of the world are coming here and getting the training in our trauma center. And again, also handholding for the country, for the various state government councils. Introduction of the unleaded petrol, seminal research from this institution going on to say that the lead is something which is not good, especially on children, from the department of many departments included in that, Then these are the pictures, how the people from the community medicine, all the Indian medical sciences reach out to the community, especially at our Vallabhgarh Center, into the core epidemiology curriculum. We were taught not just as undergraduate, postgraduate, even as a faculty, that the epidemiology curriculum, biostatistics, what is the research methodology, reaching out to the people who are not reached, field-based training. You ask any intern here, any undergraduate student, they love to go to Vallabhgarh, Dalpo, Chalsa. They want to go there and then spend time, few weeks. And then be part and parcel of building the health data collection analysis. Today, unlike the Framingham study, which we keep on quoting and studying in the books, this is the largest of the data sets which are available in this country, where we can actually do a change. What is the change which has brought to this institution and to the country? Biostatistics and evidence-based medicine, part and parcel of this. Research contributions, some of the policy advocacy which we have changed through the research policies which looked into, something this institution has taken through the community medicine and the epidemiology and the doyens who are here, they going on to know how we can do it. I just wanted to share some of the milestones. If we don't extreme, then we forget what kind of the people we had and what kind of great service and sacrifices they did for this institution and then indirectly to the nation. Some of the achievements of our Comprehensive Rural Health Services Project, CRHSP, of the aims at the Balaggar. These are pictures. What you see on this side is the main aims. And then this is Chatri. This is our beloved outpatient department those days. Now it is a little different building, and now it is again getting demolished when we are coming out of the new building. And when you look into that, this became the model of the rural healthcare of the country. Way back, today people talk about community, clinical-based, competency-based medical education. All this 1950s, 60s, 70s, it was in this institution through the Department of Community Medicine to give these solutions to the country. A model for the rural healthcare with a clear health objectives that how do you reach out to the people, how do you get the epidemiological studies done, how do you get the household survey, cluster-based studies, get the data done, be part and parcel of the primary prevention, take to the immunization schedules, bring prevention into that, and the hospital delivery done, reach out to them with the food, nutrition, school, education, it is there, the entire set of the community medicine, epidemiology principles, research principles, in practice at Balakad. That's where the integrated of the village services were incorporated. And milestones, I'm very proud to say that, some of these milestones way back in 1952, the Balakad Foundation was done. 1960, the rural posting for the interns started, way back. Many people, I don't know how many of the institutions in this country have thought of sending the people who love to stay there. Sending is different. Today also people go to some of the institutions go there, but do enjoy that? Do really enjoy that? Do take part in the building the change there? Do really believe in the social change? That's something. You ask somebody who was there, they love to be there. The bus 7:45, they are just bubbling with enthusiasm and dynamism to reach out to the Balagad in the morning, even if it is a winter foggy day. 1965 again started. A lot of funding came from the various foundations. 67, Health and Democratic Surveillance started. One of the largest data sets which are available. And today, looking at that, it is not just a Chatri or one OPD or something. 4 lakh OPD in a year. 7.5 thousand IPDs with more than 600 surgeries, including some of the surgeries as a pediatric surgeon we contribute there. All this is possible. It is visible. It's visible there. It's living there, and you can see that the kind of change which these people have brought it from a small health center there. Then other part and parcel of the community health workers training. Yes, definitely again, because it's not just an extension of medical college of community medicine or principles of epidemiology or as a foundation. Part and parcel of workers training, mobile health clinics, reaching out to another from there, going out to other people, telemedicine incorporated, huge impact. If you look at the statistics of this country, Urban Planning Commission, President Niti Ayog, Minister of Health and Family Welfare, the best of those rates of immunization, hospital delivery, care, everything, this cluster, which is the thing which reflects in the country's statistics. That is because people were taking part in that, And then the decentralized health communities, again, that's where it was very important that we decentralize our services from here to there. Then, is it just for the country or beyond? Yes, definitely beyond. Then whatever the lessons we learned from that, how to reduce the disease burden, how do we engage the community, what is the scalability and sustainability? We became a model, plug and play for the rest of the country and rest of the world. That's where it was adopted across the countries. How the community medicine PSM department reached out to the people and said that this is the way it has to be done. It is monitoring adaptation of the systems, and today it is part and parcel of surveillance, capacity building, various interventions. And then again, policy advocacy and all that, the department is very honest, and then they are doing all this, not only just for this institution, but also for the nation. And what about international collaborations? Yes, definitely. This part and parcel of the international collaborations and various agencies. You know, if you look at the strategic collaborations with the various Rockefeller Foundation, Ford Foundation, initially those days the community medicine, preventive medicine department, then going on to joint research projects. You know, what is that we can do? Collaborative research with the various people. That's where this department of community medicine of All Indian Medical Sciences, going on to the CRHSP, Balabgarh, not just became a model for this institution, not just to become a model for this country, but for the entire world, especially the global south, because how do we reach the unreached people in the world? You know, that's one example, a successful model which was given to not only to the country, but also the rest of the world. That's where part and parcel of all those epidemiological studies, building capacity building. We saw that, you know, it's not just the training the people, but even the health workers. Surveillance systems, data, the big data which came from the Balabgarh, this thing. Then today, we are happy that, you know, the department, Professor Sanjay Rai is also here, and being part of the WHO guideline contribution. Today itself, the highest of the people from this region of the WHO, they were part here, this institution, goals, you know, shaking hands with the community health, epidemiology, various departments, and see that how do we reach from here? How do we reach out to the Southeast Asian region? How we can make this successful model go back to those areas to reduce everything, you know, whether it is the mortality rates, mortality rates, focus on the primary prevention, immunization protocols, demand systems, that, you know, the things which we learn in the community medicine department. Then, and again, morning also it was discussed, and how do we have that kind of responsiveness, you know, the pandemic situations, you know. Again, the people were very so proud that, you know, in the Balabgarh, the kind of immunization was done, the kind of data they had. And then we look into the data, you know, if somebody asked that, you know, today you have COVID vaccine, what are the different vaccine, what interaction, integration, what vaccine is taken, all the data is with them, the big data things, and how, as a gold mine of the data which was there. Again, global vaccination policies and research and policy publication, all that happens from this institution. Some of the major collaborative agencies of the Department of Community Medicine, again, I don't know the name, but, you know, I took from the website, because I'm aware that, you know, they were part and parcel of the various institutions, CDC, WHO, CRO, ICMR, and DST, and other things. That's where it's happening. So you look into that, 1950s and 60s and 70s, an institution from a department, All India Institute, reaching out to the Balabgarh, having global impact. Global impact, and that's not the primary prevention, but became a role model for the rest of the world, so that it could be useful to reduce whatever we want to do for the country and reach out to the people who are unreached. What is the future? You know, this is the legacy of the thing, you know, our forefathers, our teachers, and the great people in the department have been doing it. What is the future? You know, that's what we wanted to share with you. The future in this institution, that we want to take this institution on the community medicine, epidemiology, evidence-based medicine, all these things, you know, we have conceptualized, you know, it has through various stages of our approval process in the institution, because we have statutory requirements. How do we go with the public health institution in this? You know, how do we transform public health practice in India and beyond? That's the vision. And the mission is to create a center of excellence to incorporate all people. So I'm very happy to say that in this conference, you know, other than when I came for the inauguration, bubbling with so many people, cutting across everybody, doctors, community medicine, teachers, nurses, epidemiologists, statistician, nutrition, you know, the entire encyclopedia of the medicine will be here in this particular service which we wanted to do. So that's where, you know, addressing the health challenges, skilled professionals training, bridging the policy and the practice which we have been doing. You know, this institution and the Department of Community Medicine has been part and parcel of the Urban Planning Commission and the Niti Aayog, leadership and innovation. Yes, it's an island which is doing, but we wanted to enhance our commitment and say that we want to become a center of excellence. We want to become an institution within this institution and to become a role model for the rest of the world. And that's where we are going ahead with the public health institution, with our institution. basically strategic rationalization in the departments. We will have enhanced epidemiology and health information system, which is there at the moment. This is prevention or control component in that. Health promotion and social sciences. This is a big thing. Social science is a big thing which is required here. It is being in a medical institution, medical college, we may not have much of importance to that. And I showed back to the slides, you remember the slides of how the President, the Rajkumar Amritkar said that the social science component is also important. That's enshrined in the AIMS Act. That's where we want to integrate in the institution and health systems and policies, of course, with this thing. We need to reach out to more and more people. Whatever is being done in a small scale, of course, it has a huge impact on the world, and a big scale where we can correct and do the skill gap which is existing at the moment, and then align with our policies. This policy is also aligned with previous policies and the future policies of this country. And then how do we look into the Viksit Bharat and give an example to the rest of the world that this kind of institutions are necessary for the entire holistic approach of the community health and the services. Well, what is the advantage? The advantage is a public health institution, again, in addition to the degrees which we have, we embark on something more. There's something more in the same of PhD in epidemiology, biostatistics, health policy, environmental health foster, artificial intelligence in health. Whole lot of things are coming up. That's where the focus of this institution will be, and a dedicated research center beyond research which we are doing it. International collaborations will enhance, and a practical training in technology to enhance the translational research. Because more and more things are happening. So gone are the days where sit in a bus and from Delhi go back to Bandhavgarh and then say that we are doing it. Now is a time where we need to adopt incorporate the technology, go beyond the thing, telemedicine, telehealth, telementoring, teleproctoring. Whole lot of things are there. There's a huge opportunity for us. That's where the center is envisaged. And collaborative partnership, not just the institution, not just the WHO, not just the UNICEF, beyond that, different institutions of the world where public health is the focus of the attention, the primary prevention and the training focus. So that's where the future is, the data-driven public health. As I said that, I'm not data. I was just discussing with sir that, we talk about funding in the study, but I think that the largest data is from the Bandhavgarh. And if you ask me, that's a gold mine. We need to tap that, and then we need to incorporate more and more of the statistics and AI into that, and then over a period of time, we will come up with something more, with respect to our own country, our own subset of population on this part of the world, this part of the country, where we can think of improved disease control and strengthening the health workforce and influencing the policy making, not only policy making for the EU, but also policy making for the global south, because one of the policies which the Bandhavgarh and this institution use it in this country is the practical solution for the global south, because the problems of the South America, southern part of the Africa is the problems of what we are seeing today, not least in some parts of the country and this part of the world. So it will have a lot of impact on the rest of the world also. And just to conclude that, how the institution has gone from public health department to rural health innovations, international collaborations, and the vision which I said that, institution of public health within the institution, within community medicine, merging all the people together as a team, the Department of Community Medicine, Epidemiology, evidence-based medicine, all the people sitting here, human nutrition, all those people, it's not just the doctors, it's not just the nurses, it is the people who are caring for primary prevention. That's the kind of team which we are looking at. And it's a time, I don't know why pediatric surgeon was chosen for the oration. I thought, I will not talk about anything about me or my department. It's the time that, this is possible because of the members who have put their sweat and blood to this institution. That's the time. I've been very grateful to Professor Sanjay Rao, but he just gave these pictures. And I thought, just 15 minutes before I came here, I started incorporating this. And I said, we must remember them and salute those people who have made this institution possible, the CRHS possible, the policy and advocacy of this institution possible, give the example to the world. And then we're thinking today, the public health institution and beyond. All this is because of the people who have that vision, the people who have their sweat, and right from 1950s, from Dr. Holmes, and I remember my days at least, Professor L.M. Nath, at least that much onwards, we physically have seen them, Professor Redaya, and I know how much passionate these people were, and all very few people having this kind of photographs. I think you should take them, we will get after some time. And Dr. Professor Pandey, again, I wish he was here dancing in front of my people and saying that, how he's able to take care of his personal problems with his the spirituality. And Dr. Shashikant, well, he was there with us, and Dr. Sanjeev Kumar Gupta, and the present leadership of Madam Kiran Goswami, who have shaped this department, the center, and the vision which we carry, and the benefits of the work we have. Then there are the people, it's not just the team head of the department, but there are people, Professor Rai is here, various people, we take with them, and the future of the people, the people who are already joined this institution, the new institution which is coming up, not only, but also at the Central Armed Police Forces or Institute of Medical Sciences. So I just wanted to say that, what I'm speaking today, whatever we have done, it is all because of the people who have put their efforts and time, energy, and the money and services to which that has been there. And I just wanted to share with the youngsters who are sitting there, if the country has to become a Viksit Bharat, we need a healthy nation. Healthy nation is not building super specialty departments. Healthy nation is not building the big things. It is the primary health, the primary health and the prevention. And that is only possible when we look into a large population. Large population, the nooks and corners of the country, every nooks and corner, every village, every hamlet in this country, where we can reach out to that. That's where the role of the community medicine, that's where all of you, the leaders who are here, that's where the epidemiology, that's where the people that has built for that. And that's the reason why I'm just especially addressing to young delegates, and especially the young people, especially on the inauguration also, I said that, future belongs to you. You, the team, the team of what we've spoken about, how the epidemiology, this conference is brought the people, the minds of the people, the experts in the people, make a network, take the help of them, connect with each other, and be the brand ambassador to others. When you go to an institution, you must say that, I met that professor, I met that professor, that professor. Then you will say, okay, his student is our teacher. 3-4 generations of people were there here. And it's a time where you network and then take the help to your work. It's not just taking care of your thesis or something, but how we build a nation together and the big team. And the biggest challenge is that the biggest opportunity, this is an opportunity for all of us that, we are bringing diverse people into the fold. How do we make this into a big evidence-based medicine or epidemiology or public health institution? Everybody is part and parcel of that. This is the entire spectrum. You have to see that in the entire encyclopedia of medicine and the primary care is there in this kind of a team. That's where we need to take this as a team and as a mission. And again, once again, with the salutations to the great Professor V.K. Srivastava, I say that, thank you very much. And whatever we shared is the department's time, energy, and the success story from the department to the world through the Development Planning Commission in the present Niti Aayog, with the WHO collaborations, and with the vision that, we are committed to continue the legacy of the people who have done here, so that we will be successful in building our own evidence-based institutions, public health institutions, and then foster that kind of approach, and then achieve come back to this kind of content and say there is a story of success from the Muslims and there's a story of success from CRHSP. Thank you very much.
Thank you, sir. It's an honor to be with you. And your dynamic leadership, I'm sure that we are going to achieve the missions and visions you invited. And
अभी का स्नैक्स था सब आ जाओ सर One thought, and then we can go and sleep on the flight, because I used to sleep.
He went to the, and that's why I was telling you.
People got never figured. It is a nice story. Really enjoyed. And some of the photographs I have never.
इसके लिए फर्स्ट करना पड़ेगा यही मुझे चाहिए राइटर कहेगा कि मुझे चाहिए ये तो कहीं आप कहीं जाओगे
Problem of yes. Yes. Solve the problem. मैं बहुत बड़ी that is the African flight. African knowledge. बोलो इतना अच्छा डिपार्टमेंट है आपका बात तो रही चंगा then what will be that mixture and that will speak Indian.
First, the poem was on sound. What is it, how we generally try to coconut tree बोल के उसने रट मार दिया तो वही किया मैंने भी आज पीडियाट्रिक सर्जरी से मैंने कम्युनिटी मेडिसिन लगा के रट मार दिया था क्या करेगा बहुत में बेटी का मेरे बड़े इंसान की हो रही बहुत कोई नहीं Okay, welcome to the last session, and we hope that the more speaker will come. Meanwhile, we have two speakers for this session, and this session is on the Young Scientist Award. And chairpersons, we have requested Dr. Ananya Roy. She is professor, Department of Community Medicine, Lady Harding Medical College. Dr. Johnson Cherian, Associate Dean for Research, Additional Professor, Community Medicine, AIMS, Madurai. And we have Dr. Madhulika Bhattacharya. She is the former Director, National Institute of Health and Family Welfare, as a chairperson. So with your permission, ma'am, can we start the presentation? So I invite Dr. Riksha Mahajan.
So, a very good afternoon to the respected chairpersons.
We'll be having this competition. And one of the participants will get the best presenter award.
Yes.
For their study. And here we are, three of us.
Just to introduce us, I am Dr. Johnson, Associate Dean of Research and Additional Professor of Community Medicine at AIMS, Madurai.
Good afternoon, sir.
I am Dr. Madhulika Bhattacharya. I am retired. I was ex-professor and dean at National Institute of Health and Family Welfare, New Delhi.
Very good afternoon, ma'am.
Good afternoon, everybody. I'm Dr. Ananya Reelaskar. I'm professor at Lady Harding Medical College, Department of Community Medicine. In fact, before she starts her presentation, I would like to read her CV. She's Dr. Richa Mahajan. Our first presenter is an associate professor from SMVTIM, Kakyal, JNK Medical College. And she has done her lecturership from Government Medical College, Jammu, and senior residency from Government Medical College, Jammu. And her working experience, she has worked as a co-guide for 3 postgraduates, and she has also worked as a co-guide in various research projects. And she's a member of editorial board of JK Science Journal and organized World Health, and she has World Health Days, and she has also many publications to her credit. So I would like to now request Dr. Richa to start a presentation.
A very good afternoon to the respected chairpersons, to all my respected seniors and colleagues. The title of my research work is Prevalence and Risk Factors for Postpartum Depression in a North Indian Cohort. Postpartum depression, it is one of the most common and debilitating mental health conditions experienced by women following childbirth. The government is focusing a lot on the reduction of maternal mortality as well as maternal morbidity, but I think there is very little that is being currently given to the mental health within the maternal health. On a global scale, such postpartum common mental disorders, they impact an estimated 10 to 20% of the mothers during the first year following delivery, significantly contributing to maternal morbidity, and they even impact the development of the children. In low and middle income countries like India, the prevalence tends to be higher, with estimates ranging from 15 to 25%. And this can be attributed to the different socio-cultural environment that prevails here. Postpartum is a biologically and psychosocially vulnerable time when hormonal changes converge with psychosocial pressures, as well as cultural and gender factors. In India, these are especially compounded by varied socio-cultural settings like lack of literacy, preference for gender, marital conflict, lack of spousal support, violence at home, and many other factors. This current study was taken up with this aim only because very little data, especially as far as JNK is concerned, very little data, I can say that not much research has been conducted in this area. So this was the main aim to conduct this research to find out what is the prevalence of postpartum depression among mothers and what are the various risk factors that contribute to this. So the study design, it was a hospital-based cross-sectional study that was conducted by the Department of Community Medicine in collaboration with the Department of Obstetrics and Gynecology, and the Department of Psychiatry was also roped in because all the mothers in the study who were screened positive for postpartum depression, then they were referred to the Department of Psychiatry for further treatment and evaluation. And these mothers, they are still under treatment, and the study is still ongoing. We plan to follow these mothers for the ultimate outcome. The study was carried out between January and July 2025. All women aged 18 years and above who had delivered a live born infant within the preceding 6 weeks were included in the study. The exclusion criteria were women who had a history of any other major psychiatric illness like schizophrenia, bipolar disorder, or they had some endocrine disorder like thyroid disorder and were on treatment, or any other psychotropic medications were being taken by them, or participants who experienced perinatal loss or who declined consent, they were also excluded from the study. The time window was chosen in accordance with the DSM-5 criteria, which defines postpartum period up to 6 weeks after delivery. Sample size was calculated taking the prevalence as 20%, that was taken from the previous studies, and using the formula, the sample size was calculated to be 246, but to account for the non-response, and so we included 340 women in the study. And after obtaining the ethical clearance, the study was started. Pre-tested structured questionnaire was used to elicit the basic socio-demographic, obstetric, psychosocial data, and other data like age, literacy level, religion, family structure, all these were taken. And then Edinburgh postnatal depression scale was used to screen the mothers for any depressive symptoms. And it is a 10-item scale where each item is scored from 0 to 3. So the total score ranges from 0 to 30. And cutoff was taken as 13. Those who had a score of more than or equal to 13, they were identified as probable depression, and then they were further referred to the psychiatrist for further either. And they are under, depending on the discretion of the psychiatrist, either if they are diagnosed to have mild depressive symptoms, then they are put on cognitive behavioral therapy. And those who were diagnosed to have moderate to severe depression, they were put on psychotropic drugs, looking at the cost benefit analysis. Data was analyzed and mean standard deviations were calculated, and associations between postpartum depression and the various risk factors were assessed using chi-square or the Fisher's test, and further bivariate analysis was done, entered into a binary logistic regression to identify the independent predictors of postpartum depression. Out of a total of 340 women who were enrolled, the mean age was 26.8 plus minus 4.1 years, and the range was 18 to 40 years. Nearly 30.6% of the women were found to be illiterate, and 41.2% belonged to the lower socioeconomic class as per modified Kuppuswamy scale. Majority lived in joint families and were homemakers. The mean parity was 2.1 plus minus 1, and 46.8% had unplanned pregnancies, and 21.8% were delivered via cesarean section. 28.2% of the participants reported a female neonate as the index child. Lack of spousal support was reported by 22.9%, and 17.9% reported exposure to domestic violence in the postpartum period. Based on the Edinburgh postnatal depression scale, the overall prevalence of postpartum depression that came out to be in our study was 19.7%. That is, out of 340, 67 women had postnatal depression. The mean score among depressed women was 16.8 plus minus 2.3, while in the non-depressed it was 7.4 plus minus 3.1. No significant difference was observed in the prevalence between the Hindu and the Muslim participants, indicating that religious affiliation was not an independent determinant after adjustment. On multivariate regression analysis, Illiteracy, lack of spousal support, and domestic violence emerged as independent predictors of postpartum depression after controlling for the potential confounders. These are the tables that are generated. This is the socio-demographic profile of the participants. Majority were in the age group of less than 25 years. A majority of the women, they had completed secondary education. Around 31.8% had completed secondary, while 30.6% also they were illiterate. And majority belonged to the middle class. Then the obstetric and psychosocial profile of the participants. Majority were multiparous. 53.2%, 46.8% reported that their pregnancies were unplanned. 78 had normal vaginal delivery, and 71% of the women, they revealed the gender as male. Now on the bivariate association of variables of postpartum depression, it can be seen that education, socioeconomic status, and especially spousal support, that was found to be highly have a highly significant association with postpartum depression. All these variables on multivariate logistic regression, these variables were found to have significant association even after taking care of the confounders. And as per this study, the prevalence of postpartum depression is 19.7%, which is quite a high number. And many other studies that have been conducted, they have also shown that the prevalence, some studies like a meta-analysis of 38 Indian studies has reported a pooled prevalence of 22%, which is close to our study also, and it indicates that there is a high prevalence of postpartum depression among Indian mothers. So to conclude, I would say that mental health, the mothers who are who deliver newly delivered, so the postnatal depression is a big problem, and I think focus needs to be turned towards this issue as well. Thank you.
Thank you, Dr. Riksha, for the nice presentation.
Thank you.
Congratulations on your completion of the study. Still, you said that still it is ongoing.
We are actually now all these mothers who have been diagnosed, who have been screened as positive for postnatal depression, they are still they are under treatment. Some of them are undergoing the counseling sessions, and some are on treatment also.
I just had just a couple of questions. One is, how did you sample these people after delivery? How did you? Where was the point of enrollment?
So at the
what is the association of high-risk pregnancies? Did you assess whether the high-risk pregnancies or was that affecting the postnatal depression?
So we have enrolled these mothers from the immunization clinic of the same hospital. So when they used to come for the first at around 6 weeks, when these women used to come for immunization of their babies, we have enrolled these women at that point. And all those, it was a convenient sampling. All those used to come for immunization. We used to enroll them till we achieved our desired sample size. And for the second part of the question, high-risk pregnancy, we used to ask the women regarding normal delivery or cesarean delivery. And mostly in our government hospital, it is assumed that those who are having a cesarean delivery, they only told us that there was everybody who had a cesarean delivery, they used to tell us that some complications, some said that the meconium was passed, or everybody told that there was some complication. So we indirectly link these cesarean deliveries with high-risk deliveries. Otherwise, in the government hospital that we are working, where we have enrolled the patients, all the normal deliveries are conducted. Cesareans are done for the patients who are at some high risk.
I have a few questions. How did you choose the women? I repeat the same question which Dr. Johnson has said. I mean, how did you choose them? There were many women coming to your immunization center. So who did you choose?
Ma'am, our inclusion criteria were like all women above 18 years and who were not on any medication of.
That's all.
Yes, ma'am.
Then how did you choose which women? I mean, in how much time did you complete your sample?
From January to July, we took the patients and we only used to take the patients 2 days in a week. Like the investigator or the researcher used to go for 2 days in a week.
You think those women who had come to the center, they were depressed?
Sorry, ma'am.
You chose the women who had come
to the immunization
clinic.
clinic.
You think depressed women will come to the immunization center?
Ma'am, if it is mild depression, like many a times they're not even aware. If it is mild depression, we are screening them for depression. There are many of the women who are suffering from postnatal depression. They are themselves also not aware. And the people around them are also not aware that it is a condition like postnatal depression. They consider it as like they don't even know that. So they don't even give consideration to these women that they are suffering from some problem.
Okay. How did you understand this spousal support? What was your criteria for reading this as an answer for spousal support?
Ma'am, it was perceived spousal support. We did not apply any particular questionnaire for that. It was perceived. We asked the woman.
You must have asked questions.
Yes, ma'am. We asked the woman that how much support does she get from her husband in taking care of the baby, in her own taking care of her own self, in her diet, in her household work.
See, the majority were lower socioeconomic status. You expect the spouse to support in all these work?
Ma'am, if they are aware, they should. I believe that is the thing, that awareness only we have to create, that this is a period of high vulnerability.
Dr. Ananya.
I have a similar question. In fact, I would like to want you to elaborate upon how exactly did you approach them while selecting the sample, because this is a very crucial step of your study. And if you just apply the exclusion criteria, probably those the ones you have listed, they will not be coming to your center also for the immunization. Maybe somebody else is getting if they are so sick. Yeah. Another thing is if we are taking them after 6 weeks time, or we cannot assume that everybody will come at dot 6 weeks itself. It may be a little bit later. So sometimes there is a reporting of delayed immunization of the children. This is what you mean, that
Yes,
the
ma'am.
first
Yes,
pentavalent immunization, she's coming along with them. So probably will miss out on the period before that. And secondly, ma'am also asked one very relevant question, which I was also thinking, that how did you assess the social, because it's to do with the caregiver, the support of the family. It is not just the spouse who supports her, especially in the class that you cater to. Sometimes the spouse will not be able to pay that much time. So did you assess the family support structure as such?
No, sorry,
The
ma'am.
association.
No, we have not assessed the family support. We only took into consideration the spousal support at the time of study. And regarding that other question, that around the time period, we included those women who fulfilled this criteria of who had delivered within the past 6 weeks. So who had just delivered in the 6 weeks before that, we took them into the study as per the criteria.
Families. The families were unitary or joint. Did you consider that?
No, we haven't taken
Don't you
that.
think joint families will have more support?
Yes.
Then that has an
Yes,
effect
sure.
on the postpartum depression also.
Yes, ma'am, sure. Thank you.
One thing is that it's a hospital-based study. Do you know about the maternal depression, postpartum depression? It has got 2 phases, the early phase and the late phase. So it only given the late phase, isn't it?
Yes.
And whether you have tested the European protocol, the tools which you used to diagnose the postpartum depression, it is an European based, the Edinburgh based, isn't it?
Yes, sir.
Have you pre-tested it?
No, sir, but it has been actually used in a lot of Indian studies.
First and foremost, it's in English.
Yes, sir.
Their social culture things are different. And here, you have translated.
Translated it.
Have you verified it?
Yes.
Retested it?
Yes,
You
sir.
have done it.
Yes, sir. We did a pilot study as well
How
for that.
have you done with the validity of the evidence translation?
So,
What are the steps you have taken?
no, so not the proper steps, but the researcher.
What are the correct steps?
So steps for.
Because you are translating it
Yes,
from
sir.
English to
Hindi.
Hindi.
Yes.
Or
The local language.
Now, how you find out that whether the translation is correct or not? What are the steps to be taken? सीखो ये
Yes,
क्या
sir.
है ट्रांसलेट करो फिर ट्रांसलेट करो इंग्लिश में
Yes.
दोनों वो दूसरे एक है पूरी बात है
Thank you, Dr.
Thank you.
Teacher. Thank you so much. Now I invite Dr. Vijit Viswas. With the permission of chair, should I start?
Okay. Hello. So we would like to introduce Dr. Vijit Vishwas. He is MBBS from Bhubaneswar and currently he's got 7 years of PG experience. He's ex-faculty AIMS Gorakhpur and AIMS Patna and Jodhpur. Currently, where are you, Dr. Sir?
I am currently working as associate professor in the AIMS Deoghar, madam.
In AIMS?
Deoghar, Jharkhand.
Acha, Deoghar. Okay. No.
I think
You can start with your presentation.
Yes. Thank you, madam. So, with the permission of chairs, today I am presenting my research paper titled Coverage Evaluation of Mass Drug Administration for Lymphatic Fibrosis in 4 endemic districts of Jharkhand, India. So, myself, Dr. Vijit Viswas, working as an associate professor in the Department of Community and Family Medicine at AIMS Deoghar. So, these are the co-authors in the paper. It's not moving. How to move? Acha, it's moving now. Okay. Previous slide. It's not in my control, I think. Acha, okay. Fine. So in Jharkhand, all 24 districts are endemic, contributing to the 1/10 national burden. So this study was conducted in 4 districts of Jharkhand, namely Deoghar, Dumka, Godda, and Giridih. So Deoghar had the highest LF prevalence of 34.8 per 10,000, followed by Dumka, Godda, and Giridih. So MDI has been implemented by NCPBDC since 2004 and one of the key strategies for lymphatic fibrosis elimination by 2027. Periodic coverage evaluation surveys, independent coverage evaluation surveys are mandated to assess the drug uptake as only the districts achieving more than equal to 65% in case of DEC albendazole regimen, dual drug regimen, while more than 85% with the IDA regimen, that is triple drug regimen, ivermectin, DEC, and albendazole can be only be eligible to proceed to transmission assessment surveys. So with this background, the survey was done to independently get the coverage and compliance and to find out the reasons for non-compliance among the household surveyed and to recommend the corrective measures to enhance the treatment coverage in future rounds of MDA. So this is a flowchart showing the sampling design and process of the study. For each evaluation district, we have randomly selected the 5 blocks, which is the implementation unit of this MDA. Within each implementation unit, we have selected 4 clusters, keeping in mind the representation of the rural, urban, And within each study cluster, we have selected 30 households. So first we have visited the cluster. We have randomly gone to a site, then systematically adjacent households were taken as a sample. And within each selected household, the head of the family or the next available adult member will interviewed after the consent. Data were collected using EPICON 5 and analyzed using GEMOV, where map depictions were made using the leaflet package of R. So here in this map, you can see the map of the study area showing the distribution of the study clusters. Total 80 study clusters were there, and the lymphatic fluorosis cases distributed in the map of Jharkhand. So notably here I want to specify that among the 4 districts, Deoghar and Giridih underwent MBA at February 2024 using the DA regimen, that's a 12-drug regimen, while Dumka and Godda underwent the same at August 2024 using the triple drug regimen, that's the ITA regimen. So we have done this coverage evaluation survey within 6 weeks of the completion of this MDA campaign. So coming to the results, this is the bar chart showing the overall and district-wise MDA coverage of the study households. So in 61.9% of the households, there was at least one eligible family members who have consumed the MDA drugs, while the complete MDA coverage could be achieved in case of 45% households only. That means household with all eligible members who have consumed MDA. In case of 5.6% of the household, we found ineligible members owing to underage, pregnancy or lactation or chronic illness. Now coming to the distribution of the study blocks and districts as per the MDA coverage. So here 2 types of coverage have been narrated. One is drug coverage, one is epidemiological drug coverage. The numerator for both the coverages is the same, the number of family members consumed MDA, while denominator varied. For drug coverage, the denominator is number of family members eligible for MDA. For epidemiological drug coverage, the denominator is total number of family members. So in terms of district, you can see the Dumka has the highest coverage of 65.4%, but you can see that it is still quite below compared to the reported administration coverage. In terms of district, the Giridih was having the lowest coverage, you can see the 30.4%, while in terms of block, the Jammu block of Giridih district have the lowest coverage of 17.4%, while the Purihad block of Godda were having the highest coverage of 76.9% with overall coverage of 49.2%. But all these figures didn't make the WHO recommendations and were quite below compared to the reported administration coverage. Now coming to the predictors of complete MDA coverage by bivariate and multivariable logistic regression analysis. So as you can see, with the increment of 1 unit of the educational attainment, the probability of complete drug coverage was increased by 5%. While in terms of districts of residence, in comparison to Deoghar, those who decided at Dumka and Godda were having higher odds of complete coverage, where those who decided at Giridih were 25% having 25% lower probability of complete coverage. Well, in terms of area of residence, those who resided at tribal and rural area were having higher odds of complete coverage compared to those who resided in urban area. Interestingly, we found with increase in the family size, that means number of family members, the chances of complete coverage reduced by 12%, which is 1 unit increase in the family member. So these are the similar prior literature indicated in the right side. So continued with the findings, those who are having LF case in their family heard about LF, knew that LF is mosquito-borne, received prior communication regarding MDA, and at least participated in 2 prior MDA rounds were having higher odds of complete coverage. And these were the similar literature in support of that. Now, coming to the drug consumption in empty stomach and adverse event, those who consume the drugs in empty stomach were having 4 times higher odds of developing adverse events. That was about 5% households that we got in our study. And MDA-related adverse events are mostly self-limiting, very limited consequences require hospital intervention. So these were the studies in support of that. Now, coming to the reasons for non-compliance, we found that I am not sick. That was the predominant reason that the person told that this I don't have the disease. Why should I take MDA drugs? The second most common cause was not enough information was provided. That why is this drug is given for? What is the utility of that? Whereas 1.5% also told that poor packaging of medication, as you know, that albendazole is given loosely from a bottle for MDA rounds. So this is a predominant reason. So similar studies like Kumar et al. Reported absence during drug distribution. These studies of fear of side effects, Kulkarni et al. Perceived ineffectiveness of medication. So these were similar compared to our studies for reasons for non-compliance. Now coming to the conclusion and recommendation, none of the survey districts achieved the WHO recommendation thresholds, with only every second eligible person consumed the NDA drugs. Dumka and Godda, although they are administering triple drug regimen, outperformed the dual drug regimen districts of Deoghar and Giridih. So their implementation models may scale up and further investigation, and this may be replicated in dual drug districts of Deoghar and Giridih. Prior awareness, pre-campaign communication, and participation in India rounds strongly predicted the better compliance. I may add up to this in this study, because as per Government of India guidance, coverage and compliance is the same, because if they have not consumed the drugs in front of the drug administrator, that is not taken as a coverage. So at last, we want to recommend that there should be structured revisits. There should be proper magnitude of that leftover household members should be revisited to be covered. There should be standardized communication, because that is the second most common cause that not information was given. So the drug administrators may be practiced with role play during the training, so that they can give a standardized message without any confusion in the community. There should be real-time monitoring, like selfie while administering the drug. The supervisors may real-time monitor the drug administrator by like that. Local leadership engagement, like teachers, priests as a role model, may they may provide extra support as a role model, and are pivotal to strengthen the NDA delivery and accelerate ALF elimination by 2027. I want to add that those who told the different reasons for non-consumption, given the opportunity of the survey, we tried to convince them that what is the importance of that, but with the given timelines, so that could not be documented for the purpose. So these are my references. Thank you. Yes, which table now? This one. I think it's not visible. Can you project? Yes, ma'am, I have gone there.
Oh, yes. Okay, so first you tell us why those two did better. In what way? What were the reasons behind those two with triple drug therapy were better than the other districts?
Ma'am, what I got the because this is India is a campaign that requires strong supportive supervision at the ground level. So their supervisors were more active during the rounds, and their central team also visited during the MD campaign, which included me also during the round itself. So that might have given more publicity to the campaign and more people taking the drugs. But compared to the other districts, that is subject to further in-depth investigations of why the coverage was such low.
The districts were chosen, the unit of this sampled units were chosen randomly.
Yes, ma'am. The districts were assigned to us by the ministry in CBBTC.
But then after that, you choose the
Yes.
Simply the blocks, and then the villages, and then the households.
Yes, ma'am. Yes.
How did you choose the households?
Household, ma'am, we have randomly selected the cluster, but we have gone to a random point. Then we have actually 3 teams of us.
When you went in a village, how did you choose the households?
We went to a random site, like prominent place like temple, or where the gali jahan se segregate ho rahi hai. We went there. We comprised of 3 teams, including myself, 3 interns, me, and 2 residents, junior residents mostly. So I accompanied the other intern by randomly, and other 2 residents like that. So we went to the 3 random gali, and we took the adjacent household, so that the time could be saved.
And how many did you cover? All households?
30 households per cluster, ma'am.
Per
cluster.
Per cluster. So
30 households.
So you went to 30 households.
Yes, ma'am.
And you went consecutively?
Consecutively. Because otherwise it would not be feasible within the given time frame.
Okay. Earlier also they must have been given drugs. This was not the first time that they were getting the drugs.
No, it is being administered.
Earlier experience?
No, it was.
That will also affect the drug.
Yes, ma'am. It's implemented since 2004 only, ma'am. But the main problem is that the the self-health belief model that I don't have the disease, why should I take the medication? So that is the main thing that is governing.
That is you're telling us for the current round when you went and inquired. I am asking you, these areas are endemic for filariasis.
Yes, yes, ma'am.
So they must have been given the drugs earlier in the earlier rounds also.
Yes, yes, ma'am.
Yes. Then what was their intake then? Was that also affecting the taking the drug this time?
Ma'am, we have also documented that variable. Number of times they have participated in LF, excluding the current which you have been evaluated.
What I'm asking you is, did that anyway affect their drug intake?
Yes, yes, ma'am. If they have participated prior into 2 MD rounds, their odds of complete coverage was more, 2.3 times higher.
But they said we are not sick, and that is the main reason, isn't it? That we are not sick. Why should I take the drug?
Those who are not taken, that's the reason, ma'am. This is the predictors of complete coverage where all the family members are taken.
Adverse reactions reported in the earlier drug intake?
Yes, yes. Earlier drug intake, that much recall history could not get. In this current count, we got 5% adverse event, ma'am.
So did that anyway affect the drug intake of the other people in the household?
That would affect next time because they have the adverse event this year. Although we in the training also train the ASHAs that all the adverse events are self-limiting only. You have to more water and take rest for 1 day because this is a gastric irritant. And if you have microfilariae,
And how did you handle this difference between the government report and your coverage?
so that is the purpose only. This is being assigned to us.
But did you go and tell the chief medical?
Yes, ma'am. I have been involved in each year in the training of these respective districts, and I shared the MDCS data.
So any explanation given for that? That is program data.
Yes, yes. That is program data only. So it is more only because we have been assigned to do coverage evaluation survey. In respect to that, WHO is also does one. Yes. It's quite large difference. You can see in Deoghar, we got 42%. The reported data was 92.3%. And WHO got somewhere around 35%. WHO data didn't got permission. Otherwise, I have also projected that also because WHO is also doing independent coverage versus survey. Administrative coverage was more. So that's why that, yes, yes. Because, sir, they rely, government also rely on our WHO's data more. Yes, yes. Yes, that is subject to further investigation because they are reporting such high coverage, but state microfilariae rate is quite high in those districts. If they have really achieved this much coverage, then microfilariasis would have been eliminated from these districts.
I had a question
Yes,
regarding the methodology. Could you please elaborate upon how exactly did you ascertain that they have taken it? Was it like self-report basis or
It's self-reported, ma'am.
was it
It's self-reported only. Independently, you have to go.
in what we are doing in UP nowadays is we also check for the supervisors also check whether it is being done directly observed this thing is given or not, and that is probably the reason why there is a mismatch in the numbers, and maybe that could be that could have attributed in the ones in the Girid
Yes, yes, ma'am, I understand.
and with the other better performing districts.
Actually, we were instructed by government that you don't have to contact even ASHA also. You have to, it's like a random check. Independently, you have to go, and because if I go, then they will, if we found this way also, they have not taken drug, but they have been asked by ASHAs, if anyone come for checking, please tell we have taken drugs.
And another inherent limitation of the cluster sampling is that the point where you start is a very crucial point.
Yes.
That whether it is at the center of the, where everything is accessible, or maybe the workers are also easily going there. So there is a possibility of having missed out the portions or pockets which have the high-risk pockets.
We have
in all the
we have similar findings also. Those clusters for those who have adjacent to the CHC or nearby CHC, those having higher coverage compared to those clusters, those are far from CHC. That is also a finding, but we have not documented any separate variable for that. That's why we have not used here.
And just one suggestion, the bar diagram that you have, can you please go back to that slide? The bars that you have shown for the reasons of why they have not. So you could have, actually.
Okay, that one. This one. Yes, yes, ma'am. The suggestion is well taken, ma'am. I understand.
Because the reasons will, vary.
Yes, ma'am. I understand. Why reasons differing with the high performing and low performing?
And also, two drug, you said that there are some places taking two drugs and versus three drugs. So when we increase the number of drugs, does the performance or does the coverage go down?
Ideally, it should, but the finding is just opposite.
Dr. Vijay, congratulations on your study.
Thank you, sir.
It is heartening to see that you work with the system also. The system is interested your institute or you also to do this study. And I think most important point is we know the coverage is low. These are the reasons. But how are you planning to contribute back to the system? What is the way forward that you're thinking?
Actually, I contribute in the different meetings that there should be like here also I would recommend that there should be a role play that should be inculcated because ASHA have to ultimately implement the program. If what key messages, for the example, I give an example that albendazole that infertilizes the female worms, so further microcephaly is not produced. But ASHA is what giving message to the community, you may become infertile if you take MDA drugs. So that may hostile the whole campaign itself. So that's what they should choose. Exactly, they should be drafted, and that same message should be given to the every community members so that we can increase the coverage. Otherwise, it would go for years and years. Nothing could be done.
I expect something like what kind of way forward are you planning for this issue?
This only, sir, what I suggested. This,
okay, because the way you're telling is only you're just only committing that this is what is happening. But if you were to, interested to, you are interested to increase the coverage. The previous agenda was to find out the coverage, but if you want to increase the coverage, what are the concrete steps you would like to take?
So that I have suggested here that they are not visiting the house second time. That who hasn't missed, they are just visiting one time. Those who are missed, they are not visiting for the second time. And there should be standardized communication that already happened. Real-time monitoring. There's been no monitoring. They tell ki khila diya tawa. Like that, I told ki they said that they have distributed drugs and they ask the committee members if anyone comes for checking, you say that we have consumed, but they have actually thrown the drug. So these things happen. Previously, this was distribution. Now government have mandated that it should be dots only. Then it will be should be only considered as compliance. Otherwise, and cover it. Otherwise, it should not be considered. So government is also working. We are also at the limited capacity. We are also trying to contribute to the government's initiative so that we should come up with some point.
Communication is also a very important step. But anyways, congratulations. It was very useful and very pertinent, this area of
Thank you, ma'am. Thank you, sir.
when we are targeting elimination.
Thank you, Dr. Vishwas.
Thank
It
you.
was a good study and good presentation. And like Dr. Johnson said, you should try to see that all the problems which they have faced, for which they were not taking, they are sort of handled, managed, and the coverage is better. Thank you.
Sure. Thank you. Thank you.
Dr. Surbi? Dr. Manirisha? Oh, you are here. Okay.
This is not the PPT.
Just to introduce Dr. Manirisha. She is a postgraduate.
So Dr. Surbi.
Good. Dr. Surabhi is assistant professor at NAMC Delhi. And she did her MBBS from Dayanand Medical College, Ludhiana, MD from AIMS Delhi. She has completed her DMB. She did her SRship from AIMS Delhi and worked as a consultant for the National Institute of HIV Surveillance, and currently is now positioned at MAMC. She has authored more than 10 papers and contributed to 3 funded research projects as PI and co-PI. She has received a number of awards for her paper presentations, STS scholarship, and Young Leader award also has been there for her. So, thank you.
Thank you, sir. May I start? Thank you, ma'am. Good evening, everyone. I'll be presenting my findings from the study we did on a feasibility of a multi-stakeholder engagement model at the village level for community-based management of malnutrition. So I would like to start with the introduction that we all know there is substantial burden of malnutrition, especially in the age group of under 5 years. And Asia and Africa have been the highest contributors to this global burden. And in India, childhood undernutrition is still a major public health challenge. And even if we are to see the latest NFHS 5 findings, we have not achieved a great decline from the past years. And there is also a disproportionate effect to the rural population that exists more than the urban people residing in urban area. From the review of literature, we found that the gaps that existed in management of malnutrition in India were poor caregiver knowledge. We found that 54% of mothers did not know the minimum number of meals that are to be provided to the children aged 2 to 5 years, and 45% of them were not aware of the supplementary nutrition services that were available with the ICDS. 11.3% did not have an adequate diet at the age of 6 to 23 months. We also found out that there was poor convergence. Only 30, for example, in India, we already have for health education or education about nutritional practices. VHNDs are celebrated. We have village health, sanitation, and nutrition committees that exist that are supposed to converge and work together for better nutritional outcomes. But we saw in the literature that only 35 to 50% showed joint ICDS health planning activities and sharing. Then there was also poor service coverage that only, even after so many years, only 57.1% of the under 5 children were weighed under the Anganwadi services, and only 28.5% had their weights plotted on the growth charts that are supposed to be followed up. And the referral linkages were also weaker. So what we did, we also saw that coming with the newer concept of the new primary healthcare framework that WHO had released, they put a lot of focus on patient empowerment as a core component of delivering healthcare. And we also found literature that caregiver counseling and empowerment actually can reduce the relapse rate in CMAM interventions by about 25%. So we aim to develop a feasible village level community management of acute malnutrition model and focusing on stakeholder engagement, caregiver empowerment, and implementation fidelity. So we did a descriptive feasibility study, and a village Java under the primary healthcare center of Chhaisa, that is managed by Center for Community Medicine, AIMS New Delhi, was selected conveniently. Then the study population that was included was caregiver and child pairs with children aged 6 to 59 months that were previously identified by the system as malnourished, either underweight, wasted, or stunted, were included for the intervention. For the study. Then the study was conducted between January to June 2024. We did the study in 3 phases. The first was the model development. So the model development, we had stakeholder mapping that we did initially. Then the model finalization happened with the stakeholder consensus and recurrent meetings that were held, and based on literature review of what all was available as interventions for malnutrition. Then implementation and assessment of feasibility. We oriented the stakeholders that we were able to identify. We conducted the camp, that was the community-based management camp, on a day. And then we assessed the feasibility of conducting that camp at a village level. Then we did a 3 months follow-up where data was retrieved from the system about their anthropometry. And then we did a comparison of what was the increase in
height and weight of the children. So we used PHC routine records for the same. Then feasibility assessment based on the Bowen et al. Model. We used these domains for feasibility assessment. The first was demand or acceptability, or the extent to which the model generated interest and participation. The indicators that we used were the child and caregiver pair attendance rate on the day of the camp amongst those that we had approached or called upon. Then the other was proportion of pairs attending the complete session, because the session lasted 4 hours. So how many of the pairs were interested and attended the complete session. Then implementation fidelity, the degree to which the program went as planned. So this was studied by proportion of planned activities successfully conducted and the proportion of stakeholders that performed assigned role as per plan using observation. Then practicality was commented upon by extent to which this can be implemented using the existing resources and systems. And integration, what is the potential of integration into the routine system? And exploratory outcome assessment, this was done by using anthropometry on 3 months follow-up. So the stakeholder mapping, firstly, we selected 3 areas that were working in malnutrition. That was the health, 4 areas, sorry. The health, WCD, women and child development through the ICDS, then the local governance, that is the Panchayati Raj Institute, and the community. These were identified as the broad stakeholders. Under the health, we had medical officers, ANMs and ASHAs. Then under ICDS Anganwadi workers, we also included Anganwadi supervisor that is supposed to handle 20 to 25 Anganwadis. Then local governance, we reached out to the Sarpanch, and we also took caregivers of the malnourished children as one of the stakeholders. Then the roles that we assigned to them were for medical officers, the planning and supervision of the campaign, stakeholder coordination between all of those who were involved, behavior change communication. We will talk about the exact model in the upcoming slide. So one of the component was behavior change communication. So what content will go into it, and the delivery of behavior change communication, medical officers was given to the medical officer, and clinical management of those identified as malnutrition. Then ANMs, we had asked them to do anthropometric assessment and documentation because we already had records of Anganwadis and the ASHAs that were routinely doing height and weight measurement. So at this camp, we put the ANM for supervision of anthropometry so that we could achieve better accuracy. Then we also involved them in hemoglobin testing and health education. Some part of the health education was given to the ANMs. Then ASHAs identified and listed the eligible under 5 children that can be called into the camp and mobilized the caregivers to attend the camp, and crowd management and supported the ANMs during the stations that were put up, and they also helped in follow-up. Then Anganwadi workers, they were responsible for display of nutrient-dense recipes using locally available ingredients at the time of the camp and live demonstration of the selected recipes. Then Anganwadi supervisors told about the ICDS scheme and what all provisions are there for the families that can be availed. Then under the Sarpanch, he was responsible for community leadership and resource mobilization. So he arranged for a venue to conduct this camp since we needed a bigger space than the Anganwadi or the sub-center had. So we conducted the camp at the community center under the Panchayat. Then also health advocacy. After the whole camp was completed, he also delivered a talk encouraging people to participate and follow up their children for growth monitoring. And he also reached out to the newspapers and spread awareness about the camp that is going to happen and to encourage them to come to the camp. Then for caregivers, we expected them to attend and participate in the assessments that were going on and later on implement the recommendations that we had provided to them. So we developed the SHINE model, that was the stakeholder and health system integration for nutritional empowerment. And this was a village level model for community-based management of acute malnutrition and focused on collaborative action and caregiver empowerment and system convergence. We developed this through literature review, stakeholder consultations like the one in the picture, and field implementation. So these were the pillars of our model. So we wanted to increase the knowledge of malnutrition status. Firstly, the people who are coming out as malnourished, many of them do not know the status of their children. So we wanted to increase the knowledge about the status, then knowledge of appropriate dietary practices that are there for the age group, then demonstration of some nutrient-rich local recipes that are available, then awareness of government schemes and entitlements, and management and referral linkages. So we had 5 stations that were there on the day of the camp. The first one was anthropometry, where height weight measurement happened. Then we also told them the malnutrition status based on the WHO growth charts. Then communication of malnutrition status was done to them, and the ANM and the ASHAs were available, the manpower at the station. Then the second station was hemoglobin testing, and the second station was hemoglobin testing, where we measured using digital hemoglobinometer. Then after they had an awareness about their malnutrition status, we expected them to be more receptive about our interventions that we were providing. So the next station was demonstration of recipes and awareness about the schemes. Then we had health education, where we focused sessions on IYCF, infant and young child feeding practices, growth monitoring, immunization, wash practices, and recognition of danger signs in the children. Then the last was, after everything was done, then they were referred to the medical officers for symptom-based examination and clinical management, and referral to higher centers for those who were required. The participants, 33 participants out of the 46 that we invited were attending the session. So 71.7% attended, 48.5% were girls, and 51.5% were boys. And amongst them, 36.4% were underweight, maximum were stunted. And this is actually, the figures are exchanged, but the stunting was 72.7% and the wasting was 6%. And 72.7% of them had anemia, and 21.2% actually were severely malnourished. So we already discussed 71.7% attended the camp on the day, and 100% of them actually completed the session, which we think that having the station of management at the last was one of the factors that they wanted to get free medications, and they were actually interested after knowing the status, since there was demonstration of the activities happening. Then 100% of the activities went as per plan, although there were some delays that were happening because the crowd was a lot, and we also had children running around. Then proportion of stakeholders that performed assigned role was all of the stakeholders performed their role as designed. As we can see the first picture that shows the demonstration of live recipes. Then second one was the Anganwadi workers had got low cost, locally available food recipes that can be given to the children. And there was a display for all of them. And the third one is the health education being delivered by our medical officer. Then commenting on the practicality, we actually found that there was no additional cost that came out to the system, because we used existing manpower and existing resources that were there. For the cooking, the Anganwadis brought their own setup. And even if we are to think that there is a special camp being held, 4 hours of time will be lost, but VHND days are celebrated. So we thought that this can be actually integrated into the VHND days, and the time will also be adjusted there. Then we can see the ANM that were already there. They were used for hemoglobin testing. The MOs did the clinical management part. And we also asked the Anganwadi services, they got their take-home rations on that day, and those were distributed to the families after the camp. So this also helped us give back something to them, and they thought that they were better receptive to using this product just after they knew that how to use it. So this had a strong potential to build on the existing resources, because we did not use any additional resource or cost, and this can be integrated with the village health and nutrition days that are already celebrated. And exploratory outcome assessment we did after 3 months. So median increase in weight was 0.7, and the median increase in height was 1 centimeter. And we also compared, since we could not compare pre-post, because anyway, without intervention, weight gain can happen. So what we did was we compared with the normal growth velocity given by WHO according to the age groups. So we compared them with the growth velocity in our age group, and we saw that 61.3% showed a higher growth velocity than what is normally expected as per WHO for weight, and 16.1% showed higher growth velocity for height. So again, I'll just conclude that this gives us an opportunity for data sharing between the ICDS system and the health system, which are actually working in silos. So no added cost to the health system, multi-sectoral collaboration, caregiver empowerment happens, and locally adaptable nutrition solutions are present. But it is also dependent on the stakeholder interest. And if somebody does not support, it can be difficult to conduct this. Thank you.
Dr. Farooq, would you like to ask something? Please.
We go back to the first slide.
First slide, sir. Okay.
See, acute malnutrition.
Yes, sir.
What does that mean? What is the definition of acute?
Yes, sir. So actually, acute, we take more towards wasting or weight for age, and stunting.
It is acute. If there is an acute, there is a chronic.
Yes, sir. Yes, sir.
Use the term acute.
Yes, sir. Yes, sir.
Based on that, you can compare.
Yes, sir.
The acute stage is this. I define, I diagnose the acute cases, and then I have given the intervention.
So actually, this.
We know acute pills which requires not preventive.
Yes, sir.
Curative one.
Yes, sir.
Therapeutic nutrition.
Yes, sir. Yes, sir. So we did include those, and we actually referred them for nutritional rehabilitation also. Yes. No, sir, we included both. Yes, ma'am, we included both. I missed that part, but we included both. Yes, sir. It was malnutrition.
How is this different from what the Anganwadis are supposed to do and the ANMs are they supposed to do? They are supposed to be doing all this which you have done in
Yes.
model.
Ma'am, actually, they are supposed to do all this, but on VHND is one of the opportunities where all of them can come together, but that does not happen as we saw. And the second thing is ki for ANMs, they are supposed to do medically screening of malnutrition and referral of malnutrition children. Then for Anganwadis, they are supposed to do screening of malnutrition and provide supplementary nutrition. But as of now, they are not demonstrating what are the recipes that can be provided and how to utilize. They give the take-home ration, but they do not tell them what recipes can be made of that take-home ration. So that was one of the things that we added. Secondly, we also included in the health education part for empowerment, we told them that how many meals should be given as per the age. Then we told them how to read the growth chart, how to red, yellow, green, how to identify if your child has been plotted in red, what does that mean? And yellow, what does that mean? So all these things were there. And also because all of them were coming together, we also saw that there were discrepancy in the data. So the numbers that we had in with our Asha's health system, they were different from what was there in the Anganwadis. So if you're not registered as malnourished in the Anganwadi, you will not get that extra ration, and you will not get take-home ration. So that's why this was an opportunity for data sharing also. And one was that, and then apart from the skill development that we did, then treatment was given there in that time. So we also provided with whoever was found to be malnourished. So we provided them with symptomatic treatment with IFS syrup, with multivitamin syrup, and referrals if required. And actually in our setup, we also have a pediatrics OPD on one of the days. So we referred them to the PHC, which is near to them.
Okay, how long was the follow-up?
Ma'am, currently in this, the study that I presented today, we have done for 3 months, the follow-up, but the follow-up is still ongoing, and we are also planning to scale it up to other villages and look at the outcomes that are coming for with a bigger sample size.
So you expect the ANMs and the Anganwadis who were not working earlier will all start working now?
It is just one day, because that's why I said that this has integration potential, because VHND day they have to celebrate. So this
Gives them to celebrate many things under the program, which they don't do.
Yes,
Otherwise,
ma'am.
we will not be making this paper.
Yes, ma'am. So that is why we try to group them together, and only one day we will utilize and then do it, because this will also not be done every month, because VHND topics will change every month. And we are also planning that if we give one induction intervention, maybe after 6 or 7 VHNDs have been celebrated, what we can do for refresher intervention. So all that we are developing upon.
Congratulations, Dr. Surumi, for the very short and very nice intervention that you have done. But I think it needs a lot of scaling up.
Yes, sir.
But my question is regarding how did you, because you have engaged the stakeholders, but did you think about engaging all the stakeholders at a one point? You are saying that they have not done, they are not doing this, or the VHND day is not going, but is there a mechanism to ascertain these reasons why they are not, why it is not being done? Maybe when you want to scale up, you need to think about
Yes, sir.
ascertaining that, and
What are the barriers that
yeah,
we will be
unless
facing?
you engage all the community,
Yes.
all the stakeholders in a co-implementation mode. It calls for an implementation actually.
So,
How do you take it from now?
Yes, sir. So at the village level, we try to involve all the people there. But if we need scaling up, we would like to involve the district administration, the CDPOs, all those people also. Then we will have our the health system side, the CMOs. We would like to have them as stakeholders also. So when we scale up, we will include them with our plan that is there. And even when thinking about the barriers that we will face currently, there is not a system officially that they have to communicate with. So that's why one of the limitations was that this is stakeholder driven. So we have to encourage the stakeholders and engage them so that they are interested to give their time for this intervention.
Need to start thinking in lines of, have a mixed method study.
Yes, sir. That is there in the scaling up that we are planning, that it will be there in that.
Nexus planning, finding out solutions,
Yes, sir.
and you're working with the system, so you need to have some co-implementation
Yes, sir.
strategies. Yeah.
Yes. Thank you, sir.
Thank you.
Thank
Pick it
you.
up and see that the system works.
I
Yes.
have just a comment to make. This is, in fact, this is in line. This is in continuation with the morning. There was a morning presentation which also critically looked into the various ways the supplementation programs in our country are running, particularly post Poshan Abhiyan 2.0, and we also have many literature which are supporting that there is a lot of there are glaring gaps in not just the knowledge of the Anganwadi workers, but
Yes.
also the fact that they are misclassifying
Hmm.
the children into not the red, because they are being, maybe they are
Penalized for it.
because the wrong this thing is going, or
Penalized for it.
you know
Yes, ma'am.
they are penalized, or maybe some kind of a negative feedback is going, which is harmful for them, and they're trying to hide the actual picture. So that is also a reason for underreporting. And oftentimes we know that there's a Hawthorne bias whenever everything is going on in a project mode and under supervision, just because you are supervising or there's somebody
Yes.
whom you have collaborated with. So maybe CDPO has to also
Yes.
cooperate.
Ma'am, I just wanted to say something that is very true, because we can't officially say it, but this was true because so only okay, so I just last line I would like to say that because the outcome is on health, so it is not maybe that's why ICDS is not that strict about it. So that is also one of the component that we felt on interaction with them.
Okay, thank you.
Thank you.
so much.
Thank you.
Thank you so much.
Madam, please come. Dr. Manirisha PV, please. 10 minutes for presentation.
Good evening, one and all. Myself, Dr. Manisha Pevi, postgraduate student of Department of Community Medicine, JSS Medical College, and I'm going to present a paper on unmasking hypertension, diagnostic insights from 24-hour ambulatory blood pressure monitoring in urban Mysore. So we all know hypertension is a major cause of cardiovascular morbidity and mortality. Globally, it affects 1.4 billion adults aged 30 to 79 years. 44% are unaware and only 23% have it in control. Though it is preventable and treatable, its detection and control remains suboptimal. Conventionally, we measure BP using digital or mercury sphygmomanometer, but that leads to often inaccurate results. It can be due to variability, it can be due to observation bias, or it can be due to device limitations, poor technique, or it can be due to improper cuff size. So, BP is one of such dynamic things that keeps on fluctuating depending upon how active we are, how stressed we are, what we eat, how well we sleep. So, therefore, ambulatory blood pressure monitoring offers more accurate assessment of this 24-hour circadian rhythm of BP to efficiently diagnose and predict the risk. So the objective of the study was to compare conventional office-based BP readings with ambulatory blood pressure measurements and to determine the prevalence of different phenotypes of hypertension based on ABPM parameters by assessing the circadian blood pressure pattern among adults aged 30 years and above. So this was a community-based cross-sectional study done in Banimanda PHC area, an urban area of Mysore, for a period of 1 year and 6 months among adults more than 30 years residing in this urban PHC area. The sample size was estimated to be 250 based on the prevalence of masked hypertension to be 19.3% as reported by Bendrakal et al. In a study. The sampling technique used was multi-state sampling. So this was a map of Banimanda PHC area. So this has got 5 subcenters of non-uniform population distribution. So in stage 1, we did a probability proportional to size sampling in order to get the number of participants to be recruited from each of the subcenter. Once that was done, with the help of ASHA workers, we line listed the number of participants eligible and through systematic random sampling, we approached them. We explained them regarding the procedure and once informed consent was obtained, we measured them with first conventional BP monitor and then we applied to them ABPM. The next day it was disconnected. We convinced them to carry out the routine day-to-day activities and also not to shut down it even while sleeping. So study tools were semi-structured questionnaire, Pittsburgh Sleep Quality Index, digital BP monitor, 24-hour ABPM. So the variables assessed were socio-demographic, lifestyle characteristics, and 24-hour ABPM parameters of the study participants. The threshold value of BP are as follows. Conventional BP was set up as 140/90, 24-hour ABPM threshold was set as 130/80, and daytime ABPM it was less than 135/85, and nighttime ABPM it was less than 120/70. So with all this, the criteria, based on the criteria, they were classified into normotension, persistent hypertension, white coat hypertension, masked hypertension, isolated systolic hypertension. So when they were having normal office BP as well as ABPM reading, they were turned to be normotension. And when the elevated office BP reading and elevated ABPM, there was persistent hypertension. Elevated office BP reading and normal ABPM reading, there was white coat hypertension. Masked hypertension was those who had normal office BP reading and elevated 24-hour ABPM reading. Isolated systolic hypertension was when they had both systolic BP reading above the threshold. So the data was analyzed using SPSS software. The chi-square analysis and multivariate logistic regression analysis was done. So moving on to the results. The mean age of the study participant was 49.94 plus or minus 12.49 years with slight male predominance of 52.4%. Hindus were majority and 23.2% had up to middle school education. 34% of them were housewives. Nuclear families constituted 63.6 and almost 52% of them were from either middle or lower middle socioeconomic class. 63.6% were married. Moving on to the lifestyle characteristics of the study subject, we can see that 21.6% of them were smokers, 15.6% were ex-smokers, 20% had the habit of consuming alcohol, 66 and 88.8% had the habit of coffee and tea consumption regularly. When it comes to dietary pattern, we can see that majority, that is 54.8% had mixed type of diet. And with respect to physical activity, we can see that 57.2 had no regular physical activity, whereas 30% had mild to moderate and 12.8% had vigorous physical activity. When it comes to sleep, we can see that majority of them had sleep of more than 6 hours. But when sleep quality was assessed, we can see that 51.2, that is majority, had a poor sleep quality based on Global Pittsburgh Sleep Quality Index. When screen time was considered, we can see that 9.6% of them had the habit of screen exposure before bed every night. And when the duration of screen exposure before bed was assessed, we can see that 20.8% had up to 30 to 60 minutes. Moving on to the key results, in our study, we had 45.2% normotension, or they were having BP under control. 38% were having persistent hypertension, 6% had white coat hypertension, 2.4% had isolated systolic hypertension, and 8.4% had masked hypertension. With respect to BP load, that is the percentage of readings above the normal threshold, we can see that almost 60% of them had both BP as well as diastolic blood pressure more than the normal threshold. And with respect to morning surge is nothing but the early morning rise in BP. That is an indicator of cerebrovascular morbidity. So we had 21.6% of the participants who had abnormal morning surge of more than 25 to 55 millimeters of mercury. So comparing mean blood pressure values of study participants across like office BP as well as 24-hour ABPM reading, we can see that there is a difference in both systolic as well as diastolic, but this difference is significant in systolic BP, which indicates that the office BP has a tendency to underestimate the systolic BP reading. Chi-square analysis showed the factors associated with phenotypes of hypertension. We can see socio-demographic factors like age, gender, religion, education, occupation, type of family, marital status were all found to be statistically associated with the phenotypes of hypertension. We can see that like elderly people above 45 years had the tendency of persistent hypertension, had more prevalence of persistent hypertension, whereas masked hypertension was more among younger people, that is within the age range of 30 to 45 years. And in gender, females had more persistent hypertension when compared to males who had more prevalence of masked hypertension. Like that, 3-generation families had more persistent hypertension and masked hypertension. Widowed and divorced participants showed higher persistent hypertension. Now, the lifestyle characteristics which came to be statistically associated were increased coffee consumption, not exercising regularly, poor sleep quality, nighttime screen use, family history of hypertension, presence of comorbidities, and higher BMI. These were all found to be statistically associated. Logistic regression analysis revealed the factors predicting masked hypertension among study participants. So religion, coffee consumption, physical activity regularity, sleep quality, waking up at night to check for, and family history of hypertension were the important factors which came to be relevant. So we can see that in religion, compared to Hindus, Muslims and Christians had higher rates of masked hypertension. And coffee consumption, those who don't consume coffee, when compared to those who consume coffee, had lower rates of masked hypertension. And this was found to be significant in both univariate as well as multivariate analysis. There was a trend towards lower rates in regular exercises, poor sleep, screen disturbance, and also family history of hypertension had higher unadjusted rates. So to conclude, there is a difference between the mean office BP as well as ABPM reading, and this difference was significant in systolic BP, our study identified a considerable burden of masked hypertension, 8%. Lifestyle factors such as coffee consumption, sleep quality, nighttime screen use showed meaningful associations. Non-coffee drinkers had significantly lower rates of masked hypertension. So the whole study emphasizes the utility of a 24-hour ambulatory blood pressure monitor for accurate hypertension detection and risk stratification in community settings. This recommends inclusion of circadian rhythm parameters in standard treatment protocols for hypertension management. These are my references. So this is how the ABPM report of a single individual look like. We can see that all the readings which come in red are above threshold and the green ones are those which came below threshold. And this gives a comprehensive report of when did the systolic BP rise, when did the diastolic BP rise, even including the circadian rhythm, BP variability. So this shows how many readings were there, and this it was set up like it takes half an hour reading during the daytime and 1 hour reading during the night time. So we got grants for this project from ICMR, and I would like to take this opportunity to extend my heartfelt gratitude to Medical Officer of UPHC Banimand and ASHA workers and also the study participants for making this project a grand success. Thank you.
Can you go back to the socioeconomic and lifestyle factors which you studied? So age, education, nuclear, middle, occupation?
Occupation was there, ma'am. But majority were housewives, ma'am. I had highlighted only the majority ones.
But 34% is not majority?
Yes, ma'am. Like among the other occupation, the 34% housewife were the majority.
And what about the males?
Remaining, like we had taken professionals, we had taken shopkeepers. We had
You have got so many findings now. When you're showing it is in more in males, then you should also tell us what is the occupation of the males.
Yes, ma'am.
Housewives is as a group is all right.
Yes, ma'am.
But what about the occupation of the males who had this masked hypertension?
Yes, ma'am. There were like very few percentage because like we went to them during the daytime and most of them like would have already gone for their work. So
because each of these actually except the education, I think even education, each of these needs a bit stratified.
Yes, ma'am.
Examination of who is getting hypertension and who is getting not. Can you go to further tables next? How did you assess this tea and coffee and alcohol consumption?
So,
criteria?
Yes, ma'am. Like we had asked them regarding tea and coffee. We asked them like, are you consuming it on a regular basis? If so, like how many glasses and for how many like years they have been consuming it. So like that we have asked, ma'am. And regarding alcohol consumption also, like how frequently they consume, are they a social drinker or they consume very frequently? And if so, like how much they are consuming?
And smoking?
Smoking also, ma'am. Like are they present smokers, ex-smokers?
So have you done that segregated analysis?
It was there, ma'am. Like due to the slide constraints and time constraints, I had not.
Don't you think that is very important?
Yes, ma'am.
Did you consider obesity also?
Yes, ma'am. Obesity also it was considered.
Is it there?
Yes, ma'am.
In the finding? You've got exercise.
Yes, ma'am.
What about the obesity?
Last, ma'am. BMI.
Acha, BMI you've got.
Yes, ma'am.
Grade 1 obesity showed highest?
Persistent hypertension, ma'am. Those who were having high readings in both 24-hour ABPM as well as office BP.
And what was the percentage of this grade 1 obesity?
Grade 1
population? What was the percentage of
obesity, ma'am? Like it was some around 17%, ma'am.
This grade 1 obesity?
Yes,
and the
ma'am.
rest were more?
No, ma'am.
They were normal.
They were normal people. The normal people were more, ma'am, actually. And they were like overweight people. They were having
So no relationship with overweight?
No, ma'am. No, ma'am.
Only
Like
grade
only
1?
grade 1 obesity we found to be associated, significant.
very interesting and unique study. I just wanted to know exactly how did you find out? Because I feel that you cannot just when you're taking a 24 hours thing, you are comparing with the office BP. So there is a lot of difference as in the person, or when he comes to a clinic, we take him after taking some rest, or sometimes we do repeat the time. So there is a likelihood of physiological also, and there is obviously a possibility of fluctuations throughout the day.
Yes, ma'am.
So what the instrument that you have used, is it like how is it calibrated, and how do we ensure that to correct readings, and how does it take into account the fluctuations throughout the day? And is it not wrong to jump to the conclusion that he's, hypertensive because of that, the fluctuations in the BP?
Yes, ma'am. That's why I've
Also occur.
Yeah, ma'am. That's why I've shown this at the end. Like we had almost like if they like follow it then we have almost like 40 readings. If daytime readings are taken like half an hour and nighttime readings 1 hour, so we'll have almost 40 readings. If 70 readings are there, then we can get the average 24-hour BP, average daytime BP, and also the nighttime BP as well. And we also get the circadian rhythm of BP, based on which we can classify them into dippers, non-dippers, reverse dippers, extreme dippers. Normally, physiologically, BP tends to be dipping at night. So that is physiological, but we found like almost 70% of them had non-dipping, even though they were not taking any medications, even though they were not diagnosed with hypertension before. There were almost like 70% who had non-dipping. In that, we had both non-dipping as well as reverse dipping, which means BP shoot up at night.
Where did you procure this instrument from, and the conflict of interest that has been taken into account, whether it has been, because you did not mention about where you.
There were no conflict, ma'am. There were not conflict
What
of.
was the company that
I used, ma'am, Contact ABPM company, ma'am, because that was the most affordable one. For that one single instrument, it costed around 22,000. In like our tertiary hospital level, in our own hospital, we have like BPL company, ABPM, but that cost around like 1.75 lakhs. So one instrument.
We also need to look into the repeatability of such a study and generalizability, and eventually the type of machine that we use, that is also something that whether it's user friendly or not, they can interpret and read the readings and not get panicked also.
Yes, ma'am.
That is very important.
So looking at the price, whom do you propose who should be using this BP to measure their BP?
Ma'am, like those who there are multiple uses, ma'am. Not only for that.
Not multiple uses. I said looking at the price of one instrument.
Okay, ma'am.
And it needs to be tied to the person, isn't it?
Yes, ma'am. Yes, ma'am.
Then how many instruments are you going to buy to tie to each? So who is that at-risk population whom you would like to, based on your findings?
Yes,
whom would you like to take up that these people should be tied this instrument so that their BP can be measured 24 hours?
Yes, ma'am.
Who
That's
are those?
Yes, ma'am. Like not only for diagnosis and detection, it can be also used for treatment as well. We can like customize the treatment.
I'm asking for diagnosis itself.
Yes, ma'am.
How will you choose the client or the participant for diagnosis?
Yes, ma'am.
Looking at the price of the instrument.
Yes, ma'am.
And the feasibility.
Yes, ma'am. We can like when the BP, like office BP reading comes like slightly on the borderline, we can just evaluate, like for further evaluation, we can consider those people, ma'am. One is that. And taking into consideration other risk factors also, we can suggest this instrument to other people who are having other risk factors also, who are having other comorbidities, who are having like addictions. So BP hypertension has a association with like most of the lifestyle parameters.
Did you compare with that the normal BP measurement that we do for detection of hypertension and the use of this machine? How much more did this machine detect compared to the conventional one?
Yes, ma'am, that's what. Like the results were different. There was a difference between office BP as well as 24-hour ABPM reading, but it was more for that significance was more for systolic BP, which itself suggests that systolic BP, normally when we measure by using office BP equipment, it tends to underestimate. The readings were low for when we check with office BP. So, like many would miss out from our diagnosis. Like most of them will be having white coat hypertension, but if we focus only on one time reading, then we'll miss out. There can be chances of false readings also, ma'am.
Okay, thank you. Sorry, please ask.
Yeah, Dr. Manisha, it's a very nice study that you have presented. And congratulations on completing and your funding from the ICMR for
Yes, sir.
MD thesis.
Yes.
So, I get reminded about the triple paradox of hypertension. Triple paradox of hypertension says that it is easy to detect yet remains not detected. Hypertension, and though it is easy to treat, people don't get treated.
Yes.
And even after treatment, BP is
Under
not-
control.
So this is what we call the triple
Triple
paradox of
paradox.
hypertension. So I hope you would have referred the cases to the.
He said those who are coming in the range of 160-90, above 160-90 and all, we refer to higher centers.
Excellent research work.
Thank you, sir.
Yes, sir.
This is not a, what you call research is basically just to give an idea how to do research. Okay. Yeah, SRF, JRF is not to make you a research scientist, but just to give an idea about
How
to
research is.
go about this.
Yes,
Okay, first thing. Second thing is you must know the rule of 50%, 50
Hearts.
they have hypertension. 50% do not know they have hypertension. Those who know, only 50% take treatment.
Yes.
Those who take treatment, 50% are
Out of
do not have controlled BP. Okay, out of 50%, only they have the controlled BP. Ma'am, we can have the concluding session now, if you kindly say. And we have sent you the
We are done.
so please write down the name of the best paper and first thing, and all those people who have presented for the junior award and the senior award, we will be sharing with them an appreciation certificate for the efforts which they have put in to come here and make the presentation.
Thank you, sir.
Right? Good work.
Thank you, sir.
Okay. Thank you very much.
First of all, my apologies, we are running late. We promised for 5 o'clock and it's already 5:22. But we won't take much more than 8 minutes for the validatory function. On the behalf of Epidemiology Foundation of India, I once again thank you all for your scientific and academic contribution towards this academic feast over the 3 days. Just in a nutshell, I would like to just summarize what has happened over the 3 days, and then there will be a brief award ceremony. We started with the Government of India National One Health Mission. Honorable PM is going to have a big meeting on 20th and 21st at Bharat. Along with that, we had a session from multiple national and international organizations like World Health Organization, GAIN, ICMR, and lot many others who have contributed towards the scientific event. We had a total of 28 oral presentation session. More than 200 oral papers have been presented. We are going to have awards, online distribution of certificates. After that, the most important and the most enlightening was the quiz competition. Every postgraduate have enjoyed yesterday. Along with that, today there was a big inauguration and we look forward for the pandemic preparedness center at AIMS, New Delhi, that has been inaugurated by Honorable India representative over here during the EFICON. Now, coming to the award ceremony, I request our senior ma'am and sir regarding the senior scientist and junior scientist.
It's my privilege to announce the EFI Senior Scientist Award 2025 to Dr. Sudeep Bhattacharya. From AIMS, Deoghar.
दोनों कर दे फिर I am glad to announce the EFI Young Scientist Award 2025 goes to Dr. Vijit Viswas for his paper on filariasis.
So we come to the end of 3 day session of EFICON, and I hope all of you enjoyed. And it was I personally feel there are about 750 registrations, and because of this unfortunate episode which happened in Delhi, there was about 10% dropout. Particularly from the postgraduates who are coming from nearby states, because parents get really scared and their kids to Delhi. That's number one. And I would like to thank all of you for your support in organization of EFICON. The next EFICON is likely to be in Chandigarh, and it will be sometime in September 2026. So we'll be sharing all the details with you. Please block the dates now, and we sincerely hope that you enjoyed EFICON 2025, and we look forward to welcoming you in EFICON 2026. With these few words, thank you very much. Happy journey back home and take care of yourself and your colleagues while you're traveling back. Thank you very much. Namaskar. We close the meeting now. Thank you.